statutory support to the person that is reporting. So
Okay.
once the person reports, he might not fall into any legal complications. That was recommended as an objective in another
Yeah,
Indian
because that is
study.
one of the key features. Maintaining the confidentiality and the anonymity of the thing is one of the key features. Because to get a patient safety culture going, that is the first step, that it should be a non-punitive thing. So, meaning the people who were involved, they had some doubt about that they may be penalized?
Yes, sir. Yes, sir. 65% of our staff had the.
All right.
And the second one is RTI, the information that we give out on RTI, sir. We are a government organization. We are bound to give out information that can be, that has to be documented.
Okay.
Whenever a public person asks, we are bound to give it. So that we have found, and we have included that question also into our questionnaire. And most people said that from these patient safety incident reports should be protected from RTIs. That this information should not be given out. That is what our participants had to answer.
That's tough, because even now gradually it'll come up that it all has to go to a central repository online, like in the US and all these things will have to be reported. So it's not that you can hide it if there's something. All right.
As far as the statutory and reporting is concerned, when these incidences are anonymous, that is out of question. It's just the data of incidences which is to be shared on an RTI, not with the person who is responsible or person who is reported. So that doesn't come into factor. But anyway, I mean, I would have appreciated if you have put forward certain measures to, one, increase the number of incidences being reported, and how to ensure that the points you have mentioned in your study, which are barriers to incidents reporting and taking corrective actions, are put forward. So that would be really good, because that would be a learning for others from your study.
Sir, we have an active patient safety cell at AIIMS, sir. Has been activated in the past 2 years. For that, the formal complaints that were received, and administration that is taking care of this. Since the activation of the factors that we found out through the factor analysis, those have been passed on to the patients, and they are acting upon it, sir. They are making a patient safety incident reporting system that is tailor-made for, like, personalized for AIIMS, keeping in mind all these things. And before that, sir, we don't have an anonymous reporting system. It goes by name, and it is completely detailed, and it is kept on record, sir. So that has been a problem for many employees at times too.
Yeah, because anonymity is one of the important factors to encourage this, and if it is anonymous, then it won't be related to appraisals. It cannot be related to appraisals.
But it was not.
Thank you.
Thank you, sir.
Thank you, Dr. Pawan. Moving on to the next presentation. It is from Ms. Momita Saha, and she's going to talk about prevention of patient falls in ward care settings and evidence-based approach, and she is from the organization Fortis Hospital, Anandapur, Kolkata. And to all the paper presenters, there will be a timer check. When there is 2 minutes left onto your 10 minutes whole session, you'll be given a cue card.
A very good morning to everyone. I am Ms. Momita Saha, working as a quality control nurse at Fortis Hospital, Anandapur, Kolkata. I am very much passionate about improving patient safety and quality of care, which brings me here today's presentation on prevention of patient fall in ward care setting and evidence-based approach. This also aligns with the international patient safety goal, that is 6, that is reducing harm to the patient due to fall. Agenda will cover background of the project, objective of the project, root cause analysis, methodology, result, conclusion, and sustainability. Patient fall in a healthcare organization are a significant safety concern which affecting up to 30% of hospitalized patient. From April 2024 to October 2024, we had 10 incidences of patient fall that categorized as adverse and sentinel event, which have led to increased financial burden, mental agony to the family members, and prolonged hospitalization. Objective of my project was to to reduce the incidence of patient fall, to assess the current knowledge of the nursing staff on fall prevention, to improve the nursing staff knowledge, and obviously to maintain the patient's safety. Keeping in mind of the objective of the project, we used Ishikawa model to analyze root causes of the patient fall, where man showed lack of practical knowledge, advanced beginner stuff, improper delegation of the duties, and method showed lack of supervision, wrong fall risk assessment, poor handoff, whereas patient showed previous history of fall, dementia, low non-cooperative patient and vulnerable patient, and material showed lack of safety net. Simultaneously, we have done a Pareto analysis which identified lack of practical knowledge and lack of supervision, contributing 80% of incidents, highlighting the areas of targeted intervention. After visualizing the root causes, nursing admin team adopted a PDCA tool to improve patient safety and to reduce the incidences of fall, where our plan was to identify specific strategies to reduce fall, brainstorming within the QI group, training, workshop, and safety and surveillance. For the execution of plan, we have taken 150 nursing staff for their knowledge assessment. One group pre-post test design adopted, and data were collected through CQI form, questionnaire or knowledge assessment, fall prevention audit checklist. Data were analyzed by the quality team, where knowledge was found 46% and pre-audit compliance was 88%. And we have conducted this project on Fortis Hospital, Anandpur. We have included all the admitted patients in the ward, and all ICU, ER, and OPD patients were excluded from the project, and duration was April 24 to December 24. Intervention which we have taken, that is reinforcement on patient safety board and orange color in ID band, strict protocol on staff teaching, OSCE assessment on fall prevention, and simulation lab created for practical demonstration, identified fall champion. And to say you that the maximum supervision has done by the on-duty night supervisor, who has given round on each and every bedside and checked the siderails are up and locked, and communicated to the nursing staff about the nurses call bell, orientation, and early morning dizziness, and emphasize on the bladder bowel habit to know about the urgency of washroom at early morning, and early morning recording of vitals to avoid orthostatic hypotension. And we have changed the patient bed, which is having full side rails, and housekeeping were trained also the safe handling of the patient, and fall prevention workshop conducted among the various staffs. So after lost many measures, the incidence of patient fall reduced from 1.32 to 0 per 1,000 patient days, and staff knowledge also increased up to 46% to 85%, and audit compliance also improved up to 88% to 96%. In conclusion, I can say patient fall in healthcare environment considered to be a never event, and the caregiver must have adequate knowledge and access to implement all kind of fall preventive measures to reduce the patient fall, and to protect the patient from fall and all the kind of injuries. And all the fall prevention measures in this project help to reduce the patient fall from 1.32 to 0 for 1,000 patient days, which is only possible by maintaining rigorous training, continuous audit, and patient-centered intervention, and which is already improved remarkable revolution in the fall incidence, ensured patient improve and satisfaction. And sustainability will achieve by the continuous training and handholding of these advanced beginner staff, safety rounds, and focusing on patient, nurse patient education and accuracy on assessment, and nurse patient communication on fall prevention. And lastly, my project insight is please call, don't fall. Thank you.
You have reduced the fall rate from 1.32 to 0%, but what's the period where you have calculated this rate? So 1.32 was?
That is actually May 24 to October 24. April we had 0, but still we have taken this.
No, the 1.32% fall rate you have calculated is before the study, after the study?
Before.
What was the duration?
Before.
What's the duration?
Duration was April 24 to October 24.
So for the sustainability of your intervention, the period where you've shown that zero, it's a very short period. I think it's about
It's
3 months.
November 24 to January 25.
Correct. It's just 3 months.
Yeah.
So you need to show the sustainability over a longer, because then there is a difference between you've taken 6 months for the other,
Yeah.
because it may average out.
This is
later.
our on.
Yeah.
Because, as you mentioned, it should be a never event in the hospital. So 3 months would be a very short duration to actually judge the sustainability, because these are very rare events happening in the hospital. So 3 months would be a very small period. Okay, thank you.
Moving on to the next paper presentation on the topic of emerging trends in quality management standards in the IVF department. And to talk about that, we have Dr. Shubhra Srivastava from Bloom IVF Fortis Mohali. Please welcome.
So good morning all. ART, Assisted Reproductive Technology, transformed reproductive health care, offering hope to couples struggling with infertility. Did you all know that success of an IVF treatment is not just about advanced technology, but also about stringent quality management? Globally, over 2.5 million IVF cycles performed annually, and quality standards play a key role in improving success rate. So, today we will explore the latest advancement in QMS in IVF, focusing on how they enhance patient safety, lab efficiency, and treatment outcomes. In the next few minutes, I will cover what is quality management standards and the key aspect of quality management in IVF, the emerging trends in accreditation and compliances, the impact of technology, patient-centric IVF lab, challenges in developing market, and the future direction of quality management in ART. So, ART has transformed infertility treatment since 1978, yet success rate vary globally. India has 15% infertility rate, and the IVF market is expanding at 14.7% CAGR by 2026. So, what is QMS? A systematic framework ensuring consistent quality, safety, and efficiency in IVF procedures. The key component of quality management standards are SOPs, regulatory compliances, continuous monitoring, risk management, patient safety, and ethical guidelines. The quality management standards is structured approach to ensure safe, effective, and ethical IVF treatment. It involves maintaining optimal lab conditions, using advanced reproductive techniques, providing personalized patient care. The key quality indicator in IVF lab is embryo viability rates, success rate of implantation, adherence to safety protocols. By implementing robust quality management system, clinics can enhance patient confidence, optimize treatment outcomes, and improve overall healthcare delivery. So, a couple walk in an IVF lab and feeling anxious about, but instead of that clinical procedures, they receive holistic care that address their emotional, physical, and informational need. The study shows that patient-centric care in IVF can significantly improve satisfaction and emotional well-being, leading to better overall experience. Trained embryologists, high-skilled reproductive doctors, and lab personals follow a strict quality control protocol to ensure precision. The high-quality air infiltration system, optimum temperature control environment, cutting-edge equipment of embryo culture, and use of time-lapse imaging, non-invasive embryo assessment, secure sample tracking system enhance lab efficiency. By integrating both scientific precision and compassionate care, a patient-centric IVF lab significantly improves success rate while ensuring a smooth and reassuring patient journey. So, the role of new age technologies in IVF, the technological advancements are revolutionizing IVF, enhancing precision, efficiency, and success rate. AI assists in embryo selection, increasing the likelihood of successful implantation. Time-lapse imaging allows continuous monitoring, embryo monitoring, and reducing the need for manual assessment. The automation in lab streamline sperm and egg handling, reducing human errors like microfluidics and all. Cryopreservation advancements ensures better egg embryo storage. Pre-implantation genetic testing identifies chromosomal abnormalities, minimize miscarriage risks. Additionally, wearable devices help track hormonal changes for optimized treatment timings. So, this is the embryoscope. We can see the images, and we cannot change by open the system, and we can see the images on embryoscope. And this is the microfluidics, which we read sperm better. And this is the RI witness system, which ensures that it is an automation in lab, streamline sperm and egg handling, reducing human errors. So, adherence to quality management standards ensures patient safety by ensuring procedural accuracy and minimize risk, ethical practices, standardized lab processes, and enhance success rate. The regular lab conditions and the embryo handling patient care. These are the slides are international and national quality standards ensure uniform service quality. The global standards ISO 9001 and ISO 15189 is for lab accreditations, RTCA accreditation, and for specifically India is ICMR guidelines. So, the challenges in the developing market. Barriers to standardize IVF quality treatment in developing nations, inconsistent regulation leading to various service standards, unqualified practitioners lowers the success rate, and ethical concerns due to commercialization and lack of patient transparency. These challenges requires government support, policy reforms, public awareness campaign. Bridging the gaps can make high-quality IVF treatment more accessible and effective for patients in developing countries. So, future in IVF is shaped by technical innovations and personalized care. AI-driven embryo selection is very much in. Improved cryopreservation techniques, genetic editing, so is possibilities. Automation in embryology lab will reduce human errors, increase efficiency. Personalized medicines include tailored hormone therapies. Genetic screening will lead to improved patient outcome. Ethical and legal frameworks to involve to regulate these advancements. Sustainability efforts such as eco-friendly IVF labs and energy-efficient equipments. So, this is a patient-centered care. And it's a keynote. Quality management is a backbone of successful IVF treatment. IVF clinics can improve treatment outcomes and patient satisfaction, ensuring patient safety, ethical compliances, high success rate by implementing patient-centric approach, caregiving, leveraging new age technologies, adhering to international quality standards. IVF clinic can improve treatment outcomes and patient satisfaction. The future of IVF lies in AI, automation, personalized treatment, sustainable practices, Ensuring continuous quality improvement will not only benefit patients but also strengthen the credibility and reliability of assisted reproductive technology worldwide. Thank you so much. Okay.
Thank you so much, Dr. Srivastav. With that, we end this paper presentation. And moderators would like to speak any words, or would you like to take some time? So I thank all the presenters who has come in forward and presenting their particular topics. May I request the moderators, Dr. Sushil and Dr. Pratish, to come forward to give away the certificates of participation to all of them. May I welcome Ms. Anjali Kumari onto the stage, please. May I request Dr. Pavan Gopatoti to be on the stage, please? May I request Ms. Momita Saha to be on the stage, please? May I please request K. Velupandi to be on the stage, please? May I please request Dr. Shubhra Srivastava to be on the stage, please? Thank you so much to all the presenters, and a sincere thank you to our session chairs and the moderators for their dedication and hard work. And we thank you for all the presenters to come in here. Thank you to the Dr. Sushil and Dr. Pratish to be on with us. Thank you. May I ask all the presenters to be back on the stage to take a group photo, please? The center of the stage, please. Thank you, doctors. Thank you.
most trusted and experienced hospital and healthcare accreditation provider. At ACHS International, we're proud to share the standards of one of the world's best healthcare systems. Our services extend beyond accreditation. We're your trusted quality improvement partner. Gain unique access to ongoing support from top industry experts to stay at the forefront of innovation and deliver sustainable, quality, patient-centred care with confidence. Our distinctive partnership approach includes bespoke quality improvement programs, connection and shared insights with a global network, unparalleled benchmarking of performance and outcomes globally, increased staff competencies through exceptional education and training, and international recognition for dedication to excellence. We are committed to identifying and implementing continuous quality improvement, tailored to your needs. Join our global network and showcase your commitment to excellence in healthcare. Partner with ACHS International.
The Apollo Enhanced Connected Care project has redefined patient care by leveraging AI-enabled remote monitoring to save lives at scale. The impact of this project has been remarkable.
The ECC project has led to an 80% reduction in code blue incidents and actually about 23% fewer ICU transfers, ensuring better patient outcomes. We looked at how can we reduce the nursing times, and DOSI came in as like a savior at that point of time. So with this particular project, we could bridge the gap between non-ICU and ICU level monitoring. We do have centralized command centers in Chennai and Hyderabad. Our medical teams can monitor patients across multiple hospitals.
Patients in high dependency area and patients who are in intensive care, they get monitored 24 hours, 24/7. Same thinking has not been applied to the patients in the ward who might be vulnerable. Hence, we thought that if they were to be monitored continuously, we would be able to pick up deterioration much earlier.
We started with a single hospital pilot and the results were clear. Early detection led to significantly better clinical outcomes and reduced the workload for nurses. Within months, the project expanded rapidly. Today, ECC is operational across 31 Apollo hospitals, covering 1,800 non-critical care beds, making it India's largest remote monitoring initiative. DOSI, as a key partner, played a pivotal role in helping implement this initiative at scale.
We also conducted a study and mapped to some extent some of the parameters. We actually presented the same study at ISQA conference last year. This project has resulted in about 80% lesser code blue incidents, obviously fewer ICU admissions, and improved patient survival rates. About 1949 life-saving alerts for the timeline that we looked at this project for, enabling timely interventions. About 70% reduction in nurse workload. It did help in 26% cost reduction in hospital ward operations, optimizing how do we utilize our resources effectively. Our vision is to expand this model across all of our units, driving into a new era of AI-enabled, proactive healthcare that saves lives at scale.
We found that we were not only picking up deterioration much early, but also our code blue calls, which is the emergency calls in some of the hospitals, came down to 0. But also we found that our readmission rate, so patients who left ICU went back to ward, many of them come back to ICU because things get deteriorate in the wards. That rate of readmission reduced significantly. So that gave us the confidence that this is the right way to go. We started this as a pilot. We have implemented it in our system, and we made our safe care even safer.
नहीं लेकिन ऐसे अगर
In the quiet corners of our minds, fears lurk. For some, it's the fear of closed spaces. But what if there is a solution? Introducing Fujifilm's Open MRI, breaking the chains of claustrophobia. The open design accommodates everyone, from the littlest to the strongest, because everyone deserves care without compromise. Inclusive healthcare that knows no bounds.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
Hear the warm melodies of family gathered around. Baby's very first word, making mama proud. All the things that seem to make us grow, and all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come. Winter makes the summer shine brighter. Spring and the fall make the colors lighter. Looking forward to whatever may come, knowing full well that all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come. Open up our eyes and see the sunrise. Yeah, the best is yet to come. Eyes and see the sunrise. It's been great, but the best is yet. It's been so great, but the best is yet to come.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
It's been ages since I've seen Ma smile like that. Thanks to these two incredible women, Parvati and Ipshitadi. They rise every morning, embarking on a mission that brings smiles to countless faces. They go door to door, spreading awareness. Setting up camps and educating about breast cancer. It was then we understood the root of mass pain. Didi advised us to visit a diagnostic center for a mammography. We met Polumidi, the compassionate soul who supports the mission with technology. The process was comfortable thanks to Fujifilm's mammography equipment. The mammogram revealed a lump. Dr. Shorkar assured us that there's no need to fear and advised us for treatment. Thanks to Fujifilm's outreach campaign, early detection led to early treatment. Inspired by Fujifilm's initiative, we also joined their mission to bring hope and smiles.
For 175 years, Pfizer has been discovering, developing, and delivering breakthroughs that change patients' lives. Our first breakthrough in 1849 was a groundbreaking way to treat parasites. Years later, we delivered life-saving supplies to the Union Army. We continued on to become the world's largest producer of the miracle drug penicillin during World War II.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine and invented a needle that would be a key tool in eradicating smallpox.
The disease has been wiped off the face of the earth.
From discovering innovative therapies to treat heart disease and breast cancer, to delivering the first mRNA vaccine against COVID-19, Pfizer has changed the course of history. The world has changed a lot over the last 175 years, but one thing that has not changed is our commitment to our patients, the center of everything we do. To date, we've reached billions of patients with our medicines and vaccines, and we're just getting started. Expanding the limits of science, harnessing unprecedented technologies and groundbreaking therapies. And through our heightened focus on oncology, Pfizer is driven to become a world leader in the fight against cancer. And together with our patients, advocates, partners, and colleagues, we are determined to outdo yesterday.
There's a world of innovation in every medication from Pfizer. For more than 170 years, Pfizer has demonstrated its high standards for clinical and manufacturing excellence in a wide range of therapeutic categories. We currently offer patients one of the industry's largest and most diverse portfolios of anti-infectives, more than 80 medicines, including therapies that help address areas of greatest unmet medical need, such as the treatment of gram-negative bacterial and invasive fungal infections. In 2022, Pfizer manufactured more than 150 million doses of antibacterial and antifungal medications. Driven by a passion for safety and quality, Pfizer adheres to rigorous manufacturing practices for all products, including IV anti-infectives. High-quality IV anti-infectives begin with high-quality raw materials. Our dedicated team ensures our suppliers meet Pfizer's highest standards. Every Pfizer product is thoroughly tested and analyzed to meet or exceed local requirements during manufacturing. During the manufacturing process of IV anti-infectives, key control points are continuously monitored, including air and water supplies.
Good morning and namaste again. Welcome back. I would request the delegates to please have a seat and clear the aisle. Moving forward, we have a spotlight session on perioperative hypothermia and patient safety. So ladies and gentlemen, coming up next is a very crucial and an interesting topic of discussion focusing on the critical aspect of patient safety, that is perioperative hypothermia and its impact on patient outcomes. We are privileged to have with us today Dr. Balabaskar S., Professor of Department of Anesthesiology, Bellary Medical College and Research Center, formerly the WIMS. May I request you to please join us on the stage, sir? He's a leading expert who will share his knowledge and findings. His expertise will help us reimagine perioperative care and improve patient safety worldwide. A highly esteemed anesthesiologist, educator, and a researcher with 30 years of experience in anesthesia and critical care. We hand over the forum to you, sir.
Good morning, everybody. Very happy to be here as the first speaker. Of course, there is not too much of a crowd, but I'm happy to address to a very focused gathering. And thanks to the organizing committee for having invited me. I am also part of a project related to hypothermia, which is taken up with sponsorship from TM. Can I have the PPT, please? So I have been an anesthesiologist and in anesthesia practice for nearly 40 years now. So as the stakeholders in the patient management, from the surgical side, the anesthesia side, and the nursing group, and all the other branches which are part of the surgical management in the perioperative period, we are also into patient safety. In fact, we have got multiple bodies across the world which are specifically dedicated to anesthesia patient safety. So in fact, the first dedicated professional safety association was the Anesthesia Patient Safety Foundation, launched in USA, long before other associations had launched the patient safety aspects. And in fact, we also have a dedicated Anesthesia Patient Safety Forum in India, which is launched just a year ago. Sorry for the delay in the PPT. Yeah. And we have formulated various standards of practice, because I was part of the Indian Society of Anesthesiologists guidelines formulation for various practice aspects. I was a past president. The reason I am trying to speak about my past affiliation is that I have been part of the system where we have stressed upon the importance of patient safety. So among the most important components, if you look at the title today, is perioperative hypothermia. So how bad it is for a patient in terms of his management and the surgical outcomes is what I'm going to discuss today. Be happy to know if there are my surgical colleagues here, anesthesia colleagues here, in the audience, outside of the surgery. Not many, I said. Sorry, sorry to have kept you waiting. Because hallucinatory, I just walked around and could pick up some, expend some calories also. So all of us are in the health field. when we say the body temperature, it's around 37 degrees Celsius, and it is very good for the normal homeostasis of an individual. Any change in the body's temperature would affect the physiology of the person. The heat is generated normally from metabolism, and we have got the explanation related to what is known as core temperature, which represents the metabolically active organs, and the peripheral temperature. Normally there is a difference between them of around 2 to 4 degrees Celsius, and we also have a thermoregulatory center which maintains a temperature within the normal regions amongst all of us. And there is an afferents in the form of the receptors from the skin and from the deep tissues and also from the spinal cord, and they are transmitted to the center in the hypothalamus, and the efferents would normally involve autonomic nervous system, the muscles, and sometimes we also have some behavioral modifications to see that we don't suffer from hypothermia. And this interthreshold range, when I say is just around 0 to 2 degrees Celsius, nothing happens to us. For example, all of us are sitting here in a cold room. We are very happy because the thermocompensation works. But if it becomes more than this 2 to 4 degrees normally, it will elicit certain important autonomic responses which are definitely not good for the patient overall. So one simplest thing we do is, like, for example, we are sitting in this room, we are all suitably clothed. We don't feel the cold environment here. But whenever we talk about a patient, there are other mechanisms if indeed it is going to be troublesome. So there will be some autonomic responses in the sense the blood vessels become, go into spastic condition, and we shiver whenever there is cold, and especially in pediatric age group, we have a mechanism called non-shivering thermogenesis, right? So we grade temperature depending upon the severity into mild, moderate, and severe. And I am not going to discuss about accidental hypothermia, which can happen. For example, if we go to Antarctica and other things. I am not going to speak about the low temperature when you go to Kashmir to enjoy during October, November. Right? So what are the adverse effects of hypothermia? We are speaking about this. So one of the important reasons I am speaking about this is, for example, perioperatively, there is a great risk of hypothermia. We have the patient who is coming for surgery and he is generally suffering from physiological alterations and pathology. And it's going to cause certain problems. And these problems could be at the enzymatic levels, at the nerve conduction levels, and they can also affect the cellular structure. So it doesn't end there. So if it is sufficiently prolonged and severe, it can affect the various organ systems from the brain to the heart to the kidneys, liver, and all the parts of the body are affected because of hypothermia. Very simple, I'll just go through some of them. The skeletal muscles will have problems with respect to the skeletal muscle function, its activity, mechanism involving calcium and acetylcholine transfer, it's affected. And when you talk about cardiovascular system, I said there is vasoconstriction, there is risk of hypertension, there is risk of ischemic heart disease, there is risk of arrhythmias, and if any patient has got temperatures below 28 degrees Celsius unattended, he is likely to go into ventricular fibrillation and death. And of course, nervous system is also likely to be affected. So somebody can go into a state of confusion, and progressively it can affect the brain to the extent the patient can also go into coma. And it can also precipitate hypoventilation and what we call as accumulation of carbon dioxide. Respiration is also affected overall. And of course, liver, the kidneys and are definitely affected because the clearance of metabolic end products. These patients are likely to suffer from metabolic acidosis. There is risk of accumulation of lactate and metabolic byproducts. And initially, there will be increase in the urine secretions, but subsequently, the urine secretion also falls. Electrolyte changes are life-threatening things which can happen. They could be due to combination of respiratory, renal, and endocrine issues in these patients. They can have hypokalemia, hyperkalemia, with associated metabolic acidosis. And in fact, any patient who suffers from either of these, hypo or hyperkalemia, can have significant arrhythmias, and it can precipitate the cardiac changes in the patient. Blood, of course, when we talk about blood gases, we speak about arterial oxygenation, we talk about PaO2, PCO2. So in general, there is an increase in solubility of the gases with hypothermia. So this results in a fall in the PaO2, means oxygen is not being delivered to the tissues, and it will also reduce the PaCO2. A normal PaCO2 is required for good brain blood flow or perfusion. So this gets affected in hypothermia patients. And simple blood components, for example, there is a contracted blood volume, the platelet function comes down. In fact, and it is possible that some of the patients may have increased viscosity and microcirculation is affected and blood flow to the tissues comes down. And in fact, various evidences have shown that the perioperative blood loss is especially increased in cardiac procedures whenever there is a deliberate or inadvertent hypothermia. Drugs, it is a basic science to all of us among medical fraternity that drug metabolism is definitely influenced by the prolonged surgeries, orthopedic procedures, total hip replacement, spine procedures, polytrauma and all. So it is found that there is a greater rate of wound infection and delayed wound healing, mainly because the subcutaneous oxygen tension comes down. So wound infection becomes more common and there is certain amount of immune suppression. So this will result in prolonged hospitalization and increased cost of hospitalization for the patient. So of course, I will not go into the depth of all these things. There is a temperature monitoring could be a, I got a warning for 5 minutes. So we can have surface temperature measured as well as the core temperature measured for the patients. Only during major procedures, we think about core temperature where we use tympanic membrane, pharyngeal temperature. And in fact, invasive temperature monitoring is also one of the possibilities. A patient, whenever a patient enters into an OR, so one thing is normally they are just covered with a linen or a blanket, and they are, by this very fact will probably result in loss of heat from the patient's body by 4 different mechanisms. We call them as radiation, convection, which account for 90% of the heat loss. And there is also loss by evaporation and conduction. And whenever we administer anesthesia, we give multiple drugs to the patient. Majority of them act on the brain, and we also use muscle relaxants which affect the skeletal muscles. So what will happen is the center in the hypothalamus is suppressed, the afferents are suppressed, and the efferents, including the muscles, are also suppressed. And in fact, whenever a surgery is started, the initial 1 hour, if you can see, is the time when there is a rapid fall in the temperature. It's mainly attributed to redistribution. Then there is a gradual fall in the phase 2. And finally, we have got what is known as a phase 3, where it is a real plateau. So any treatment we try to administer or preventive measures would normally be applicable to the phase 1 also. So as I said, when we give spinal anesthesia and epidural anesthesia, our surgical colleagues will know, anesthesia colleagues will know, when we give, it will block the sensory nerves, motor nerves, and autonomic nerves. So all these 3 sets of nerves are very important in temperature regulation. So when you block them, we will not have the afferent influences going to the brain, we will not have the efferent influences to cause some sort of response. That's the problem with neuraxial blockade. And in fact, we will have some technical issues in monitoring the patient when we use pulse oximetry, when we use ECG monitoring and other things. So what we should be doing is we should strategize to prevent the temperature loss. So we normally target the second phase of temperature loss in the intraoperative period, and we don't have much control over the first part. So there are multiple options which are available. I will not go into the details. It could be very simple pre-warming before induction. When the patient is come, just cover up the patient, try to increase OT temperature. These are small things which are normally carried out, but they don't work too efficiently. Okay? Even blankets, mattresses are used, but they are not that useful. Even if they are warmed, the effect lasts for only a short time. So we may not be used, even the preheated mattresses, warm water mattresses, which many of us are used to, they are also not useful in the OT environment. What could be useful is the conductive warming blankets and the forced air convective warmers. Forced air convective warmers are among the most effective systems, and they are widely accepted and used. They act by reducing the radiant loss and by increasing the heat gain by convection. So you can see the illustration where the patient is nicely covered, and it is specific to the surgical area. We can have different blankets which can be used, and they are basically consumables for the patient. And therefore, we have got other options which we do in the intraoperative period. We use humidifiers, we use HMV filters so that the body retains the heat and temperature, and there is no loss and hypothermia risk comes down. And you would have seen young children being put under radiant warmers. So this is one technique which can use in pediatric age group, but it is not worth using in adults. It's not going to be useful at all. And preparation solutions during surgery, irrigation solutions. If you are surgeons, you will know arthroscopies and endoscopies and QRP procedures. A lot of irrigant solutions are used. It is advisable that we warm them before they are used. Of course, IV fluids, blood, very well known. We must warm them because any reduction in the blood temperature would definitely precipitate further fall in body's temperature. So in fact, we have taken up a guidelines formulation on how to control and bring down the risk of hypothermia and therefore the adverse effects on the patients. We have a national project which is taken up by us in association with 3M. Thank you very much for the patient hearing, and sorry for the technical glitches. Thank you very much.
I would request the gathering to give him another biggest round of applause. And it is, of course, apologies from our side for the technical issues too.
Namaste and a very warm good morning to everybody present here. It's a pleasure to welcome you all to day 2 of 12th International Patient Safety Conference. My name is Anjali and along with me is Sulakshna, the host for you. I'm thrilled to be here with all of you as we embark on an exciting day filled with insightful discussions, knowledge sharing, and meaningful connections. After an insightful first day filled with the thought-provoking discussions, innovative ideas, and meaningful collaborations, we are excited to continue the journey, enhancing safety across the fraternity of healthcare. Your experience, perspectives, and voices are essential in shaping the future of patient-centered care. With this, let me introduce you to the first topic of today's discussion. Welcome to the pivotal role and the interesting panel discussion of IPSC conference, where we will be delving into the intricate balance between innovative, financial sustainability, and patient safety in healthcare, a topic that resonates deeply with all of us committed to advancing the quality and efficiency of care. We are honored to invite Dr. Madhu Sasidhar, President and CEO, Hospital Division, Apollo Hospitals Enterprise Limited, onto the stage, who will also be chairing the session for us. May I please request you to join the stage, sir? Dr. Sasidhar, a physician in internal medicine, pulmonary and critical care medicine, has served as president of Cleveland Clinic Tradition Hospital. He holds a patent through Cleveland Clinic Innovations for a technology he invented that was subsequently commercialized. Dr. Sasidhar is also a self-taught computer programmer with expertise in big data platforms. Once again, I welcome you, sir, here. With this, we would like to invite the esteemed panelists here on the stage. Over to you.
Thank you. And we start with the first panelist. It is Professor Patrick McNeil. May I request you to please join Dr. Madhu Sasidhar on the stage? Professor Patrick McNeil has graduated in medicine from the University of Tasmania, is a fellow of the Royal Australian College of Physicians with specialty training in rheumatology, completed a PhD in immunology at UNSW, and undertook a postdoctoral fellowship at Harvard Medical School. Welcome, sir. And the second panelist is Dr. M.I. Shahidullah, Chairman and Managing Director, KIMS Healthcare Management Limited. May I please request you to please join the stage, sir? Welcome, sir. His experience in the healthcare sector ranges over an impressive 40 years, spanning across several countries such as India, UK, Saudi Arabia, US, and other countries of the Middle Eastern. Welcome, sir. And for the third panelist along with us, we have is Dr. Murli Srinivasan, Chief of Medical Services, Manipal Hospitals. He has been very instrumental in delivering quality healthcare across all the healthcare fraternity, and we welcome you along with the other panelists, sir. And the fourth panelist, we do have Dr. Ashwini Agarwal, Director, PwC India. May I please request you to join the stage, sir? With approximately 19 years of experience, Dr. Agarwal has worked with clients across the healthcare spectrum, including prestigious institutions such as AIIMS, Cleveland Clinic, Johns Hopkins, Aramco Hospital, Bill and Melinda Gates Foundation, National Health Authority, and Niti Aayog. We would like to extend a warm welcome to all our panelists and will request the respected moderator to continue the conversation, sir. Over to you.
Thank you. I've really been looking forward to this panel, and since the audience is full of people who are committed to quality, I'm hoping that when we leave today, we will change the title from Margins versus Safety to Margins and Safety. Incredible panel, look forward to it. So, Dr. McNeil, I'll turn it over to you. If you could just give us a little bit of a background on your experience. You've been leading a large university healthcare system, and I think one of the things that is top of mind for us is how do academic institutions collaborate with hospitals with provision of care and drive patient safety and financial sustainability?
Yes, thanks, Dr. Madhu. Look, I've been working in teaching hospitals for a long time, more than 30 years, and what I have found that teaching hospitals in my country don't collaborate particularly well with universities. And I think that is a problem on both sides. I think universities are interested often in discovery research rather than translational research or health systems research or research that would really make a difference to patient journeys. And so the first thing I would say is that academic institutions need to think about the sort of research they're doing that is very relevant to healthcare. I think the second thing, though, is if you look at the challenge of safety and quality that we've heard about at this conference, we still have a system, an industry where patient harm occurs far too often. And if you look at the healthcare institutions that actually perform the best with the least harm, they are academic medical centres. If you look at the top 20 institutions, say in the United States, that are the most profitable and the safest, the vast majority, if not all, are academic medical centres. And so I would say that universities should start running hospitals, should start building hospitals, should start having them, their clinicians, their academic clinicians, integrated into healthcare. That's something that I have been involved in starting at my university. And that is the way I would say that we can move to the next level of safety and quality by really having that threefold connection between research, teaching and care, highly integrated. Otherwise, CEOs that run healthcares and CEOs that run universities are both wonderful people, but their KPIs don't overlap enough.
Patrick, so let me just maybe ask you a follow-up question, and it comes from my own personal experience as a critical care physician in an academic setting, right? And way too often we would find that there's a body of evidence, but that evidence does not necessarily always translate to the bedside, right? Sometimes very simple things. In critical care, we knew that, don't give patients excessive tidal volumes, don't give them too much salt and water in the first 48 hours. And yet, even within the academic centers, it does not translate to the bedside. How do we do that better? And do you see a role for technology, especially AI and decision support in driving this?
Yeah, look, I think we're in a better position than we've ever been in history in terms of having evidence readily available at the point of care. And so in many ways, there shouldn't be any excuse for we clinicians not to adopt the best evidence. Now, sometimes our patients come along with problems where the evidence is still not clear, and so that's where we use our clinical experience, our clinical judgment. But where evidence is well established, technology, point of care, health informatics offers a lot of future. Much is available right away. But it's I think having watched the evidence-based medicine journey over 25 years, I think it is a blending of clinician judgment and information rather than purely reacting to information, because the patient in front of you is not necessarily a number from a clinical trial, randomized clinical trial. So there's always that combination of using the evidence with judgment. I would say in academic medical centres, one of the strengths is that you develop very strong academic clinical departments, and you put in place peer review discussions, you put in place mortality, morbidity meetings, and you should be able to use clinical data of the clinicians in the department that should be openly shared, and you start to then look for variation amongst practitioners in the clinical department. Clinicians don't like to be outliers when their length of stays or their operating time or other metrics are displayed to their colleagues. And so that is what I have found, is that one of the best ways to change clinician behaviour is actually to use the clinical data from that department, shared openly in a good culture with the right set of values. Then you start to reduce that variation and improve patient outcomes.
Great perspective. Karthik, if I could please ask you, or maybe even to Dr. Sahadullah, both of you run hospital systems that have multiple hospitals in multiple locations. Professor McNeil talked about variation, and I'm sure you deal with variation at an institutional scale across hospitals. How do you manage variability in care across hospitals? How do you drive standardization?
Good morning. Good morning to everyone, and thank you, Dr. Mathu in the chair, and also fellow panelists. I think, when we have a chain of hospitals, and one will be the flagship hospital, and where you have all the focus from the very beginning. And your systems and everything will be well placed over there. But as you go, out of sight, probably out of mind, many of the things may not be able to be implemented with the same intensity to your strategic units or your branches. So this is a common factor we see in India, especially because a lot of chain of hospitals are coming up and a lot of merger and acquisition is happening. What my experience is that, the main thing is that the basic thing should be there and in all hospitals. And the basic patient safety measures, of course, is based on our NABH accreditation. So we have to get all our hospitals accredited, and all our 5 hospitals outside the main hospitals are accredited from a long time. And whatever other accreditation can be obtained, like lab and neonatology and emergency medicine. So that's a common thing, everybody does it, and that's one thing I want to say. And what is beyond accreditation is the question we always ask, And so what we have done is that a clinical auditing team is there, and this clinical auditing team, based on various KPIs, either clinical, operational, or financial KPIs, they do auditing in the main hospital and all the hospitals. And some of the members of the other hospitals also will be involved in the team, and they will interact and take corrective measures with the department heads over there. And so this continues, periodically in various KPIs, and also the KPIs is we have divided into clinical management or operational as well as financial. And even the manpower recruitment is being controlled so that, one of the methods we have a centralization and centralized credential and privileging. So that is, I find, the most important component which we have done effective in keeping the patient safety. So people who have been recruited either in the periphery or in the central will be scrutinized by a credential and privileging committee very strictly, and they will be authorized to do only procedures where they are adept with or fluent with. Otherwise, if they want to do other procedures, they have to be mentored and they have to be trained. And this follows in a very strict time, strict manner, and even to the extent that if they are posting a case, the anesthesiologist or the nursing supervisor will say, sir, you are not privileged for this, so we cannot post you for that. So that has helped quite, in controlling the patient safety. And then, of course, all the places, the training and development has to continue in the same scale, and that is very important. One more thing which we have done, found to be very effective, is the clinical coordinators or group, chiefs. I have tried to bring a lot of doctors into management because I'm an internist in profession and an intensivist, and then I came into management, and so many doctors. So in the main, flagship hospital, we have, very accomplished consultants. They are taken as group coordinators or group heads of departments, and they will go to the periphery also and try to instill the same kinds of standards, for example, pulmonology, bronchoscopy, and what safety measures are you taking there? Is it almost equivalent to? And gastroenterology, you have got certainly, a cleaning mechanism for the scopes, and is it, done properly before we reuse it again, we use it again. And so such questions have become very important. And so those are the methods. And then, of course, the centralization has helped, and we also have, a delegation matrix, which also has given control from the periphery. And finally, of course, automation is important. We have a single MR number, total adoption of, EMR, and 100% CPOE lab integration, radiology integration, and even SAP as the the financial system. So all of this have brought in an excellent control, and more or less, I will not claim to the extent of the central hospital, main hospital, but to a great extent, 60 to 70% of the, for example, antibiotic prophylaxis for, elective surgeries. It should be 100%. There is no question it should be. DVT prophylaxis for post-operatively in, all high-risk cases. It should be done 100%. There is no question there's a margin can be given. So this is the way we have controlled, the quality and the patient safety of the peripheral centers. But if I answered you, that's what we have done. That's just a model of.
No, you've answered it very well, Dr. Sahadul, and I want to reiterate a point that you made. And I think this is especially relevant for our Indian context, where health systems are becoming larger and much more integrated, horizontally integrated health systems. And you make the point about what do you centralize and what do you leave to the individual hospitals. And I think this is a careful choice that we have to make, and it has incredible implications. You have chosen to centralize credentialing and privileging, and through that mechanism, you do drive a lot of standardization. I think these are things that we should think about very carefully as we roll out.
Safety and margin.
Absolutely, absolutely. So let me take that, the point that you make, this considerable investment that you have made within your health system, driving standardization of DVT prophylaxis, or making sure that appropriate patients get perioperative antibiotic prophylaxis. These sort of quality measures need some investment and of both time and money. Let me ask Dr. Ashwini Agarwal this question. Dr. Ashwini, you've worked a lot with both US-based not-for-profit systems as well as in the government. How do you see this? Is should health systems see this as a trade-off between cost, margins, and safety?
So that's a great question, actually. Is there actually a trade-off between margin and safety? And I wish the answer were very simple as yes or no, but I think it's pretty complicated. In our expertise, and as part of my role in PwC, we work with variety of hospitals. These can be small-sized hospitals, these can be small clinics, and we also work with large established hospitals. So we find that there is actually a scope of maturity, a maturity curve where different hospitals lie. And the answer to the question that how much should you invest in technology, how much you should invest in the capital, how much you should invest in the operations, that depends a lot on where on the maturity curve you are. So like for example, for a small physician, for a small clinic, a just started nursing home, the answers are going to be very different. The person, the organization may not have the financial withdrawal, may not have the expertise, may not have the knowledge to invest that much amount of money and expect the returns out of it. But yeah, if you're talking about a large hospital, an established chain in multiple parts of the country, the answer is going to be very different. But having said that, I think in a simple language, we believe that there is no real dichotomy over here. It's like in economics, you say that with high growth, high inflation is inevitable. No, it's not the case. We have seen countries, we have seen examples where the countries managed to achieve high growth and managed to achieve the low inflation also. From a healthcare pilots, I think regardless of where on the maturity curve you are, some of the principles remain common. You have to have standardized operations. You have to invest in technology. You may invest in the technology which is simple, basic, readily available off the shelf. If you're a highly mature hospital, you may want to invest in high-end technologies, cutting-edge technologies over the work. You have to invest in the basic principles of management like lean staffing and all that. So if you do all of that, we believe that, and we genuinely believe that you can achieve a very well-balanced trade-off, not trade-off, actually a balance between the margins and safety without compromising one or the other. Thank you.
Would any of the panelists like to comment on the point that Dr. Agarwal made, the trade-off between margins and safety? Please.
Yeah, it's always a question, there's a time when in healthcare, all of us are trying to push the margin and, how we can cut down the cost and all. See, in this respect, sometime we cut down the safety margins also. For example, we recently had an exercise done in cutting down the consumable cost. And so naturally, we have to have by the doctors also in this process, because there are brand items which are highly priced, and we can certainly cut down and looking at the generic items of very good quality. So that's quite possible, but at the same time, the doctors also should trust the management how we can really do that. And these drugs which are buying from the generic or other companies are equally good. So that's one of the exercises we have done. And so at a time when we are trying to cut the cost, there are two questions we ask about how guest safety or patient safety can save cost. And I think, I had very painful examples, before COVID. We had, I saw Professor Bala talking about anesthetic accidents. And, we had an anesthetic accident. He was talking about a lot about physiology as well as the metabolism and the physics of anesthesiology. But this is very simple, the anesthesiologist left the theater for about an hour, entrusting with a postgraduate. And so an accident happened before COVID. And that reputation loss and, the media attack and the social media attack lasted for about 2 to 3 years. And even now the case is not completely settled against the doctor. So it is very painful. There's no question that we will have a lot of loss and financial loss. All the studies across the world, and if, all the Indian studies also show that the losses are there. So it is prevention is always better. And What we looked at is a CCTV, and the doctor did not say that he was out of the theater. And so the human error is more important than the machine error, and that's what I feel. And in fact, 1 hour he was outside and he was looking into some media, mobile and all. So the CCTV inside the theater could give us the complete clue on it. And so the important thing is the leadership. We should, the management, upper management should be fully involved in the patient safety. That's the only way so that the culture will develop from the very beginning if the management is with the doctors and the nurses in the safety. And for example, hospital-acquired conditions, there are many, and millions of dollars can be saved if they can be avoided. The other thing is, I mentioned about credential improvement. The second question we will always ask is, do patient safety measures reduce margins? I think, I feel that if you have the quality and patient safety, we definitely, initially there may be a cost, we agree, but however, now now is the time for everybody is making the budget for the next year. There should be definitely a budget for patient safety and risk management. And we all do that all across internationally, it is being done. And that's an important part. And quality care and profitability, we know that with the quality care and patient safety improvement, the profitability definitely increases and the outcome also increases. The trust factor we established with our guests, the patients, certainly goes a long way, and that's how we. And even a simple, sometimes many of the costs we have to absorb. We had recently, during dilatation, there was a rupture of the narrowed esophagus. And that was a major problem in the gastroenterology department. So we had to immediately operate and completely do the anastomosis and save the patient. So the right action at the right time, and whether we have taken enough precautions. So the medical legal cases and all that can be saved by doing the right action and taking the right preparation. So in this case, we have done it. We completely gave the free to the patient. And in fact, we got a lot of compliments from the patient, even though there was a medically induced complication for them. So these are the lessons about the patient safety. So definitely, margins can be saved by investing in patient safety, and that's my conclusion. Thank you.
No, thank you. And so maybe I'll ask Dr. Murali this question. In Manipal, we heard from Dr. Sahadullah of intentionally accounting for the expense, right? The cost of patient safety and quality in your budgets. These days, there are tons of vendors who are coming to you and promising to give you better quality with some widget or the other. How do you decide? How do you evaluate technologies, and how do you decide which technologies to invest in to improve patient safety and quality?
Thank you very much. Once again, I wanted to subscribe 2 points before I get into the question. Is that very rightly Dr. Madhu said, it is safety and margins. And I can say that if you add quality, safety, and margins, it becomes very easy, because quality talks about processes, quality talks about a lot of things where, the margins will also get addressed. Specifically to this question, what we do is probably like every other organization, we prioritize what are the 80% of the safety issues which happen in a hospital, and where a technology or something else other than a human interface can save the problem. Say, for example, I'm just taking an example of a remote monitoring system, especially in patients who are in a step-down unit or in a patients who are a little vulnerable, which, if you look at, as Dr. Sahadullah pointed out, the cost of non-quality, if you look at that, it really helps a lot of, save a lot of patients in terms of converting the so-called code blues into non-code blues. Before the code blues happen, you are able to take them. Now, how do we choose, these vendors, So I'm sure all of us will go through certain parameters, but I think more important in an Indian scenario is look at cost and scalability. If you are able to, get them at a reasonable cost so that the patient is not burdened, and if it is also scalable, and I think Indian innovations are also, a lot of them are available, and all of us will also understand, we have an intensivist in the panel, we'll understand that this is one of the tool, and this is not the definitive, thing to take a decision. This is going to give an alert system. So, to be in a nutshell, how do we do is we prioritize what are the problems, and we see what are the technologies available for that, and we see whether that is scalable from a place like, say, a Bangalore and a Siliguri, whether we will be able to train them, and whether culturally there will be adoption of this, and how much impact it has. So based on this, we decide on what and where, whom to go with.
No, that's great, Dr. Murali. So, Dr. McNeil, maybe I'll turn this question over you. We've heard a lot about sustainability. Dr. Murali talked about this innovation for the Indian context, frugal innovation, if you will. How can academic institutions drive research into clinical effectiveness, sustainability, and cost?
Yeah, that's a complex question. Just on technology. Technology, I think we should define exactly what technology we're talking about. In my institution, which is a very kind of operative institution, elective surgery, we find that a lot of operative technology actually adds cost. And so I would say that in an academic institution, it is important to decide whether a technological innovation is really benefiting the patient. Is it shortening operative time? Is it shortening post-operative recovery? The answer is often yes, say with a lot of robotic surgery. But it also then gets down to looking very, again, as I said, with good peer review, what is the robot use time between practitioners? Because there is a learning curve for a lot of robotic surgery, particularly some of the newer robotic surgery. So technology, I think, is something to look at technology by technology rather than assuming that technology is going to reduce costs. And then if it is going to reduce costs, you need to balance up what are the patient outcomes. And they would generally, if they're better, justify the cost. But again, you have to ask these questions from a research point of view every time. You need, in our institution, we have a clinical innovation committee that looks, because doctors love bringing technology into the operating room, but as a system, we need to look at what is the evidence for this technology. So that is what I'd say about technology. Now, what was your question again?
I was wondering about clinical effectiveness too, because I think that is, you mentioned robotic surgery, and we've struggled with this, right? What is the right application of robotic surgery? Where does it make sense? And then over time, of course, doctors get better. The time for surgery, it's a multivariate analysis, time, recovery, outcomes. So how do you think about clinical effectiveness and cost?
Look, I think as a system, our system is still designed around we clinicians. It's a provider-centric system. I believe our systems of healthcare need to be designed more around the needs of the receivers of healthcare. Now, that's a challenge for us. But if we want to have a sustainable health system and really address this persistent safety and quality 10% of errors or that are happening in even the best health systems, we really have to rethink how we design our health system. That's a big answer to that question, and not an easy one. But I do believe integrating clinical research with practice, as academic health institutions have done for 150 years in the US and in Asia and Europe, is a way to challenge the problem, safety and quality, that's persistent for us. I think an interesting point is that only 17% of hospitals in the US are academic medical centers, despite, probably a country that spends a lot of its resources on healthcare. So it is a challenge, but there are good examples of, I think in India, I think Apollo is a terrific example of a terrific health system that has embraced academia, training within its facilities, increasingly research, its own colleges of medicine, nursing, physiotherapy, etc. That is how you start to create a culture where the clinicians working in your institution, in your system, start to look at the most appropriate and best patient outcomes.
No, that's a great answer. You make the point about redesigning healthcare from a patient-centric standpoint rather than with a provider-centric view to it. So let me ask the panelists, the ones who work with hospital systems. We are focused on safety and quality in the hospital, but the risk to the patient far exceeds the hospital stay, right? They go home, they are still at risk. How are you looking at, especially technology, IoT devices and so on, to integrate that post-acute care with the hospital? Any interesting models, anything that you've done, Dr. Murli?
So I think one of the way to look at it is, today I think all of us talk about patient experience, and that's taken a very, very big stage. It's not feedback, it's not, patient, it's an experience and delight. So if we are able to build, and I'm sure all of us have built in care into that experience, if we are able to build that safety element into that, I think that answers the broader question. And to very specific, today we have, of course, some of them have proven efficacy, some of them are, maybe it is more for the comfort, but I think to answer that in one line, we do use a lot of IoT devices in some of these vulnerable patients, maybe after surgeries, maybe patients who are at a high risk of fall, patients who are at a high risk for events to happen. We have started using a lot of IoT devices with monitoring systems in the hospital. And while I think it's still in a nascent stage, I think definitely as only studies can show whether it has made a real positive impact in care in terms of safety and care, but definitely in terms of the patient's comfort, family comfort, doctor comfort, I think it has made a change.
Thank you. I think we are close to the end of our allotted time. Dr. Sadullah, do you have, we have a couple more minutes. Yes, please.
Yeah, I think you were asking about automation, right?
Yes.
Yeah, I think automation will come in a big way and in the coming, few months or years. And we all have to really adapt to it in a careful manner, because so much of automation is also coming in. But a few things, the medication errors, because of the QR coding, and it will be very useful. And another thing which we found is that RFID and coding of the mops and the various surgical things, which prevents actually sometimes the mop count and all becomes a confusion. And the coding you can either find out by X-rays or by ultrasound, and it's very easy to find. So I think these methods are definitely indicated. But again, finally, that human error is the important thing. And I think the training and development aspect, however much we can automate, that will be the most important thing. And I'll just conclude with a small example. My vice chairman was operated, and when I went and visited him post-operatively, he was very, very confused, and he was delirious. So he has, just now, Bharat was talking about hypothermia. So I was remembering the case. So I asked the nurse, what happened? You have the warming blanket, what you call herring brewer, and all that is there. And so I hold his hand and found that he's very cold. So I said, what is happening? Oh, the warmer is there and everything, and it's cold, and he's delirious. There should be definitely hypothermia. I asked him to take the core temperature, and it was below normal. And the simple answer was that the nurse did not connect the herring brewer to the plug. And that was the main thing, and I could see that it is. So that factor has to come in. And so the automation is important, but training and development, making it a habit and a culture, and automating the training and development, that's the way we have to go. Thank you.
No, thank you for sharing that story. So I think wonderful panel. You've heard a lot of viewpoints. Dr. McNeil's focus on that academic, bringing that academic viewpoint to healthcare, the rigorous peer review, the ability to translate evidence-based medicine consistently to the bedside. We've heard a lot of examples. I think Dr. Sahadullah, the choice that institutions have to make between centralized systems, a systematic approach to ensuring, for example, credentialing, privileging, making sure that the doctors are continuously trained. A great example with the use of IoTs, and Dr. Agarwal, appreciate your perspective on that it is not a trade-off, and that one has to be cognizant of the cost of non-quality, right? The cost of failure. So appreciate, it's been a fantastic panel. I hope you've enjoyed it, and I hope each one of you will take back to your organizations at the perspective that we must redesign healthcare systems from a patient-centric standpoint, and always place patient safety and quality at the center of everything that we do. So thank you all, appreciate it.
May I please request all the dignitaries to be there at the center of the stage for the photograph, please? I would like to express my sincere gratitude to all our esteemed panelists and the chair session for the very insightful and awareness of facets of patient safety which was shared with us today.
Thank you so much to all the speakers out here. Thank you so much for being a part with us. Moving on to a small spotlight session, we have a topic to be discussed on how to tell an improvement story utilizing plots. And this would be given to you by Mr. Amit Pasrija, Business Analysis of INSU. Welcome you onto the stage, sir, and the forum is waiting for you.
Morning, everyone. I think for this session, I should call you storytellers. You are lifesavers for us, but appropriate term for you today for this session is lifesavers and storytellers. So, how many of you, if I can ask, love to share stories or love to hear or listen to stories? I think be a little excited. It's an interesting session. I'll ensure that it will be an interesting session for you. So raise your hands, because I can't believe that there will be very few people. Most of us love to share or listen to stories. And how many of you do presentations in your day-to-day work, in hospital or in office or anywhere? Okay. So if you combine storytelling with your art of presenting, then it becomes magical, isn't it? Yep. So I have been given an opportunity today to tell you how you can share or present improvement stories by using plots. Fine. So let's dissect this topic a little. What is an improvement story for you, if I ask? Can anyone share what is an improvement story? Raise hands if anyone. You will need to speak loudly. Okay, sir. Yes. Yes. So if you are planning or you have already done an improvement in your process, even in your life or at home or in office, in hospital, then it becomes an improvement story for you. Okay? And what is plot here? Plot is not a property plot. If you are having a plot in Delhi, so then you are very rich. But I'm talking about plots which will make your story rich, authentic, and interesting. So plots are usually visuals. It can be a graph, a data, or any other visuals can be a plot. So any story, if you are sharing, if you use plots, then it becomes more engaging, more authentic. Fine? So what I'm going to do today is going to use an example which I have taken courage to share because I'm not a medical professional. So it's a completely fictitious example. I do not have real data with me and I don't want to see that also. But just to drive the point here, I thought to take an example which is on medication errors in hospitals. So to err as human, medication errors may happen, isn't it? So इसका वास्तविकता से कोई लेना देना नहीं है. जो numbers मैं present करूँगा, it's all fictitious. So do not relate to your hospital or anywhere. Fine? So what I have done, I have tried to create a secret sauce for you to understand how you can tell an improvement story by using plots. So first ingredient for you will be you need to understand the problem. When you are sharing with someone, you need to be very clear on what problem you are trying to solve or improve. Fine? So you will need to set the context when you are presenting to someone. Fine? Once you have set the context, now when you are progressing further in your presentation, you will need to share the goal which you want to achieve or you have already achieved. Make sense? Then third ingredient in the secret sauce will be that you will need to show how you are progressing in that improvement story or how you progressed when it's a past story. Fine? Fourth ingredient will be the outcome which you would like to achieve or you have achieved as one of the owners of that improvement story. Make sense? And last one is the insights. What kind of lessons you will learn after executing that project or action or whatever you are already you are sharing or you have already taken care. Fine? So let's go to the next slide. Before I jump into that, what I have done, you need not to use the way I am presenting here. Just visualize, suppose in your life, right now you need to present something somewhere. So you need to visualize what I'm trying to say. So what I did, I have used a technique of identifying a narrative, what kind of plot I need to use to support that narrative, and what point I need to drive out of that narrative and plot. Fine? So narrative here is with an example of medication errors. So in our hospital, we noticed a rise in medication errors over the past year. This was a critical patient safety issue leading to longer hospital stays and increased costs. Isn't it? That is a narrative you need to drive. And in order to support that narrative, if I just use some rough data or some rough notes, it may not become very interesting for you. Isn't it? So the plot which you are using is a line chart. You can see In the year 2023, medication errors is in upward trend. Number of errors are increasing every month. You can see that graph. Only in the month of May, errors got little reduced. But over the period of time, they are increasing. So obviously, it's a cause of concern for the hospital, for the professionals who are working in that hospital, isn't it? The point which we need to drive when you are telling this story or presenting somewhere is that this plot shows the problem clearly. Medication errors were increasing and we needed to act. Make sense? So it's time to act. You cannot sit silent when medication errors are happening because even they can impact human lives. Yeah? So now, what is the goal? What will define success? What will be the success criteria for this particular improvement story? So our goal was to reduce medication errors by 50% in next 6 months, aligning with national safety standards. Apologies, as I said, I may be ambiguous here. I do not know what are the patient safety standards, but yes, obviously there's an improvement needed. And hospital is ambitious that they want to improve it by 50% in next 6 months. Fine? So how they will present that in the plot? So graph is same as per previous slide. Graph is, there's no difference. But the plot here is, you created a line, horizontal line, showing that you will be reducing it by 50%. Does it make sense? Any questions here? I'm happy to take questions in between or at the closure. Okay, so the point which is to be driven here is that this target was ambitious but achievable with the right interventions. Make sense? So now, journey. What steps you are taking to improve or show the progress? So narrative here is that as a hospital or as a team of medical professionals, we implemented several changes. Introduced a barcode medication administration system, provided staff training on error reporting, we improved skills of our staff, and we started doing weekly safety audits. So safety audits help in identifying the challenges and correcting them on real time, on immediate basis, wherever possible. Fine? So now, we need to show the progress. So you can see, I have added one more line here. In 2023, the trend was upward. But by taking interventions, by taking some steps by hospital, in 2024, there was a dramatic change in the numbers of medication errors. So graph is showing downward. So plot here is this graph, which is a visualization. It will immediately hit your management. Let's see how the progress is happening. So my recommendation to everyone is to use as much as visuals as possible, though within your professional setup, within the ethics which you need to follow, but whichever way possible, use plots in your regular presentations. Okay? Now, outcome. You have shown the progress there. You have shown how month-on-month basis, there are reductions in medication errors. But final outcome, you need to articulate when you present. So narrative is, after 6 months, we achieved whichever percentage, 60% here, just fictitious number, in medication errors surpassing our goal. So our goal was 50%. And now you can see that we achieved 60%. So that is a narrative. When you are telling a story about your improvement story, you need to present. Okay? So plot here is a bar graph comprising the baseline error rate before and final error rate after. Make sense? So the plot here is error rate trend. So in 2023, error rate was 1.5% around. And in 2024, error rate got reduced to less than 0.5%. So it's an amazing trend, isn't it? And you were able to present it effectively by using this particular chart. So hope you are able to get, in this simple example, you are able to get importance of using plots in your presentations or storytelling. Make sense? Now, come to the insights, lessons learned. So, you need to present the insight. What all analysis which you have done, the insight here in this example will be, we learned that the barcode system was the most effective intervention, reducing errors by 60%. Staff training also played a key role in improving reporting and accountability. So your insight was that the barcode system which was used became quite effective. You will see a continuous improvement there also. And in future, I pray that in hospitals, medication errors become zero. I know it's not possible, but praying to God is important. So, sorry. So insight is this. And now, once you have shared the insight, you are clear on the insight, now you need to talk about big picture. So what can be a big picture in this improvement story is, this improvement story isn't just about numbers. It's about saving lives, improving patient outcomes, and building a culture of safety. So it is an impactful, isn't it? What you are talking here is, you are talking about saving lives. You are talking about building a natural culture within hospital that everybody thinks about patient safety when they treat, when they attend patients. So you are showing that picture also when you are concluding your presentation. Yep. So I think this was the last slide which I thought to present. It was a very short, simple share which we wanted to do. So any questions anyone has, anybody would like to ask on anything before I conclude? Yes, sir. Your voice, unable to hear.
Thank you. So this was a presentation that you did to demonstrate the improvements that we have achieved through a process improvement program. Generally, what we face is at the beginning of a project or an intervention, you need your leadership buy-in. And that's where most presentations come in, and you're talking to the people who are probably not clinicians as well. So what is your suggestion how we can modify the presentations that you did to put up a kind of a case to the leadership to get that buy-in at the beginning of the projects?
So what you are going to do, thanks for the question, and it's important. You are talking about future projections here. In the similar slides, for example, in this improvement story, suppose you want to improve medication errors. They are happening now, and you have been given an opportunity to lead that team and improve medication errors, basically reduce medication errors. So now these plots will become projections for you with realistic assumptions, with realistic clarity then how you are going to achieve that. But all investments will be required to achieve that. So it will become future, but you will have to add a couple of more slides to talk about investments, to talk about time needed, to talk about how the periodical path will be taken to achieve the numbers. Hope I am able to answer.
Thank you.
Okay, so thank you Apollo Hospitals Group to give this opportunity, and on behalf of Concordia, I thank you all. If you, I think presentation is closed, so I wanted to show you the last slide, but no problem. So thank you, have a good day.
I have a comment if I can make till the time we are going on to the next session, what Sir was presenting was data visualization. Actually, my other friend was just asking a question, how do we get the buying from the top management? So this method which he said is only plotting a graph bar chart, but actually there are more statistical ways of analyzing this kind of data, and NABH also wants us to be using the statistical tools to analyze our data in order that we make sense of that data and we can use that data for improvement. So the other chart which would be more effective would be the control charts. The idea in control charts is an upper and lower limit of a particular kind of error which you are plotting. It gives us an opportunity to identify causes as special cause or common cause. And that is the point where we will be able to focus on special causes and then make improvement. So this is one of the ways which I and my day-to-day practice as a quality and safety officer has implemented this control charts, and we were able to demonstrate the special causes and then get the buying. With figures, we must talk to our top management, and it's then only that it makes a difference. So yeah, that was just a comment from my side.
Great Chair, ma'am. Thank you for adding the value. As I said, it was quite a simple example to address people of all levels. But yeah, there are various ways to improve and show. So thank you for the addition. Thank you.
Thank you, Mr. Pasrija. Looking at the setup of the stage, you must have realized what our next session is going to be all about. So, ladies and gentlemen, let me welcome you all to a big debate session. The Great Patient Safety Showdown. Are safety reporting systems helping or hindering progress in patient safety? Is the topic. One topic, but two different perspectives. In our pursuit of excellence in healthcare, patient safety reporting systems have been established as a cornerstone for identifying, analyzing, and mitigating risk. However, the effectiveness of these systems is a subject of ongoing discussion. While they aim to enhance patient safety, questions arise regarding their actual impact. Please join me in extending a warm welcome to Dr. Anupam Sibal, the Group Director of Medical Services of Apollo Hospitals, here on the stage. I welcome you on the stage, sir. Dr. Sibal's extensive expertise in healthcare management and his unwavering commitment to patient safety make him the perfect voice to address our conference today. I welcome once again to the stage. May I have the honor to introduce our next session chair, Dr. Hari Prasad. May I please request you to be here on the stage, sir? Group Chairman and Non-Executive Director, Quality Care, India Limited, Care Hospitals, KIMS Health and Eye Care. Former President at Apollo Hospitals, author of Impossible Cricketer. I once again welcome both of our session chairs here on the stage.
And today, we are privileged to have 4 distinguished speakers who will represent their perspectives on the critical issues. Let's welcome them onto the stage with a big hand of applause. On the speaker 1, we have Dr. Lallu Joseph, the Quality Manager and Associate General Superintendent of CMC Vellore, Secretary General, CAO. May I please request you to please join the stage, ma'am? A passionate teacher and trainer, she's involved in training quality implementation across the country through NABH, CAO, AHPI, and is also faculty to many hospitals' administration programs. She's a principal assessor of NABH and Secretary General of the Consortium of Accredited Healthcare Organization, CAO, India. And we welcome you again, ma'am. And on speaker 2, we have Dr. Suresh Ramasuban, Senior Consultant, Respiratory Medicine at Apollo Multispeciality Hospital, Kolkata. May I please request you to join this dais, please, sir? With over 23 years of expertise in critical care, his focus lies in areas such as acute respiratory distress syndrome, mechanical ventilations, and sepsis. Dr. Ramasuvan's contribution to the field have been recognized through prestigious awards, including the ICMR and ACCP Research Award. He also served as a member of the Executive Committee of the Indian Society of Critical Care Medicine and as a DNB Specialty Board member in Critical Care Medicine. Welcome you again to the stage, sir.
Dr. Suresh and Dr. Lalu.
They're here.
Dr. Suresh and Dr. Lalu are in favor of the topic, and the topic is, our safety reporting system helping or hindering progress in patient safety?
We have another set of speakers now to be welcomed here on the stage who will contend that these systems may hinder progress. May I have the honor to please invite Dr. Sanjeev Singh, Medical Director, Amrita Hospital. Dr. Sanjeev Singh. He worked as a regional coordinator at WHO India in a disease eradication program from 2000 to 2003 and joined as a faculty and chief medical superintendent at Amrita Institute of Medical Sciences and Research Center at Kochi. He has written a book, Hospital Infection Control Guidelines, Principles and Practices, and has several international and national publications. Once again, I welcome you here on the stage, sir. We have another speaker, Air Marshal Dr. Pavan Kapoor. May I please request you to join the stage, sir? As he walks in, may I have the privilege to introduce him, a leader with an illustrious career spanning over 38 years in the Indian Armed Forces Medical Services. He is currently the Vice Chairman at Russ Education and Vice Chancellor at Lincoln American University Armed Forces Medical Services Officer, to having been awarded as prestigious Colonel Pyare Lal Gold Medal. I welcome you once again here on the stage, sir. Over to Dr. Hari and Dr. Sibyl to take forward the session. Thanks so much.
Good morning, everyone. Namaste. We need to up the energy in this hall because we're going to have lots of fun. Promise you one thing, this is going to be a lot of fun. Could I have the slides, please? So we are going to be debating a very interesting topic today. Slides, please. Right. So systems are designed to give consistent outcomes. Isn't it wonderful, you know? Working to perfection, look at the plants. But then, what's stopping an individual for developing his own system? Systems can be very complex, like the ventilation system in an aircraft to keep the temperature really precise. But then systems can be very simple. This system also provides air at a controlled temperature in 2 rooms. Pillars are an essential part of a system to support a complex structure, but then an individual can also use a pillar to support a complex personal structure. If you put good people in bad systems, you get bad results, according to Stephen Covey. Systems rely on adherence by people, but then the human mind can redefine adherence. Measuring performance by the number of injuries you have is like measuring parenting by the number of smacks you give. Systems need compliance. Did I say compliance? So to debate this topic today, safety reporting systems are helping patient safety is the motion. And we have very, very eminent debaters who are going to enlighten us on their viewpoint. Sometimes in a debate, there is a big difference in terms of opponents, in terms of strength, right? Sometimes it's plain stature. And sometimes it's sheer size. But in today's debate, it is a debate of equals. On one side, we have Suresh, an eminent pulmonologist. We have Lalu, an eminent administrator who spent most of her life looking at quality systems. We have Sanjeev, an able administrator, a clinician who manages hospitals. We have Dr. Pavan Kapoor, who's spent a lot of his time, in addition to serving the nation through Indian Air Force, working on quality and has been instrumental in developing the NABH standards and, of course, CAHO. And then, of course, my dearest friend, Dr. Hari Prasad. Hari and I started our careers together at Apollo more than 2.5 decades ago. Hari, as you know, is not only an eminent physician. In fact, he's has been responsible for setting up the specialty of emergency medicine in India, but also a multifaceted personality, played cricket Ranji Trophy for Andhra Pradesh, and of course is a well-recognized author, wrote a beautiful book called I'm Possible. So today we have equals. Hari has decided to go against the motion, and I will be going for the motion. So we will start with Hari giving his opening remarks, then we'll have Suresh, then we will have Sanjeev, then we'll have Lalu, then we'll have A. Marshal Kapoor. Each of the debaters will have 5 minutes, and then we will have a rebuttal for 3 minutes from both sides. And just to remind you, your 5 minutes are up or 3 minutes are up, you're going to hear this sound. And we will then open it up to audience questions, and then there will be an audience vote. And you notice here that there are no iPads. This is going to be not by a show of hands, but by a voice vote. And can we please up the audio as we play this? So the voice vote is going to be like this. So, you know, it's very good to have to make some noise if you want your side to win. And I wanted to ask, is everyone ready in this room for the debate? Yes? And let's see who's going to perform like this today. Like the All Blacks. So let the debate begin. Over to Dr. Hari Prasad.
Good morning. Let's get some energy into the room. Good morning.
Morning.
First, let's begin by a show of hands. How many of you are believe that reporting systems actually improve patient safety? Almost everybody, right? I must tell you this. Yesterday I got a message from Mandapam, would you want to be for the topic or against the topic? And as I usually say, it's up to you. And because I knew what he was going to say. And immediately I got an answer, I'll do for, you do it against. Because he thought that the for would be the obvious winner, like we just saw. But I want to start off with a story. There was a cafe owned by somebody like Anupam. I'm just saying somebody like Anupam, but this is a true story. He introduced a fantastic reporting system where he had a feedback mechanism where, the waiters, everybody used to pick up and put it into the system, all the incidents and all the remarks and everything. And then you would have a team sitting at the back end, and they would analyze the whole thing, do root cause analysis, and a month later come back with a problem statement, why that error happened or why that problem happened. And by that time, that customer who had the problem would have gone to 4 other restaurants elsewhere and never come back to this restaurant. Opposite that, there was a small pizza shop which is always full, and people used to be standing outside. And this man, this cafe owner was wondering why that is always full and why is my cafe not full. So one day he decided to actually take an appointment and go into that cafe. There were no computers. There were no reporting system, feedback forms, nothing. The owner of the pizza shop actually received every customer. Most of them, he knew them by name. He addressed them by name and ensured that he took care of them personally. And the entire staff who were working for ages at the same place knew most of the customers, and there was no reporting system. If there was a problem, it used to be sorted out then and there. So now you tell me, now are you against or for? How many are against the reporting system? Now, if you are not yet convinced, please be aware of the fact, please look at this panel. At the end of it, whatever tamasha which Anupam showed on the screen in terms of voting with that, how the vote is going to be counted at the end of the thing, please remember that if you don't vote against, you will be bombed. You have an air marshal sitting here on our side, and you would be bombed. And the same warning to the two gentlemen and the lady sitting there. If you want to go back in proper shape, I leave it to you.
Excellent. Thank you so much, Hari, for that opening remarks and trying to make an emotional pitch. You see, when you know you're going to lose, you always try to get emotional. So nice pitch about the pizza shop. But let's get down with data and let's get down with some hard facts. So over to you, Suresh, for the motion.
All right. Good morning, everybody. Am I audible? I think so. Alrighty. So I think straightforward, the debate motion is safety reporting system help progress in patient safety. And my answer is a resounding yes. Obviously, they do. I'm the opening batsman, so I'm going to lay the ground a little bit more than what Anupam did about what safety system does. I actually did open the batting for AFMC, so it's not an untrue picture. So we all know, I just want to portray to you and bring to your attention that we do cause harm. Patients do suffer harm in every day in healthcare facilities and do die unnecessarily. And this can be as simple as a near miss, can be a no harm incident, can be a harmful incident, but we really have these incidents, and if we run away from acknowledging this fact, then we are really not really, we are like an ostrich with our head put in the sand. That's exactly what. And do not forget the other people who are in the healthcare industry. It's the healthcare workers. We also suffer a lot of injury. Violence is very common. I think all of us undergo violence as a doctor, as a physician, as a nurse. You must have experienced some sort of violence at some point in time. And of course, needle stick injuries and so on and so forth. But more important, also harassment. It is not very uncommon for people to be harassed in the workplace, and all these things are not easy, and say that this complaint can go to a pizza delivery manager and you report I'm being harassed and it'll work out so well. It doesn't work out so well. You need a system in place, and that's exactly the message. So nothing in the world is more dangerous than what we just heard from the opponents, that sincere ignorance and conscientious stupidity. So please do not believe in this, that we cannot report this, we should just be ignoring all these facts. It's absolutely this. I'm a clinician. I'm going to give you an incident which we tackled about 8-9 years ago, and we're very proud of it. It's one of our safety improvement thing. This is a guy who presented with non-occlusive mesenteric ischemia, presented with abdominal pain at midnight. The resident DNB student thought there was nothing much in the colon. 8 hours later, the senior consultant in radiology feels that there's a focal bowel wall thickening, and we undergo a surgery about 12 hours after the patient's admission, and what we do is a total hemicolectomy instead of a sigmoid, just a right hemicolectomy. So this is something which now our opponents will say, कोई बात नहीं, हो जाता है, ये सब तो बड़े-बड़े देशों में छोटी-छोटी बातें तो होती रहती हैं, है ना, sir? So ये सब तो होता रहता है. These things will happen and these things should be ignored and this should not be reported because obviously the best result which they will say is that the manager gets the DNB resident, fire him. And that's probably the best solution that they will offer. And that's not what we really want to know. Safety system is central to this. And I'm going to give you evidence over the next 5-6 slides that how they have improved. No hera-fairy business here. I'm going to give you facts. I'm going to give you evidence to say how they have improved healthcare outcomes and not just whether it is going to do it or whether it's not going to do it. Obviously, we have data from the aviation industry where it shows improvement. And the more important thing is it's common sense. Why should we learn from our mistakes? Learning from our mistakes is the wisest thing that we can do. If we don't learn from our mistakes, at least learn from somebody else's mistake, because that's much more quicker and easier. But we have to learn from each other's mistakes or the possible mistakes that we are doing. And if this common sense doesn't strike us, and if we don't have incident reporting or a safety reporting, or a system in place where you are processing the data as everybody is saying, then it is going to be futile. And the reason why, I'm going to give you 6 points and saying how the safety reporting system are going to help you and how evidence is saying that they're going to help you. So first is that it's going to detect your risks and hazard early. And there's a very nice study by Baker et al. From 2007, which clearly points out that safety systems allow you to detect incidents much quicker and prevent harm. Number 2, it will be the fact that it's going to promote a culture of safety where you're not going to blame any one particular person and you're going to be fearless and will be able to report what you want to do. Number 3, you're going to have a lot of data to collect for evidence-based improvement that you can do. Again, studies which have really shown that this can do. But most important thing is that it does make a clinical difference. This is from a study by Carroll published in the Journal of Patient Safety, which categorically says that several healthcare, not only Apollo hospitals, but several healthcare systems have shown improvement in outcomes when you have a safety system. When you have these kind of evidence, it is impossible to say. Similarly, training in continuous education and like the JCI recommendation and the NABH recommendation, which we have been written by our esteemed opponents, that it is going to give your organization accountability and organizational learning. So in this kind of a situation, what we did in our clinical case is that we have created a turnaround time of 1 hour for critical reporting for acute radiology turnaround times with a consultant read. And these are small things, and this is the Swiss cheese model that we can do to improve the outcome. So very simply, in 5 minutes, I've given you 6 solid evidence. No going to pizzas and cafes, just telling clearly that safety system reporting systems are crucial tools in advancing patient safety with evidence and with no doubts in our mind for our own safety as a healthcare provider and for the safety of our patients. We need to do it. So I request a little bit of maturity on the part of my opponents to accept this fact that apologize when you're at fault, admit your mistakes and learn from your mistakes so that we can carry on reporting these important safety events. Thank you very much.
Thank you. And clearly, from the other side, Sanjeev is going to need some extra energy, so some water. Sanjeev, as you come onto the stage.
We don't need water or anything else. First thing is, Ram tried his best, but I must, before my colleague starts off, because that's going to end their argument. He talked about the aviation industry and reporting. How many years ago was the Malaysian aircraft gone missing? 5 years, 6 years, how many years? It's still not, it is reported that it was missing, right? It is still missing. And despite all the analytics that went into that missing report, there have been airline accidents even after that, and people have died in airline accidents even after that. So I think reporting is not a way of preventing errors. It doesn't prevent deaths. It creates an environment of post-mortem. So Ram very nicely argued for post-mortem, and now you see how my panelists will argue for actually preventing deaths rather than going in analytics and searching for the missing plane.
Right, thank you so much, sir. Dr. Suresh spoke about aviation safety. There, you die if the plane crashes. Here, if you leave a foreign body, the doctor doesn't die. And that is how possibly Dr. Suresh would have been working in this hospital. But need to improve, sir, if the safety reporting system has to improve. So, how many of you have fallen in love? Raise of hand. Have you ever felt that there is a tingling sensation in your gut when you have fallen in love? And that is what he spoke about, common sense. It is common sense leaving your body. And that is the tingling sensation which Dr. Suresh and Lalu has. The common sense when it has left, what are you going to do? You keep talking about safe reporting system, but there is something which is much bigger. But that will only happen if you are working on ground, not from an air conditioning offices. So they have presented their point where it is so complex. Like pizza, which you eat is round, it comes in a square box and it eaten as a triangle. And that is the mechanism which they are presenting, which he enumerated as 6. Now let me give this thing what is most important. Safety reporting system is not critical. It is the culture which you create. And I'll give you my personal example. My wife, very beautiful wife, professor of anesthesia and palliative medicine, had an post-ERCP pancreatitis, was also having spondylolisthesis and S1, S2 fracture and disc prolapse, was slated for internal fixation, went into the theater. The anesthetist got a subclavian done. As he got the subclavian, he perforated a pulmonary artery. And then her BP dropped 60/40. They just couldn't understand what is the reason. And then she had tachycardia, she had a cardiac tamponade, shifted into the cath lab, and the pericardiocentesis was done. You have a safety reporting system. The sonography machine was there, right there, was not used. You have a surgical safety checklist which was used, but pulmonary artery was perforated. What happened? She was moved from a theater, a sterile zone, into a cath lab, another sterile zone. In day 3, MDRO, Acinetobacter grew. You have a safety reporting system, but what is happening? Not working. So risk assessment is high, sonography line insertion was not followed. But what was very interesting is antibiotic stewardship program exists, but they have given a drug called Alores, which is a banned drug, ceftriaxone with sulbactam. You just cannot give this drug because it is not acceptable, not approved by FDA, but that is what has been given. And ultimately you land up with an hospitalization, which is not your problem. You had a safety reporting system, you had a sonography machine, you had a surgical safety checklist, but then a bill of 6.8 lakhs. And this is what happens because you are only dependent on. So my point is that its culture of prevention has to be there. Another point, Dr. Suresh, I didn't realize that he is a pulmonologist. In Delhi, air quality index is 450. The patient comes with shortness of breath. What happens, basically? A CBC is taken, and when you ask, CBC क्यों लिया? कि सर जो आता है उसका CBC तो होता ही है hospital में. And then you say that LFT, KFT क्यों किया? I don't know whether. सर जब खून ले ही लिया है, तो ये भी भेज देते हैं. उसके बाद an X-ray was done. Why X-ray? Because he came with shortness of breath, sir. And then why ABG? Because we didn't know whether it is alkalosis or acidotic. तो उसको why HRCT? Because sir, he has come to a quaternary center. कुछ तो different करना है गली वाले institute से. Sir, that is how it is practiced. A very good safety reporting system. Then what do? You give us salbutamol. क्योंकि हमने 20 साल पहले पढ़ा है कि ये work करता है salmeterol. Then you also give a long acting. छोटा तो दे दिया, लेकिन एस्थमा हो सकता है long standing हो. रामबाण देना बहुत जरूरी है क्योंकि हमें मालूम नहीं हम क्या ट्रीट कर रहे हैं क्योंकि डॉक्टर सुरेश ट्रीट कर रहे हैं उसके बाद डेरिफाइलिन 18% oral absorption of this drug but we are giving it every day then we are giving a mast cell क्यों इसका नाम बहुत अच्छा लगता है क्या है मोंटेल्यूकास्ट लगता है पेरिस से आया है then हमें मालूम ही नहीं हम क्या ट्रीट कर रहे हैं तो हम क्या करते हैं एलेग्रा ये एलर्जी तो होगी डॉक्टर सुरेश दिस इज हाउ इट इज आपने कंप्लेन इतनी ज्यादा कर दी कि पेशेंट को अब च्यूएबल टैबलेट देते हैं कि चुप रहे विटामिन सी उसके बाद हमें मालूम नहीं हम कर क्या रहे हैं तो हम इम्यूनिटी बिल्टअप करते हैं तो बी को सूल देते हैं What is required is only this pulmonary function test, period. Safe reporting system की क्या बात कर रहे हैं? And only give inhalational corticosteroid with long acting. And that is how it has to be treated. The other prescription is close to 8,000. This prescription is 340 rupees. And that is what is important. It comes from a GINA guidelines. So what I'm trying to say is culture, prevention, evidence-based practice, and not concentrating on reporting system. So what did we do? Am I just coming and speaking just like that? We created a behavioral culture in our institute using a tool called sociogram, where we shadowed the doctors when they were rounding. Every doctor thinks he is the best communicator in the world, and we don't disagree, but he doesn't communicate, unfortunately. So we charted in the color code, we charted how does he communicate. We went back to him. This is how you communicated. He was so surprised, and he was so surprised and angry. The surprise went into anger that he stopped the whole program. So how do you create a safety reporting system? And here, once the antibiotic gets started, it doesn't get ended. Your infection prevention is not there, and still it is hierarchical in nature. The senior speaks, and we published it. I'm not just speaking. Now, here, you talk about safety reporting system. In theater, this is my hospital, where you have 45 times operation theater door gets opened up. Why? Because एक बार blood लेना है, दूसरी बार ABG भेजना है, तीसरी बार suture लेके आना है, and it is directly proportional to surgical site infection because you are turbulating, creating a turbulence of indoor air quality, and that is how it is so bad. What I am trying to stress is, don't get into this paper-based thing of safe reporting system. Create a culture, prevention, and change behavior. Now, how do you, he is passing stool, he is sleeping properly, he is stable, but he is in the hospital. Because safe reporting system exists. How do you understand this in a safe reporting system? God knows what this doctor has written, but then safe reporting system is there. I'll end with one. I was doing an assessment of a hospital. I was doing a fire safety round. When I went to the round, there is a sensor, which was there, the smoke detector. I said, can we test it? He said, "Arey, sir, Midas ka hai, France se liya hai." I said, we still would like to test it. He got a agarbatti, he stood there. I looked at him, he looked at me, nothing happened. Then I said, what next? He said, sir, fire alarm hai hamare paas. I said, come on, we'll see that. Break the glass. He said, glass tod do? I said, glass tod do. Glass tod diya. He looked at me, I looked at him, nothing happened. I said, what next? Sir, pata hai hamara code red hai. I said, announce. Samne bola dialysis ki ladki ko, code red announce karo. I looked at him, he looked at me. Because unfortunately, he didn't say the location. 5 security people came with fire extinguisher. Thak thak karke aaye. Sir, bataiye. They looked at me, I looked at them, nothing happened. And this is the save. This hospital had a fire policy. This hospital had a code blue. This hospital were doing mock runs. And this is how it generally works. I'll skip this. Monitoring is important. I'll skip this. I'll come to, because my time has ended, I'll come to this. Safe reporting system, it's a bogus thing. Don't waste your time. Create a culture of prevention. Create a culture of behavioral change. Create a culture of humility. Doctors needs to be humble to say, I did something wrong and I wanted to quote this experience of Sri Devi. But please vote for us. Thank you.
Thank you. Excellent, Sanjeev. Hari, you want to say something?
Yeah.
Yeah. See, they need more water.
हम दुश्मन को मारने से पहले पानी भी नहीं पिलाते. पानी पिलाना is like the reporting system. Because by the time you give water to the dushman would have shot you. And that's what I learned from my colleague sitting here. Is that right? So Anupam, sorry, we don't give you water.
Thank you. Very nice, Sanjeev. We are nominating you for the next episode of the Kapil Sharma show for making us laugh. And there hasn't been a doctor on that show. So the debate, after you lose the debate, we will definitely, with the support of the House here, send a nomination. Very nice arguments, but of course devoid of science and evidence, because you did have to rely on quoting the GINA guidelines yourself. And you talked about showing data and fancy colored charts to convince people. So deep down, this is the comedy show. So over to Lalu for the motion.
So Sanjeev sir, you made my life very easy. It's all about safety reporting system and whatever you said, if there was a proper reporting system, the next person will not get harmed. So that's the whole idea. So I have a story to tell here. So let me go directly to the point. I know. All right, so let me go directly to the point. I am going to tell you a story, a kutty story. I come from a state called Tamil Nadu, so it's a very kutty story that I'm going to talk about here. Listen to me very, very carefully. This lady entered into the portals of healthcare in 2007. And when she entered into the portals, she did not know the difference between ECG and EEG. The first board she saw was EEG, and she thought it was a spelling mistake. Later on, she realized, okay, there is something called as EEG available. Then she went on to set up quality systems in her hospital, moved on, and in the year 2012, this is a real flashback, she meets somebody, attends a session on patient safety. By then, she's kind of used to the NABH standards, aware of the systems, and in 2012, she attends a talk on how incident reporting helps in creating the culture of safety. By a well-known, renowned founder and many, many organizations, patron of our own organization, CAHO, patient safety champion, lifetime achievement awardee, a great person, always smiling. Any guesswork? Come on. The person is here. Who is this person? Air Marshal Pawan Kapoor. Do you want to listen to what he said? He is a true champion of patient safety. He breathes patient safety. He talks about patient safety. He's created all possible checklists for incident reporting in the country. Look at the irony. Pawan sir, I feel very, very sorry for you. You have the flag of India here standing as the champion for incident reporting. And ladies and gentlemen, you have to listen to him. Why don't we listen to him now?
Encourage transparency and non-punitive incident reporting by staff. Rather, you should award them for reporting
Look at
incidents.
him.
Non-punitive incident reporting by staff. Rather, you should award them for reporting incidents.
He's
Rather, you
talking
should
about
award them for
awarding
reporting
staff.
incidents.
Let's give him a great round of applause. This can only happen here. Now let me come on to 2014. By now you would have guessed that person, the one who entered in 2007 was me. And my dear friend, the most handsome, look at this person, you need to understand this. She goes as a faculty for the assessor training program at Haryana. Professor of pediatrics, hospital administrator, publisher of a book, Hospital Infection Control Guidelines, amazing hats, the most important person in the healthcare ecosystem when it comes to quality, patient safety and implementation. He took a topic on incident reporting and corrective and preventive action. I actually understood correction, corrective action and preventive action from this gentleman. Any guesswork? Sanjeev Singh. The same person, Dr. Sanjeev Singh. Let's give him a great round of applause. And look at the two of them today. Against the motion. Ladies and gentlemen, by now you know the two safety champions who talk about safety incident reporting system are here. We are done. But I am not finishing here. I want to give hard data to all of you. There are several published literature that says that when you have a good safety incident reporting system, the culture gets established. Sir, this is to you. Without a proper incident reporting system, you cannot have culture. There are lots and lots of Indian studies available to state that. Incident reporting at a macro level and at a micro level. This lady brought in the consciousness of patient safety in this country. Her mother, who was operated in Sloan Kettering in Manhattan on the wrong side of the brain, I think all of us started talking about patient safety in 1996 when this incident happened at a macro level. So what did we do? We started checking our own hospitals about what systems we have. This is the latest fire safety incident that happened in Dindigul. 6 relatives were stuck inside a lift. What did we do? Immediately we went back and checked all our lifts, whether our automatic rescue device was functioning or not. That is the beauty of a safety incident reporting system. I can go on and on and on. 2 men stuck in an MRI machine. What did all of us do in our hospitals? Started checking on the safety systems in our MRI machines. At a micro level, every single day we have some incidents happening. If that is not reported, nothing can be done on a larger scale in the hospitals to improve the system. So, sir, I asked AI, how do I even talk to these 2 gentlemen who actually established safety incident system? And AI told me, Lalu, all you can do is, on behalf of the 2 of them, ask the audience to take a pledge. I pledge to uphold patient safety by promptly reporting incidents, near miss and risk. I commit to learning from errors, fostering open communication and supporting a blame-free environment where safety comes first. Together we strive for continuous improvement and the highest standards of care for every patient. I am talking on behalf of the 2 of you. Let's give them a big round of applause, please.
As you notice, almost the entire 3 or 4 minutes was about our panelists and praising them. So thank you very much first for that. ये बोलते हैं ना, जब खुद में माल नहीं है, सामने वाले ऊपर रोने से माल हो जाएगा. So I'm really proud to be sitting on this side of the table, because even the opponents who tried their best had to praise them at the end of the day. And that is an indication for all of you on whom to vote for at the end of this. And now the actual top is coming to demolish. They'll disappear after this.
But before Air Marshal Kapoor comes in, and of course, Dr. Hari's been alluding to the amazing work of the Indian Air Force. The Indian Air Force always protects everyone. They don't bomb anyone. And that is the ethos. And therefore, Dr. Pawan Kapoor will also obviously talk about protection. But Hari, we are so grateful to you for recognizing the love this team has for you. And it is in that spirit of love and affection that we invite Pawanji for his closing remarks.
Okay. Good morning, everyone. There's one more bullet point to this. We do not doubt their intellect, but we are worried about your sheer innocence. They are still in the reporting systems, which we formulated in 2006. The same standards have changed the reporting systems into management systems, not reporting. Okay. So I think we must all applaud their innocence. And of course to Lalu madam, kya khoob lagti ho. Rest she knows. Okay, we all must have a story. Because session before this was a story. So I must tell you the story and a journey of a safety reporting system, how it actually happens, and why we moved away from reporting systems to management systems. This story will tell you, it happened in the NCR region a few years ago. And what does this story say? A young nurse on duty saw an anxious patient, rang up the doctor. The patient is very anxious, roaming around the ward and disturbing everyone. So what should I do? The doctor said, give 10 milligram of diazepam orally. She went and gave 10 milligram of IV diazepam. Patient got sedated and fell down. Incident occurred. Safety incident occurred. It was reported. Because the reporting system was in place by NABS standards. Report. After the reporting was over, analysis was done. Were you not aware of the verbal order policy? Yes, I was aware. Were you not trained? I was trained. Do you know the fall prevention protocol? Yes, I know. Okay, so your word. Then the final trump card. Report and deport. So this poor nurse got deported. She exited from the organization. What lesson it taught everybody? They are my colleagues. Don't talk. You will go into shock. Now let us ask certain questions. Do safety reporting systems serve as a measure of safety? How many of you say they serve as a measure of safety? Please raise your hands. How many say they serve as a measure of safety? So nobody says. Nobody. Correct. Because they're random data. It depends upon the whims and fancies, on the vigilance, on the honesty and integrity of the reporting persons. 7% of adverse events are reported in the world. Not my report, WHO report. They don't report, under-reporting. Why? Because fear of retribution, fear of litigation. Tomorrow I tell you, hey Dr. Ajay, you are wrong. You made an error. I'll give it to the press. My God, you are finished. Your career is finished. Will you report? No. So this is what has happened. There is no serve as measure of safety. Let's go to the next one. Next question. Do they serve as tools for comparisons? They should have something. Do they serve as tools of comparison? So you have got some errors. Can you compare? Let's take an example. What do you make out of this example? The oncology unit has had 112 medication errors. So you are called Chai with Dr. Anupam. 112 errors. Hey, gear up, please. Wake up. Wake up call for you. So what you do? What does the oncology department do? Next time they come down to 15. Because they had chai pe charcha. In actuality, oncology department had a good reporting culture. They were doing double check all the time, recording all the near misses and reporting them. So they had a good safety culture. They had a good reporting culture. But see, this comparison brought in time. So do they serve the tools of comparison? No. Let's go to the next question. Do they result in in-depth analysis, strong interventions? No. You don't have the resources. We're going to waste time. Patient has fallen, no injury, no action to be taken. Superficial. Because resources are not there, require time, energy. You can't do in-depth analysis. Recurrences keep on happening. Again, what you do? You keep quiet. And then there are some studies. Oh, my good friends here showed studies. I will show you studies now. Okay, here it is. Institute like John Hopkins, 1,000-bedded, 500 incident reports every month. They do not have resources to read. much less analyze all these reports. In addition, they found out report is complaining quietly about the behavior of the colleagues. And it is not surprising that many users feel dissatisfied. कि तो हमारे against ही report जा रही है. They provide, this is their study, not my study. They provide little incremental value about the insight of safety. Sir, no incremental value. And this is what we found in NABH. Most of the reports on falls, nurse found patient on the ground after the patient tried to get out of the bed. So the physician was notified. After evaluation, no permanent harm was identified, case closed. So such reports question the benefit of having the user system at all, this reporting system at all. Then do they reflect? This is the master slide. Master slide. You must all look at this. Sir, you must look at these slides. Sir, this is JCI, sir. Data collected from 1995 till 2013 on wrong patient, wrong site, wrong procedure events. Mind it? Sir, I will have to dance for 1 more minute, sir. Okay. Sentinel event reported in 1998, 26. So they start a process of reporting. In again 2002, 2001, they had follow-up review. They had increased. Oh, reporting has increased. Very good. Reporting has increased. Safety has not increased. Then they gave an intervention. National Patient Safety Goals, January 2003. Wrong site surgery summit. Incidents went up. Oh, reporting has increased. What about safety? But wrong site surgery continued to happen. It did not come down. You are reporting, so reports are increased. What happened to the safety culture? They do not reflect changes in safety over a period of time. Okay. Now, last of it all. Do they cost? Oh, yes, they cost money. They cost money in terms of development of systems, implementation of systems, collecting data, reporting, analysis. They also cost in terms of the retribution which the person who has committed an error faces, that he will start committing more errors because there is a second victim involved. That also costs. All these things cost. I know what for you compensated. You are compensated for the number of patients you take, for the number of procedures you do, not for the number of errors that you report. You don't get compensation for that. So ladies and gentlemen, when reporting systems are not measures of safety, they cannot be used for tools of comparison. They cost money in real terms. Their benefits are theoretical only in the minds of my innocent opponents. Do they think they will help patient safety? So therefore, we must move into what my dear friend said here, into a culture of safety, not into reporting risks, into preventing risks by adopting a culture of safety. Thank you very much. Jai Hind.
Thank you. Thank you so much, Pavanji. This was really a master exposition, a master class, a teacher who's taught a subject for 15 years, but because the college has changed, he decided to turn the lecture upside down. Fantastic, a true master class. And now we have time for the rebuttal. So we have Suresh. Suresh, you'll have about 3 minutes.
Alrighty, you heard a lot of, personal stories. Dr. Sanjeev told about, So, and obviously he derided Montec LC and Allegra to a great extent. Fair enough. So the question that you want is, do you want your patient who's going to go in for an elective spine surgery to have the same kind of casualty, to have 6.8 lakh bill? Or do you want not to analyze it? Do you really don't want to do that? How many of you here would say, nahi ho gaya is patient ke saath chhod do? So what are we talking about? He's highlighting the importance of the fact that we do not want this to happen to the next patient. That is the message that he is not getting. The message is that he is not getting is that we do not want this to happen to anybody else. And that is the culture of safety that we want to encourage. Rather than to say, what can you do? This is a best intervention radiology. What is the point of reporting and all? Why don't we report this pulmonologist who is not qualified, who's prescribing a Montec, Allegra, doing a chest X-ray? Why don't we get him out of the system? Why don't we report him? Why are we afraid of it? Why are we letting this happen? Why are we letting an incompetent doctor take care of your patient? Why is nobody standing up, have the courage to say, get the dash out? Why are we not doing that? And why are we not reporting it? Because you're afraid he's air marshal. That is the reason. Because you think he's Dr. Suresh Ramasubban, he's a senior pulmonologist, nobody can touch him. I should be touched. And that is the culture that we want to inculcate amongst all of you. If I am doing wrong, you should have a safety culture. You should be able to report me. You should not be afraid of air marshals and director medical services who are sitting here, or a senior consultant, head of the department. You should be able to have the courage to report it. Sir sang a song for Mrs. Lallu Joseph here. How many of you think it is harassment? No rebuttals here right now, sir. No.
Complaint committee in this place.
No. How many of you nurses and doctors, junior doctors have gone through this and do not have the courage to report it? Please raise your hands here. And how many don't want a safety system? Just go to the owner and say, Hari sir, aisa ho gaya. Dare you to do that. Dare you to do that. All right? He sings serenades a lady in front of all of you and nobody wants to report it. Hail Mary, God help you all. Or gaiye gana. Seriously, what are we heading? The culture of safety is what we want to promote, and the best only way to promote culture of safety is to recognize that errors can happen. If you ignore that fact, if you don't report, if you don't analyze, if you don't go through the Swiss cheese model, if you start blaming people, it will not work. We want our patients safe. We have to learn from our mistakes, and we have to have a culture of not only reporting, analyzing, and yes, there is going to be an overburden. There are countries which report more than 500 cases of incidents every month. And there are countries like us where there are hardly 5 reports. There are hardly any sentinel events. Why? Don't tell me there are no sentinel events. It's just that we don't report it. Under-reporting, over-reporting is going to be a problem. Doesn't mean that we escape the problem. These are highlighting issues, but the moot point remains the same, that you cannot not report and not have a safety system in place. Thank you very much for your kind attention.
Hari.
Isn't it really sad? After listening to these two gentlemen, Dr. Suresh had the guts to go up and say what he said. Are Baba, we are looking at patient safety for the patient who is on the theater table for spinal surgery now. If you don't do this well, you might not get the next patient to make it more safe. Isn't it? First thing is, it doesn't get the fact that patient safety is for every patient, starting with the patient today. Analytics and reporting is for the future. You may never be a doctor also in the future, or you may not get patients in the future. And he also reiterated and strengthened our panelists' argument, saying that culture is more important than the reporting system. One. And he also reiterated the fact that the reporting systems are more harassment in nature than true patient safety. I hope at least the next time you people speak, trust, sun ke, samajh ke, baat kijiye.
She was happy about my song. Thank you, Hari. Over to Sanjeev for the final rebuttal.
So there is a hierarchy which exists in the hospital. There is a cardiovascular thoracic surgeon, there is transplant surgeon, there is God, then there is physician, pulmonologist, and administrator from CMC. Now, what do? They just have not understood what exactly are we debating on. So there were 3 people. There was a doctor, there was a marketing person, and there was a statistician. They were asked a very simple question: what is 2 plus 2? So as Dr. Suresh is flamboyant and prompt, 2 plus 2 is 4. Marketing person was also asked the same question. He says 2 plus 2 is 5. I would like to believe it like that. And then the statistician was asked the same question. He huffed and puffed. locked the door, and said, "What number do you want?" Can you see a marketing person here and a statistician here sitting who have absolutely no clue what they're talking about? My worthy Air Marshal sir had said that we are not talking about a reporting, which is archaic. And it is so bad that you are at this forum, which is the world's largest patient safety forum, you are misrepresented. She didn't take a consent before showing our photographs. What kind of reporting system she's talking about? She didn't take a verbal or an implied consent even before she showed what we were doing. And that's bad culture. Dr. Suresh came and fought for Lalu. That is harassment. Ask Lalu, she loved it. So, ladies and gentlemen, I would like to be extremely brief. Don't get into the rigmarole of creating more documents, more reporting systems, more training. Please change behavior. Please upskill staff. Please be good. You're in a fantastic, noble profession. Please be humble to accept if there is a mistake. Please be empathetic. Please listen to the patient who comes with a lot of trust, speaking to you. And that is what we want. And that is what Indian healthcare system is. And not what these opponents have been telling. Please also vote for us.
Thank you very much. Very nice, Sanjeev. You made a very passionate case on why reporting systems don't work. Korean Airlines had the worst safety record amongst all airlines. An aircraft took off from Seoul and was meant to land in Guam. The pilot who was supposed to fly had not got the requisite number of hours of rest. Very experienced pilot, very experienced co-pilot. Clear weather, they are starting the descent into Guam. One of the devices that is supposed to guide you in landing in terms of altitude malfunctions. Suddenly, a storm appears from nowhere. The pilot wants to land blind. The co-pilot says, "Captain, don't you think the weather is very bad?" He stops. He doesn't say anything. They make a descent, they crash into the mountain, and everybody dies on the plane. When Korean Airlines analyzed, they realized that in each of the aircraft disasters they had, there was a singular problem. The problem of being subservient. In the Korean culture, you do not speak up. What the co-pilot was saying, "Captain, we are going to crash. You can't see anything. Let's go around." But he said it very politely. So Korean Airlines went into a transformation where they changed the culture. They changed the reporting system where they encouraged everyone to speak up. And after that accident, Korean Airlines has not had a single air crash. And why did that work? Because of a reporting system. So as you decide to vote, please keep that in mind. We are charged with looking after lives every single day, every moment of the time that we work. And if we do not measure, how will we get better? Time for the voting now. Hari, you want to say something to counter that? No, sure.
I think he showed us a team preparing for a match, right? The team follows the leader. जब लीडर नहीं समझता टीम क्या समझेगा? We just spoke about airlines and airline accidents, and still he takes that example. Korean Airlines killed thousands of people before it decided that something was going wrong, so it started using its reporting system to improve its systems and transformed itself. As medical professionals, do we have the license to kill even a single person? And then report it and then make sure that the next person is not killed or harmed? So the basic thing which we do this session basically to drive home a point. Patient safety is our utmost priority for any healthcare professional, and there should be never any compromise on that. But the tools you choose to make the environment safe for a patient are multiple. And as we evolve, the priorities of the tools keep changing. Yes, reporting is one part, is one tool which helps us in improving care for the future, preventing harm in the future, preventing disasters in the future. But I think, as my side of the team said, it is more behavioral, it's more the culture, and it's more the skill and the training, which contributes more to patient safety than just incident reporting. We're not demeaning incident reporting in any way. It is important. It needs to be done. And I think all the four panelists, along with Anupam, need a big round of applause from all of you.
A big round of applause for you, Hari, for navigating this.
And now all of you lift your hands against the motion. Quickly.
See, the thing is,
Quickly,
don't worry
quickly,
about
quickly.
it. With the light here,
See,
he can't
Anupam,
see, so he's imagining
Anupam.
everybody's raising hands.
अंधे को कुछ नहीं दिखेगा.
See, there we go.
But the thing which you need to remind yourselves is, at the beginning of the session, there was not a single hand which was lifted against the motion. But by the end of it, almost all the hands were lifted. So thank you so much.
Thank you so much. Time for the voting, because we have to have that ritual. So, no,
Ho gaya, Baba.
Acha, you concede
Oh,
defeat.
no,
So
no,
he actually
you
said
saw
yes
it
after 52
yourself.
minutes. But thank you so much for an absolutely wonderful session. Big thank you, Hari. Thank you for coming from Hyderabad. Always, and pure joy to be able to have this session with you. Thank you, Sanjeev, Pawan, Lalu, and Suresh for making this very lively. And thank you for an absolutely amazing group of experts here, young and old, who sort of were very participatory in this session. Thank you so much, and over to the organizers.
Can we please request you to please step forward for a photograph? Ladies and gentlemen, that was Dr. Anupam Sibal, Dr. Hari Prasad, Dr. Lalu Joseph, Dr. Suresh Ramasubban, and Dr. Sanjeev Singh, and Air Marshal Dr. Pawan Kumar. A bigger round of applause. That was an outstanding moderation. Your energy and witful information based on discussion was indeed one of the highlights of IPSC 2025. We appreciate your time and efforts for making it such a success. Thank you again to all of you. Thank you, sir.
Thank you once again. It's time to play our very favorite game, Bingo, again today. And we are going to announce the first set of words. Yesterday we had announced the 4 set of words. Today is the first set of words which we are going to announce. I would request everybody to take out their bingo cards. If anyone is not aware from where to get that, it is available with your registration folder which was given to you. It's available there. Please take it out, and we would be announcing the first set of words. Please strike off the words as we announce. We are going to play bingo game 5 times today in a day, followed by the completion of it, and you can drop the cards there at the IPSC counter. And it's one more announcement here, a very important announcement. Do not miss the special mindfulness session with Sister Shivani today with us here in the same plenary hall. We have also Honorable External Minister joining us today for a very important discussion. I would request everybody to be available for that session today, which is planned at 5 p.m. The session would be here at the same hall. Again, a reminder for a session with Sister Shivani and again a next session with Honorable External Affairs Minister.
Right, moving back to the bingo words for today, please we request you to take your bingo cards from your registration kit and you can strike out these words, what we're going to say today. The first word for today is SOPs. SOPs. Followed by, the second word for today is sterilization. Second word is sterilization. And the third word is accreditation. The words for the first bingo words for today is SOPs, sterilization, and accreditations.
Another important announcement related to the games which you are playing, the lucky draw coupons, you need to collect it from the IPSC counter, and there is a box which is available there available. You can drop your lucky draw coupons at the box available at the IPSC counters. Please grab your lucky draw coupons and drop it there at the IPSC counter. I request everybody. We will be announcing the winners of these games today. The time would be confirmed shortly, and the winners would be given with some special awards. As we move forward, we are delighted to share that now we are moving to a very important session now. If everybody is available, I would request everybody to take their seats, settle down as we are moving for our next very important session. Okay.
Requesting all the delegates and speakers to please clear the aisle and we settle in for the next interesting sessions.
The topic for our next session is the transformative role of technology in patient safety. In our rapidly evolving healthcare landscape, technology has become a pivotal force reshaping how we approach patient care and safety. Patient safety remains a cornerstone of quality healthcare. Despite advancement, challenges persist. As we navigate this digital transformation, it's crucial to embrace innovation, foster collaborations, and ensure ethical implementation. To delve deeper into the topic and to chair the session, it's my pleasure to welcome on stage our worthy session chairs. The first session chair, as I invite Dr. Rohini Sridhar, Chief of Medical Services, Apollo Hospital. Please give her a big round of applause as she walks the stage. Dr. Rohini Sridhar, may I please request you to join the stage, ma'am? A prominent figure in the medical community and a valued member of the Apollo Hospital's team. Her expertise and dedication have significantly impacted patient care and clinical outcomes. Dr. Sridhar embodies excellence in healthcare. I welcome you here on the stage, ma'am. With this, I would like to invite our second session chair, Dr. Abhijit Seth. Dr. Abhijit Seth, if you're here available, please join us here on the stage. Dr. Abhijit Seth is Director, Medical Services, Apollo Hospitals. I welcome you here on the stage, sir. It's my pleasure. Ladies and gentlemen, may we please welcome our session chairs with a big hand of applause. Thank you so much. Now we invite our set of speakers here. It's my pleasure now to invite the speakers who will share their insights and experience on how technology is reshaping patient safety. Our first speaker for the day, Dr. Ahem Arora, Lead Education Strategy, J&J MedTech. May I please request you to join the stage, sir? Over 25 international publications, a book chapter in Oxford GI Surgery Library, and notable speaking engagements at Harvard Medical School. Dr. Arora is particularly dedicated to upskilling India's next generation of surgeons, addressing the evolving challenges in modern healthcare with a pragmatic use of AI. I welcome you on the stage, sir. We have the second speaker here with us, Dr. Mulidhar Verma, Head Infection Control Department, KMC Manipal, Mahe. May I please request you to join the stage, sir? Dr. Verma is involved in teaching both undergraduate and postgraduate students, providing patient care, guiding thesis work, serving as the medical officer of the Hospital Infection Control Committee, and overseeing the HIV clinic.
Over to the speaker number 3, we have Dr. Vaswant Potipati, Medical Affairs, BD India Private Limited. A big round of applause for him to join us on the stage.
Apologies. Dr. Vashwant will be joining us in a while.
All right. Moving on to the speaker 4, we have Mr. Prapat Kumar, co-founder and CEO of the Dream Soul. May I please request him to join the dignitaries on the stage? Mr. Prapat Kumar, with an MBA in Marketing and Human Resources from IIPM, New Delhi, with 2 decades of healthcare sector focusing on technology-driven solutions that enhances patient care. And under his leadership, DreamSoul has developed cutting-edge applications that streamline hospital management system and ensure data security. And on speaker 5, we have Mr. Chandrasekhar Sibal, Head of Medical Division, Fujifilm, India. May I please request him to join with the dignitaries? He has efficiently designed and managed go-to-market strategies across direct sales verticals and the indirect channels, volume extraction strategies, customer satisfaction diagrams, ROI, accountability, and top-line to bottom-line management with employers like Fujifilm, Samsung, GE Healthcare, and L&T Medical. May I request now the moderators please to continue with the sessions, and over to you, ma'am.
Yeah, good morning and namaste to all of you, including all the eminent speakers and my colleagues. It's very interesting session, and this is the way forward for the healthcare, and in next few decades, the healthcare is going to change significantly, dramatically, and the practices which we are doing may be completely different than it could be after a few years. Only 2 or 3 things which is important, which we try to do at our organization at national level, is 1, to promote the clinical research and innovations, because that leads to discoveries and advancement of technologies. Second is we must, while developing the clinical technological advancement, we must assure the humanizing factor, means humanizing of the healthcare is very, very important at the same times. So the ethical values of the clinical medicine must be maintained, and that's what what I would like to summarize. And certainly, it will be one of the wonderful session. Thank you.
So I'd like to again welcome you all to this session. As we saw with the previous session, I think all of us in hospital administration and healthcare professionals are fighting this battle to make healthcare safer. And whatever we might do within our hospitals in engaging our employees and talking to them, I think we need to also learn to harness the power of technology. Because this is a battle which, if you saw Dr. Pawan Kapoor's slide, over the years we have not made much progress in preventing preventable harm. And so I think it's important that every tool that can be brought into play to enable us to win this battle should be deployed, utilized effectively, and that will drive for us the more safer and safer healthcare of the future. So we have an absolutely expert panel today, and all aspects are covered, starting from generative AI in healthcare, to digital solutions within the hospital, looking at also what we can do in terms of safer vascular access. Vascular access is something that all of us know. It's one of our big pain points in healthcare delivery, particularly with the challenges we now face with such high attrition in the healthcare space. So I think we have a great panel here today, and I'm sure that all of us will learn from their experience, insights, and what they have built and what they have to offer. So over to Dr. Ehem. I think he's the first speaker.
Good morning, everyone. First and foremost, thank you so much to the entire team for a chance to speak at this esteemed event. I think the sessions so far have been absolutely brilliant, and I'm going to try to keep the energy up as much as possible. Can I have my slides up on screen, please? Any confirmation that the slides are coming up? All right, great. So in the meantime, I'll just share with you a brief intro about myself. I am Hem Arora. I come from Mumbai. I'm actually a GI and abdominal wall reconstruction surgeon by training. But for the past few years, I have been leading education strategy for J&J MedTech. Some of you, especially the soft tissue surgeons in the audience, may be aware of the great inroads in minimally invasive surgery that J&J has facilitated in India over the past 20 to 30 years. Over the course of a year, we reach out to maybe 50, 60,000 surgeons with hundreds of training programs, and it's my job essentially to steer the strategy in the right direction. But a large part of my career was actually spent as teaching faculty in Mumbai's Grand Medical College and Sir JJ Group of Hospitals. I got an opportunity to see upfront what the challenges of healthcare delivery are, particularly in the public sector, and thank you. Perfect. So I got to see firsthand as to what the potential challenges of healthcare delivery could be, and also what the challenges of certain education essentially are. So I would start off with my central thesis that skilled surgeons are safe surgeons. And most of the stuff that I'm going to be discussing today is veered towards the early career population, because I had hundreds of these young surgeons pass through our institute over my entire stint there. And it's kind of made me realize that that's one place that we really need to do a lot of work. We had a lot of opportunities that we came across. How can we improve workflows? How can we improve both healthcare delivery as well as upskill our surgeons at the same time? But unfortunately, when we got together to ideate, we always hit roadblocks. A lot of the solutions seem to be very expensive, novel software models, which were difficult to install, may not work within our ecosystem, may not communicate with other software out there, and it landed up creating more headaches than solutions for us. The other more jugadu traditional way of doing things would be, why not we have more manual intervention? Why don't we ensure that there are more checks in place so that adverse events don't happen? And why don't we just have more professors on our roll to ensure that upskilling of the surgeons is happening at a particular level? But as you're aware, the more human intervention comes in, there are potentials for a lot of biases. Your workflows get distorted, and that's not a very efficient way of actually improving your systems. In about 2020, we started seeing the first glimpses of artificial intelligence and its intersection with surgery, and I was really excited about this. These early papers were all about AI being used on data sets for analysis, trying to predict trends in populations. They were also looking at images. So things like radiology and ophthalmology were primed for diagnosis. But I'll tell you what really caught my fancy were papers like this, where they were using AI not just to look at data sets, they were actually using it to identify different parts of the anatomy, and in this case, help surgeons identify the critical view of safety in laparoscopic cholecystectomy before you've clipped or divided any structure. I saw this and I thought, wow, we are on the precipice of a revolution. Go ahead a couple of years and suddenly we started seeing all these commercially available AI large language models coming in. Now the onus is on us. How do we use these commercially available tools which are going all around in a way that improves our patient delivery and does not land up becoming one more step or redundancy that holds us back? So very quickly, what is generative AI? At the risk of sounding a little nerdy, or let me avoid that. Generative AI is just artificial intelligence which is made to create content. What could the content be? It could be videos, it could be pictures, it could be a workflow, a decision tree, it could be a bunch of code that you'll end up using in software. We've seen this in several different iterations, but there are some basic principles that we have to be mindful of. One, Gen AI requires a large amount of data. Most people get overwhelmed by the quantity of data, but I want to bring it to attention the quality of data as well. When I was preparing this talk, in one of these popular image generators, I put in a prompt, and you can see that up there, promotional images of watches showing the time 6:30 p.m. And look at the images it generated. All of the watches are showing 10 past 10. Are you telling me that artificial intelligence does not understand 10 past 10 is not the same as 6:30 p.m.? But you need to think it's actually learning from images out there in the market where companies always show their watches at 10 past 10 so that their logo on the watch is clearly seen. So the AI is only as good as the training data that is being fed into it. It's extremely good at generating new content, but it's also about the prompt that you'll end up giving it. It has to be in a highly specialized, narrow focus. We still haven't come to terms with one AI to rule it all. I know if anybody's watched Terminator and Skynet, we still aren't quite there yet, where you have one tool that manages to do everything under the sun. There's a lot of fine-tuning and adaptation that is required, which means that if you're using an AI software to essentially improve your emails, you will not be able to use it for noise cancellation. You will not be able to use it in the OR. You will not be able to use it to handle statistics from the research that you guys are involved in day in and day out. So AI is purpose-built for the job that it is meant to do. So where is Gen AI being used at this point in time? It's being used for research. Over the past year, you would have gone and realized when you Google something, on the top, it actually gives you an AI summary of what it is you're looking for. Because who has the time to go through the different links that it used to share at the bottom, right? You don't want to waste time doing that. Let AI take care of that for you. It's also being used at this point in time for optimizing tasks. So I use it all the time for improving emails, for grammar checks, spell checks, things of that sort. You can use it for tools use it as a tool for ideation. Like, give me a rough outline as to how I will talk about generative AI in healthcare. And it spews something out to begin with. It's also used for visual content generation. I just gave you an example of this with images, but you can do this with videos as well. And we have a generative AI tool which is for J&J to be used internally, and I'll end up using it to analyze my data. So I mentioned we have 500,000 surgeons that we interact with, so many hundreds of programs. I don't want to be grappling with Excel sheets all the time. Sometimes I just want to put the data in, let it analyze it, and ask it leading questions. What was the feedback from X type of programs over the last year? And it does all of the work for me. So it's making me more efficient in understanding the data. As a segue to my next session, I think a good example would be the previous one, where they spoke about what do we do when data comes in. A lot of times it's just lying there. Nobody has time or effort or resources to actually go and analyze the data. AI can land up helping us with that. So where is Gen AI being used in healthcare? It's being used in a similar fashion. I see a lot of young faces out there. When I was in residency, one of the critical tools that was required is how do you use filters in PubMed? I kid you not, there used to be workshops conducted as to how to use PubMed effectively. You don't need to do that right now. It's a good to know thing. It's not a must know because AI summarizes so much research for you. It's absolutely easy. Once you find the right paper, you can ask it to summarize it further, give you a little more information than the abstract, or ask it leading questions. For example, was this a controlled trial? Were they registered? Where were they registered? And what the adverse events were. You don't have to go through a 5,000 word article to find something specific. And Control F on Adobe Reader is not going to do that for you as well. These tools in AI definitely can. It definitely helps in improving your workflow and saving a lot of time. Let's see a few examples of this. Patient engagement and personalized care. The need for making healthcare more humane is what Sir spoke about in the introduction, is extremely important. So now you can actually create custom pathways for patients within hospitals and connect them with the right people without making them feel like they're going through a cookie cutter approach. You can create automated patient education materials which are intended to educate them, not overwhelm them. The people are already experimenting with conversational AI bots for pre-op as well as post-op counseling. Just imagine that. All the work that you have to do in the OR is done and dusted, but now a bot is going to take care of setting expectations for what the post-operative recovery are going to be with the patient, solving patient's queries at all odd hours of the day as well. The next bit is data from wearables. How many of you are aware of Holter monitoring? All right, so it's 24-hour ECG monitoring in a nutshell, right? There is a person at the other end of that really long ECG lead that is looking at the data. And I'm just going to quickly go ahead in the interest of time. You can definitely improve your workflow and save time using automated medical documentation, using prior authorization and scheduling, especially in insurance cases. A small point about residency is that there is a huge skill gap that actually exists in our residencies today. There is a need for coaching. There's Mr. Acharkar, who's Sachin Tendulkar's coach, but Tendulkar had a coach for a large part of his career, and you can see Michael Jordan there at the peak of his past that actually had a coach in his career as well. Atul Gawande from the Boston system has written amazing articles and an entire book called Better on Justice, that coaching, even at experience levels, can help improve. We're already aware that laparoscopic skills require a significant amount of upskilling. But how do you go about it? Do you use these traditional endo trainers, which are clunky? And mind you, when we use endo trainers in these settings, usually a trainer like me is standing behind looking at what exactly is going on. I can tell you it's boring. It's very effort and time intensive, and it's very redundant at times because people need hours of practice. Well, we are now actually experimenting with an AI-based tool to take care of this. There's a tablet camera feed that goes into the cloud, and that cloud is essentially analyzing the motion of the instruments in the visual field. And you can see that there is a nice path that has been created. I felt I was rather smooth in this video, but apparently not. As a result of getting data generated like this, and this is back-end visuals, the person performing the exercise will not see it, I can comment on what the efficiency of the surgeon was in getting from point A to point B, what their smoothness is, the time taken for the exercise, and how accurate they were in performing that task. And we've also gamified the entire experience. So now you can play against yourself over and over again at any time of the day, and guess what? We don't need a trainer looking over you the entire time, because the system is giving you feedback all the time. This is another way of going about it. So the AI tools can be tweaked to different exercises. Here, not only is it tracking the instruments, but it's also tracking the peanuts, trying to identify how many of these fall, which you will see in a bit, actually lands up passing out of my hands. The tools are very useful in a training setup and can have a significant impact, I feel, in improving the overall skill set of our surgeons and enabling our educators and clinicians to concentrate on what's absolutely important, taking away a lot of these basic needs. I feel the next step really is going to be taking all of this AI tech into the operative field, where surgeons at the top levels are getting AI-based feedback to ensure that they don't stop improving, irrespective of which step of their career they are at. Thank you so much.
Thank you, Dr. Ahim, for an absolutely brilliant talk, which offered some exciting possibilities of the use of AI in healthcare, not just in surgical upskilling, but in hospital admin as well. And I'm sure everybody in the audience has taken note of it. I think in the interest of time, a couple of points to make. One, if there are questions, we will take them at the end after all 4 speakers have finished. And I request all the speakers to please keep to the time of 10 minutes. Thank you. So I think the next speaker, I'm not sure what the order is. I think it was Dr. Prabhat. Yeah, okay. 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 So now we'll have Dr. Verma speak, and I think he's speaking for the 2 speakers in the session.
Yeah.
So 15 minutes perhaps? I'm sorry, but
Yeah.
we're really, way past
I'll
time.
do it before 15
Yeah,
minutes.
please.
Should be fine. Good morning, everyone. First of all, thank you, the organizers, for giving me the opportunity. I know we had 2 sessions. One was very interactive and everybody enjoyed it, right? I know everybody knows the truth is in between, right? And we had a wonderful session just now about the AI. But I'm going to talk about which is very fundamental to healthcare and which we do day in and day out. So if I ask audience, how many of you have you given a blood test? Have you given a blood test? I'm sure all of you will raise. There's so much awareness about healthcare now. Everybody wants to do their routine tests. How many of you went to a hospital and got an IV line inserted? Quite a few, right? So the next question is, how was your experience? When you gave blood, did your phlebotomist got it in first prick or multiple pricks? Did you have a lot of pain? And they said, oh, this is not good. Or you've seen your parents suffering 2-3 pricks. And when you got an IV line, it was fine. But when you were removing, you had a lot of complications, right? And you had so much pain when the drip was going on. These are not uncommon. I come from an institute which is 2,300 bedded, and this is day-to-day problem. Being head of ID and infection control, these are the common reports I keep getting. So what I will do is, I will show you how a very fundamental technology can help solve some of these problems. I'll skip this. I've been clinician for so many years, I know how patients suffer, right? So when an IV line is inserted, as I told you, majority of them hospital patients who come undergo some sort of IV line, and ICU patients probably central lines. So there are multiple ways those lines are touched. Either a nurse touches, or a clinician comes and touches, or phlebotomist wants to do something. But these products cause a lot of problems, right? It can cause thrombosis, right? It can cause pain, it can cause infections, which are dangerous, right? And also occlusion. So many times within one day, our nurse says, I want to remove it. That's one of the common complaints. It comes with cost, etc. And they also cause a lot of serious problems, especially when you have central lines, which can cause bacteremia, which can be life-threatening. So this is some of the data which is published in the worldwide. I will just run through it. When we say club sheets, basically a tool we use to find out how many times patients had bacteremia, that means blood in the bacteria in the blood from central lines. But the other definition which is often confused is CRBSA, which is more of a clinician definition. So if you look at the rates, it's less than 1 in most European countries and Americans, but in Asian countries like developing countries, it's about 5 to 8%. It used to be around 10, 12, now it is about 5 to 8. So we are almost 5 to 10 times the rates what we are. There are other challenges. It causes mortality. I'll show you some of our own hospital data. It can be at an average about 2.2%, but in countries like us, it can be as high as odds ratio of 3.3. Apart from that, what we don't understand is in India, there's a growing problem of AMR, antimicrobial resistance, which is a massive, massive problem. And lines do contribute significantly to line-related infections and AMR, especially in high-risk areas like ICU. So this is our data. So we do monitor very aggressively we monitor, we stick to standard definitions. So this is how our rates are. Our rates have significantly come down, but I'm showing you the last year data, right? If you look at per month, how many are there? Roughly we had around 68 cases. Noteworthy point is of this significant portion of them are multi-drug resistant and pan-drug resistant. When we say pan-drug resistant, that means these bacteria cannot be, we can't use the standard drugs like carbapenems, right? And this is a reality. This is to give you a snapshot. I'm sure Delhi has similar problems. So this is how a bad lines can cause serious problems. In our own hospital, when we looked at data, every extra day, patient is spending thousands of rupees because they had a line-related infection. So it adds cost, it adds infections, it causes. So before we go on to the technology, it's important to understand some very basics of how lines work. If you look at how they are used, there are open systems and closed systems. When you look at open system, they basically open to environment. So every time a nurse has to open the hub, connect it, and they're causing a lot of touch points, which will increase colonization and subsequently infections. And also they're exposed to environment, what we call it as colonization. This is a traditional system. The new system talks about closed systems, where needleless connectors are used. It always reduces your way the fluids are given, and also reduces the amount of colonization, which is the first step for any infection. So if you look at needleless connector, I will not dwell into too much into the types of it, but predominantly when we look at it, it's the split septum based, which are the ones which make a lot of difference. The life is so easy for us once these were introduced. So we can push fluids easily, connect it, and scrub the hub which is told but not often done. Is a human. I mean, let us be honest, we had a big debate how systems work, right? People start creating wrong data and we try to believe it. Being a clinician, I see every day what is happening. So it's important to understand some of these fundamental problems can be solved, and it not only reduces needle stick injuries, but also reduces the infections. So when we create systems in our place, for me, very important thing is to how to protect my nurses and doctors who do these lines every day. And needle stick injuries are serious challenges, and we never know which patient is HIV positive. So the other thing is, once the line is inserted, the maintenance is a challenge. The flushing, what does flushing do? Flushing will help patency. It prevents biofilm formation. Biofilm occurs within sometimes hours and within days of insertion of anything foreign in our body, let it be fluid, anything. So using a simple flush like that can significantly reduce the risk of infection and block. So is there any real data? Yes, this is the data. Again, most of the data is from Indian population. You can clearly see by using septum-based single pre-fill flushing, we can significantly reduce the rates. Not only that, we can also reduce the cost, which is what your admin wants, right? People think by investing more about we actually spend more. No, but ultimately, as I said, every extra day patient is spending more and we can't discharge him, especially in ICU patients. Of course, there are limitations in this data. The second one, the topic, as I said, I'm sure all of you have given the blood, right? So you had pain points. But the challenge I always find when we write protocols is pediatric patients and cancer patients. They have two unique problems. One, children are scared. Even now we say, okay, if you shout or anything, I'll call a doctor, give you injections. So it's already ingrained in our human minds then, oh, doctor means he'll give injections. So when children come to our OPD, they're so scared, right? And mother has to hold. Two things happen then. One, they try to poke and the phlebotomist is also scared and she pricks herself, or sometimes instances where she pricks the mother also, right? Because the child is so fidgety. Oncology have a different set of problems. They have a small veins and multiple drugs would have gone into them. As a result, veins are difficult to get and they become so fragile. So all these are big challenges. So there are different ways we could have easily handled this. Of course, for children, we give toys, we distract, there are different strategies. But ultimately, it's the technology that helps us covering these shortcomings. That is very important, right? So for that basic understanding of why these needle stick injuries occur, why it is difficult is important. This is one product which will solve many of this. Again, I'm telling you, there are 2 points here. One is taking care of the patient's blood. Second one is to protect your healthcare worker, your phlebotomist in this case. So what does this device do is, one, it is thinner, as you can see on the right-hand side. It is so thin, you can see nicely it is going into the vessel. And there are 5 points so that the pain is significantly less. And the major times, I'm sure some of you experience, the phlebotomist doesn't know, okay, as the blood come into the system, they keep poking you. This system allows you to see live, okay, blood is coming. And once that is done, the other thing is, how do I protect my healthcare worker from getting needle stick injuries? That is just push of a button, the needle retracts and we can discard it. So there are multiple advantages of this system. Again, these are just a snapshots of how a simple technology can transform patient safety. Okay, I myself worked as an intern. I know how many times I used to draw blood, poke multiple times, and all my patients used to curse me, difficult patients. And I don't see that much. And some of them scolded me also. I was a junior doctor, right? I know systems are much better. That's how technology can transform lives and improve the patient safety. Our needle stick injuries also have significantly come down. Thank you very much. If you have any questions, as we said, probably we'll take it. Thank you.
Thank you, Dr. Verma. I think you addressed several very important points, not just in obtaining access, in maintaining lines. We know the problems that come from needle stick injuries, and it's something that every healthcare professional, particularly those dealing with quality and safety, try to address every day. And I think many of these devices, if looked at, will actually make the process much easier for all stakeholders, whether it be the patient, whether it be the nurse starting the line, or the clinician in charge of the patient. So thank you for that. That was explained very lucidly and very simply, and I think many in the audience would have found benefit from that. Can I now request Mr. Prabhat Kumar from DreamSolve to talk about digital innovation and how it can help us transform the patient experience and operational excellence.
So thank you so much. Good morning, everyone. Good morning, everyone. Thank you so much for having me. I will be sharing my 2 decades of experience, working with various healthcare groups. And there are 7 specific case studies that I'll be sharing with all of you today. So let me just let my slides get on. So we'll be talking about, service excellence. We will be talking about patient safety, operational excellence, engagement. In interest of time, I'll be rushing actually, but still, I'll try to give glimpse of what we have done, how we have done those turnarounds with various brands. We have been working with the largest of large healthcare groups, currently in 8 countries, but we soon are going with Philippines, Singapore and all. And we have been working with all those brands, basically. Okay, so before we begin, there is a question for all of you. What's common among these big shots of healthcare and wellness domain? Can anyone, try to give an answer for this? Any guesses? Okay. The answer lies here. Simple, they leverage our enterprise productivity management applications. Lot of people ask, what does productivity management application actually mean? So, many years ago, it's been almost 20 years now, when we started this organization and we thought HIS is already there. And what role should we play? So then we found lot of niche areas, lot of gaps, and then we created certain tools around it, which can create lot of turnarounds for these brands, which we just showed you basically, right? So and I'm thankful to Dr. Sangeeta Reddy because around 10 years ago, when I was at Hyderabad and I was interacting with her team and she was very clear into things and we got a vision actually. She said you do anything to enhance the patient experience, patient engagement and operational excellence because this is something which whole of the healthcare they actually require and hence we created certain tools and today's case study will be around this. So even if these tools are there but we always customize and we go around with it. Under patient experience, there are multiple tools, but operational excellence is something where we do a lot of research and we have created a platform over which we can kind of do. So let's go straight on the 7 case studies, success stories that I want to share with you actually. The first one is about transforming the complaints to create a wow experience actually. So 15 years ago, one of the hospital invited, they said, can you please automate, can you give us a tool wherein we can just enter, the feedbacks into some tool and create some graphs. But then later on, lot of hospital adopted, tab and lot of other things. However, now, what has changed and how we are helping out, as you can see, there are more than 150 plus hospitals, 100 plus clinics and more than 500 pharmacies. How we are turning around for them is, it's not only about capturing these complaints or feedbacks, but creating a robust system for root cause analysis. Lot of quality people are here and that will interest. The corrective action, preventive action. But, patient is not, they are not caring only about your NPS, because most of the, people, service excellence, patient experience people are, trying to get a better NPS, but patient needs something better than that. Hence, we created a tool wherein a predictive analysis can be done. And when next time the patient is there in the hospital, we can tell about that patient that this patient has given a 0 detractor and the reason was this, or he had a preference. We can create a wow factor out of it. especially for onco, the largest onco group, in Asia we worked around, and onco patients are very repeat patients. They have a different kind of mindset whenever they come down for those painful chemos and all. And if, small needs can be addressed in terms of extra blanket or, some, food preference and all, this can actually create some wow experience, and this is what we have done actually. The second one is, when patient is there for 2, 3, 5 days, whatever, duration, one of the things that they struggle is about basic services, And when we started off, there was only one US-based company who was providing that kind of services. And, the industry needed some customized tool for healthcare. Hence, we came out with this where, all the complaints can be registered right from scanning a QR code from the bed. And, there are multiple mechanisms. The largest Asian healthcare hospital right now is addressing more than 50,000 such complaints. And, we are because whatever is measured, is always improved. We have a trend analysis that on which floor, how many GDAs are required, what is the peak time when people request about something. So that is about this. Then we have customer queries. So a lot of hospitals get a lot of queries actually, and then what we created was the revenue out of it. The largest group at Middle East, whenever there is any query which is coming down into the system, we have a workflow which is very dynamic in nature. And this can create automated next workflow out of it, and then the solution is very readily available so that, the monetization can also be done out of those queries actually. Patient safety is very important, and hence we created a tool wherein, currently it follows NABH, JCI, DHA guidelines and all. It is capable of n number of checklists. Our hospitals are using more than 40 plus checklists for nursing assessment or for, patient safety quality indicators actually. It's very handy in mobile, and whenever they are walking around, they can click a picture, they can record it, and it gives a lot of insights and actionable data, what has to be done actually. And this data is compliant with all those reports which are required. Then, asset is one of the very important component for hospital. And, all, whether it is biomedical or engineering and other assets, somehow hospitals, do not have any systematic tool where they can manage the complete life cycle of it. Hospital minus this asset is just a hotel, all of you know that. And hence we created very comprehensive tool which captures each and every, life cycle of it. There is a lot of alert mechanism to different level of hierarchy. Everything is paperless through this, whether it is contract renewal and all. And many of the hospitals are kind of again benefiting out of it. Next is about, operational excellence. For one of the largest hospital, we created more than 20 plus operational excellence, tool. We integrated with HIS at lot of things. And the transformation was that all these small processes which were not digital are now, it's very much digital and it's very accessible, and there is a turnaround time for all those tasks. The milestones can be created and the KPIs are taken care of into that. CRM is something, in the healthcare, most of the large companies, they tweak, but we created the first CRM and the largest hospitals are using it for, the CRM part of it. These are very exhaustive and other tools. I'll just end off. Today is a very special day for us because exactly today, 20 years ago, we got incorporated, and we feel that it is just not 2 decades of our working and serving the healthcare, but it's just the beginning actually, because now we are working on Gen AI and other things, and in next 3 months, you will actually find all our tools very much, powered with Gen AI and, the latest things in order to help you better. Thank you very much.
Thank you, Mr. Prabhat Kumar, for that showcasing of the different digital solutions which have been developed. And as you could see that many of those solutions actually demonstrate significant insight into our pain points. So whether it's CRM or asset management or even enhancement of patient experience, I know that those of us who work on the floor, these are problems we deal with every day. And solutions of this nature would be of considerable help in not only enhancing patient experience, but also operational efficiency. So thank you for that. Our next speaker is Mr. Chandrasekhar Sibal. We go back to AI again and see how AI can redefine the patient experience.
Thank you very much for giving this opportunity, and thank you very much for giving your time. So I will, Chandrasekhar Sibal, Head of Medical Division, Fujifilm India Private Limited, and I will take you through a few of the innovations which we have done and how we are taking the AI to the patient and how it is changing the lives of the patient or making a difference in the life of the patients. So we are empowering a brighter tomorrow, commitment to innovation. Our logo is giving our world more smiles. And we are a one-stop solution for all your equipments. We are the leaders in CR, DRs, films. We have added CT, MRI, ultrasound, IVD, and many other products, healthcare IT. And we are a one-stop solution for the hospital needs. And you know that TB is the big problem across the world. And the 4 million patients lack the access to timely diagnosis and the treatment. And the challenge is providing the medical facilities in the rural areas. So what we have a product called X-Air. And this product is a small X-ray machine, ultra-portable X-ray machine, which is 3.5 kg weight with digital panel and a laptop. And that is fitted AI-powered diagnostic support is there. And this can go to any place, smallest of the small places, and it can scan the patient and you can get a result immediately. And then you can go for a sputum testing, gene expert testing, and this can go any part of the world. So that is a major advantage. And it is a battery operated machine, and this can take 100 X-rays once fully charged. This can expand the coverage by utilizing the PHCs, accelerate the TB control. And in PHCs, in a smaller places, it can go to the home clinics also. And it can do not only the chest X-ray, but stomach, bone, or any kind of new lung infection it can detect with the help of AI. And the use case, actually, what we have done in India, we have done this lot of testing in India. We have multiple phases also. And this is our vision for this. Like, during the COVID days, you have the information every day coming that this area has 100 cases, this area has 200 cases. So what we want to build is that worldwide we want to make a cloud server and give the information that this TB, this many cases are there, so that we can go and solve the problem and diagnose those cases and give the treatment for those people. In India, we have done different phases under our CSR program. In the first phase, we have taken 27 locations and 1.2 million patients have been reached by us. Number of X-rays were 12,000 and number of TB 225. Similarly done second phase. Now we are doing the third phase, and the fourth phase also will be started soon. So we have detected more than 500 to 600 patients with active TB. So this is the power of this tool. That small tool will go to home or any kind of clinics or small places, and it can detect the TB at a very early stage. The next thing what we have done is that we have opened the screening centers. We have the Neura screening centers. We have opened 4 centers in Bangalore, Delhi, Mumbai, and Hyderabad. And these centers are going to tell you about the top 10 cancers. These are the screening centers. So top 10 cancers we will tell you, and these are enabled with the AI technology. And within 120 minutes, you have the report of the patient. And the clinician or a GP can tell you with a tab that, okay, you have this kind of problem. It is like a CT scan is there, a mammogram is there, all is AI enabled. So this is a thing which we are doing with the help of AI, and it is going to detect the disease at a very early stage and help the patients. Next point I want to bring is the National Digital Health Mission coupled with AI. And now, as you know, that Government of India has a mandate to go digital, and all the hospital, healthcare providers, and Aadhaar card is there. So with the help of that, if we can connect all the patients, and AI will also analyze further if we have that kind of infrastructure is available with our hospitals, or even the providers, those people, and the data can go to that unified health interface. So basically, with the help of that, we can, like a UPI, it is going to be a UPI for healthcare. If this kind of infrastructure we can develop and we can connect all our hospitals, and then we can analyze these things further actually. And this will be able to give us a lot of insights into what kind of problems are occurring and what kind of problems can occur. So AI can definitely work for democratizing the healthcare and providing the healthcare to all the needy people at a smaller places at a very, very low cost. So this is a very, very important thing. And to ensure that we should have algorithm biases should not be there. We have to have a better understanding what we are doing and how we are writing those algorithms so that there are no biases in them. So, but in the world of AI, my last slide, because I have only 1 minute left now. So I want to see that we should not stop thinking, because AI is giving us too much actually. And sometimes it is not relevant also, because everybody is selling their products, just they're saying that it is AI so it has become a fashion actually, it's become a fad. But actually how we can think, we have to make our mind a pleasant place. So that is very important, and I have taken this Chitta Prasadanam. So this is the one of the 8 this thing in Yoga Sutras. If you see the Patanjali Yoga Sutra, you read there, and the answer is in 1.33. How you want to make your mind a pleasant place with the help of the Maitri, Karuna, Mudita, and Apeksha. So the mind field is made pleasant by practice of amity towards the happy, compassion towards those who are suffering, joyful at seeing others meritorious, and the practice of indifference towards the transgressors of the virtue. So this is by Swami Veda Bharati ji. So very, very important to think clearly. And if we will not be able to think clearly and make our mind a pleasant place, it will be very difficult. And these are the 4 things with the help of which we can make our mind a pleasant place. And I'll stop my presentation by saying, Om Sarve Bhavantu Sukhina, Sarve Santu Niramaya, Ma Kaschit Dukh Bhav Bhavet, Om Shanti Shanti Shanti. Thank you very much.
Thank you, Mr. Sibyl. I think this presentation exemplified the power of innovation. We talk about frugal innovation, but if you saw or looked at the device which they had made for TB eradication, to take this power of technology to the most unreached people, I think that was absolutely fascinating, as was the Neura centers with which I think all of us are familiar. So it just shows you that when the innovation is contextual and satisfies a felt need, then the uptake is also good, and it actually manages to achieve what it set out to do. So thank you very much for that. I think we've come to the end of the speakers' sessions. We have time for a few questions. So if anybody in the audience would like to ask any questions. Has anybody put up a hand? We can't see them because the lights are bright. Okay, if there are no questions, then it is my pleasant duty to thank the speakers for sharing their insights and thanking the audience for their...
Just one message out of this wonderful presentation of the technological advancement. In the context of this International Patient Safety Conference, I think the industry should come forward to train the students and nurses in their formative years without much expectations, because more better you train them, more better your technology will be adapted, and more safer the practice will be. And I'm an admirer of AI, but we must understand that many of the issues which are not going to get addressed by AI so soon. Let us take an example of empathy. Empathy is it's a sense of feeling how the machines are going to utilize that sense of feeling, although some of the masters are saying that at some stage we'll achieve it. So that's why I again reiterate the humanizing of the medical practices while we advance in innovations and discovery. That is what my summary is. Thank you.
Very good point. Thank you, Dr. Abhijat. And with that, we come to the end of the session. Thank you.
I would request everybody to come forward for a picture, please. The bingo words, quickly, I'll announce. The 3 bingo words to be striked off: technology, teamwork, leadership. Please take out your bingo cards. As the picture is getting clicked here on the stage, I would request you to mark the words there on your bingo cards: technology, teamwork, leadership.
Thank you, Anjali.
Also, there is a reminder that we have a mindful session on by Sister Shivani at 4:30 p.m. So kindly be available in the same hall, followed by the presence of Honorable External Ministers of India, Dr. S. Jaishankar. So it's a reminder for everybody to be here by 4:30 p.m. in order to join both the sessions with us.
Thank you so much, Anjali. And we moving forward to the next session, the top gear, speed, precision, and power. And welcome to another inspiring, innovative session titled, as I mentioned now, the top gear, speed, precision, and power in healthcare. We are thrilled to have you join us to explore this dynamic intersection of rapid advancement, meticulous accuracy, and robust innovation that are revolutionizing patient care. For taking this particular session forward, I am glad to invite Mr. Gaurav Loria, Senior Vice President, Head Operations, Apollo Hospitals, to join us. May I request you to please join the dais, sir? Mr. Loria's exemplary leadership and commitment to excellence have been instrumental in driving forward the quality initiatives and operational efficiency of Apollo Hospitals. A big round of applause for Mr. Gaurav Loria.
I take the opportunity to invite our respected speakers on the stage. The first speaker for the session, Dr. Giridhar Gyani, Director General AHPI. May I please request you to join the stage, sir? Dr. Gyani has been conferred with 16th Lal C. Verman Award in 2002 in recognition with distinguished contribution in the field of standardization, precision measurement, and quality control. One of the prominent industry magazines, SME World, in its cover story of June 2012, described Dr. Gyani as Quality Man of India. Once again, I would like to welcome you here on the stage, sir. Our second speaker for the day, Dr. Lalu Joseph, Quality Manager, and Associate GS CMC Vellore, Secretary General, CAHO. May I please request you to join the stage, ma'am? She is experienced in healthcare quality and patient safety, professional with rich experience of implementation at the largest hospital in the country, accredited by NABH. She is in the program director for many training programs in healthcare and a trainer. She is passionate about spreading the wave of quality, patient safety, and accreditation.
And we have speaker 3 joining the other speakers is Dr. Manish Mattu, Chief Executive Officer, Karnataka and Central Region, Apollo Hospital. May I please request him to please join the other dignitaries. Well-rounded healthcare business leader having significant experience in leading large hospital businesses with focus on building high-performance teams, setting up new hospitals and specialities.
It will not, don't
Welcome,
worry.
sir. And we also have one more speaker joining them. It is Dr. Mradul Kaushik, Senior Director, Operations and Planning and Chief Operating Officer of Cluster 1, Max Healthcare. May I please request you to join the... May I please request Mr. Gaurav Loria to take the sessions forward, sir?
Hello. So good afternoon, everybody. I do understand we are between lunch and the session kind of a thing. So we will try to make sure that we finish it on time. But I promise you this is going to be an interesting session. This is the third edition of the session that we are doing it. Obviously, the third one is happening today at this conference. This session is about the top gear, about the people who are on the top, but there are things about them which you may not know or which you may want to know or which may be surprising at times. Just to go down their memory lanes, just to go down their learnings, their experiences, and what we can take it from them. So for today's session, I do have very interesting people on the panel. Dr. Girdhar Gyani, I think everybody knows him. I don't have to give introductions actually to any one of these three panelists who are here, Dr. Lalu Joseph and Dr. Manish Mattu. So we will start with Dr. Girdhar Gyani, but before that, our team actually worked really hard to, talk to some people, also find out some of your history, your education. So they did some research, and I would request my team to please play the video that we have prepared for Dr. Gyani, and then we will get into some of the questions for him.
To reveal your code, then upload it on the app to rack up points.
See there.
Dr. Girdhar Gyani is a visionary leader who has transformed the healthcare delivery in our country by his deep dedication to promote quality and accreditation. He is now working for many more problems which are plaguing the hospitals through his organization of AHPI. We are extremely proud of Dr. Girdhar Gyani being the patron of CAHO, Consortium of Accredited Healthcare Organizations, and he is the guiding light for us to continue our journey of continuous quality improvement and help developing the culture of safety in the hospitals. I find Dr. Girdhar Gyani to be an extraordinary personality, and I find the most remarkable thing with him is his humility.
I'm Dr. Samina Zamindar from Zamindar's Microsurgical Eye Center, Bangalore. There are these two people in quality in healthcare without whom I cannot imagine how the healthcare scenario would be in India today. The first is Dr. Girdhar Gyani sir. He's also fondly known as the father of quality in healthcare in India. And second is Dr. Lalu Joseph, madam, who is the Secretary General of CAHO. Both of them have highly influenced the way I think about quality and patient safety. They've broken a lot of myths about the so-called quality, and their clarity in thoughts about what quality means and what is the patient's perspective about quality, and why leaders in healthcare should, along with working inside the hospital, they should have dedicated time to work on the hospitals and take care of the smaller details. It's about time that clinicians become quality leaders. I congratulate both Dr. Lalu and Girdhar Gyani sir for doing such fabulous work in quality in healthcare, and I find myself terribly lucky that I've got a chance to know them and learn from them. Thank you very much.
Please have a round of applause for both of them. So I think rightly termed as father of probably Indian quality in healthcare. So my first question to you is, which is tougher, managing defense systems or hospital administration, considering your background in DRDO? Can we have the slides? Yes. From missiles to bedpans, what's been tougher for you?
You see, the first few batches of when we joined DRDO, we were trained to see the big picture. And I think our batch was the privilege to have been trained in Missouri, along with the IAS officers. And, we worked on it in greater detail. And later on, I was sent to UK for training on total quality management. And there, I don't know why, I picked up the healthcare as a specialization. They trained us on framework on quality, and where small portion, some of us took education, some of us took manufacturing, I took healthcare, and I came back. I didn't know that I will be later on working in the field of, but let me tell you one thing. In aeronautics, because I spent 10 years, each small part, let us say even micro switch of the aeroplane, is tested for the life. Endurance test, what we call. Some of you must be wondering, the life combat aircraft of India has taken 25 years from design, because each part is to be tested, let us say, for 3,500 flying hours. So it takes that much time. And after that, also you have seen that checklist is the main criteria in operations. Do we do that in healthcare? I think we have a long way to go. NABH has brought some degree of system working. But for example, pharmacy, for example, medical devices, refurbished equipment, and host of things, still we have to work. So if you have to compare the aeronautics, we always compare aeronautics and the healthcare. So I think healthcare still has to travel a lot to match the quality and reliability of the aeronautics. So I think I have that little privilege to have been trained first on aeronautics and then come to the healthcare.
I'm not sure if all of you sitting here actually knew that he had this kind of a training or an experience earlier, but thank you for sharing that, sir. And we are happy that you chose that as a profile, or as that at that point that you want to get into healthcare quality. So the next question is, you are called the quality man of India. Is the ISO stamp checked on your morning chai every day?
Actually, I know this tag was given to me in 2012. And if you really ask me, the first of task was when I joined Quality Council of India in 2003, was to set up the accreditation system for conformity assessment, what you call 9,000, 14,000 inspection or all that. I think I did that for 2-3 years, and then came the opportunity to establish NABH. And then an opportunity to have 2 meetings with Dr. Abdul Kalam in 2007. I tell you, that changed my whole perspective. Otherwise, I wouldn't have developed the system for environmental impact assessment, food safety, public services, and school education, let me tell you, and finally for the Gram Panchayat. When I did from 2007 to 2012, this magazine picked up that how can you do it, implement quality accreditation in such field, and they named me, I don't know, Quality Man of India. So.
But sir, you still didn't answer the question. Does your morning chai also has a quality stamp?
Of course, I prepare chai for myself for sure, and definitely, let me tell you openly, even for my own wife, I prepare my chai every day till today.
That's really sweet, sir. What keeps you more awake at night? Accreditation deadlines or retirement fund statements?
Oh, I think I am lucky once again that retirement doesn't come to my mind, even my dreams. Actually, my friends, some of them are sitting here, you and also my friends in that sense. The kind of motivation you have been giving me, it keeps me pushing and pushing to do more and more. And that's why I think retirement doesn't come to my mind. I thank my all people sitting here for that very purpose.
Thank you, sir. You have definitely had a very vast career in different fields, from engineering to DRDO to quality and now in healthcare. What's next? Is it like directing a Bollywood movie from surgical strikes or surgical sites?
I think seriously we should plan a movie on that. And but maybe I remember the film like Mother India. So I will cast her as a Nargis. And 2 of you have to be Rajendra Kumar and Sunil Dutt.
So the casting is done.
No, but really, what keeps me worrying, that when Dr. Abdul Kalam told me quality is for the national well-being. So we invited Veerappa Moily. That time he was the Minister of the Law. And he came in our conclave, spent half a day along with the Dean of the Police Academy from Hyderabad and one retired Supreme Court judge. And I think he announced after the lot of discussion that I'm going to introduce system in this country that within 3 years, no court case will remain in court for more than 3 years. And in next 6 months, he was transferred out of the law ministry. But if you ask me, our wish, all of the wish should be that legislation, executive, and judiciary, if we can make system like we have made for the healthcare, I think we will be a much better country. We have capabilities. My dream is that. Can that happen?
Interesting. If you had an unlimited power for one day, what's the first rule you would enforce for every hospital?
Oh, so you have seen the movie of Anil Kapoor.
Nayak,
Oh,
being
yeah,
the CM for a day.
I tell you, now with so much international exposure which we have now, I think first thing I will do is that our contribution to GDP should be 5%. I don't think less than 5% we can do anything on that sort. I think my second wish will be that I involve the local bodies in making the promotive and preventive healthcare. Third will be drastic transformation in the medical education, nursing education, and the allied healthcare, because they are the fundamental of reforms in the healthcare. So I think these three things I will try to bring in. And fourth, if you ask me, is that I would like to do a complete survey of the India once again. For example, I keep quoting that Kerala has got 3 beds per 1,000 population and Bihar has got 0.3 beds per 1,000 population. So if we do this survey once again, taking help of ISRO mapping, and then bring regulation, that the state now, private sector, should be incentivized to invest in those states so that to improve availability and, importantly, accessibility. So that will be my 4 or 5 priorities.
Thank you, sir. Very well said, and I think very, very critical points. He definitely deserves an applause for that. If you had to put your life's mantra on a hospital wall, what would that be? Not about washing hands or prevent patients from falling, but what would your mantra be that should be on a hospital's wall?
Okay. I think over the years, clinical quality has improved a lot in our country. Again, thanks to NAPH. But service quality, I'm seriously worrying. So my mantra, if I want to write, is healing hands. Maybe I will write compassionate hearts and empowered workforce. These 3 things will be my tagline.
That's great, sir. Actually, even we for this year at Apollo, we have kind of taken, last year actually, kindness as one mantra, and then we should kind of just focus on being kind to patients and to our staff members and to our doctors and to the community.
Kind,
so thank you for that, sir. One advice for the hospital CEOs who think quality is too expensive.
Oh, actually we have missed out one thing, that cost of poor quality. This subject is so straightforward. We have not transformed that into the healthcare. If we develop more case studies, maybe Kaho should be doing on that, and bring into the notice of the CEO, I think the message becomes so clear that you spend money on the prevention, appraisal, automatically, the losses will come down, reputation will go up. I think simple model has to be, we must educate people on cost of poor quality, and that will solve the problem.
I think very well said again, sir. You have been or you have seen NABH from first hospital to many other hospitals. What do you think is the biggest headache while launching NABH or going in for NABH?
I think Pawan is sitting here.
He's there.
I think we had a team of these 5 doctors along with Dr. Yashpal Bhatia. We were so enthusiastic that we have launched something international and people are going to rush for it. But we were so disappointed in the first year that, we decided to run around. Actually, we were going around country every week, 2 places. Pawan, myself, Bhatia, Gupta from Apollo. We were going around somehow, to sell the product, not market, sell the product. And somehow it was not working. But somehow I think because Pawan is also Fauji, so we didn't lose the mind, didn't lose the heart. we kept on persisting. But at the end of 1 year, we got 37 applications.
Wow.
I thought, okay, big number. But when we got accreditation, only 5 out of 37, and Abdul Kalam gave the awards. It provided boost to the country. Oh, President of India is giving award.
Yeah.
And later on, of course, CGHS came forward. And then, of course, the next year we got touch about 337 applications. I think it has been a journey. I think thanks to that team, which worked technical committee and accreditation committee, we brought, and I think today the cow is now taking it forward. So, but I think today NABH has made a huge impact on improving the patient safety. There is no doubt.
Thank you, sir. Speed or precision? What's more important in Indian healthcare?
Oh. You see, I can't say precision is not important, but if you really want to give edge, because I'm now working in HPI, I will give edge to the speed. I want to bring 3 beds per 1,000 population in our country. Precision will obviously follow.
So the man with speed. Thank you, sir. What's slower, getting a hospital accredited or getting a government policy approved?
Oh. I don't know, somehow, policy in 2017, which has been made, a good policy. It took years, of course, from 2015.
Right, sir.
But even if you want to make changes now, it will take longer time. Getting accreditation today, thanks to kind of awareness we have got, is much easier. But 2017 health policy needs to be now implemented, which we are now bothering. But overall answer is, accreditation is easier.
Thank you, sir, for that answer. One bold move you wish every Indian hospital would make tomorrow?
One bold?
Bold move.
Okay.
Every hospital would make tomorrow. What do you wish?
Okay. I think I will say each hospital first has to become a smart hospital. Actually, I used to tell 5 years back that if you do not become smart in tier 1 town, you will lose business. Now I think 2 years are already gone. So next 3 years, if you are not smart means complete digital, then you will not survive.
Right, sir. What's the future word for Indian healthcare? Technology, quality, or survival? Out of these 3.
I think there are 3 things: humanware, software, and hardware. I think let us not forget humanware. I think all of us must focus now on humanware, because ultimately they are going to drive technology, they are going to drive operation, and above all, the service quality. So in this order of preference: humanware, software, and hardware.
Thank you, sir. Very well said. How is AHPI working towards building a more patient-centric healthcare ecosystem in India, especially for smaller and rural hospitals?
Yeah. Actually, this is, I know this capacity building is our motto, although we lose a lot of time in wasting. Sometimes I call wasting time in advocacy, because government doing advocacy is such a difficult job. But recently, we started a project given by Quality Council of India, where they mentioned that let accredited hospitals drive quality in the smaller hospital. So we did in Gujarat at 4 places where accredited, no consultant, our accredited hospital invited each location from the tier 3 towns. And I think that is doing wonderfully well.
Sir, the last question. What policy changes do you believe are most urgent to improve patient safety and hospital governance across the country?
You see, my main emphasis to the government has been now, again the same thing, to bring availability 3 beds per 1,000 population, and accessibility, that means people can travel for tertiary care within 100 kilometers. That is the motive we are working, and we have submitted a paper that how do you make it happen. And I'm telling government, because they don't have money, you just incentivize private sector, they got huge money. But that incentivization has to be very bold. It should not be guarded. And that, I think, they have started now listening, including the things like co-payment. So those things we have submitted to government. Hopefully something will happen soon.
Thank you, sir, for all the great answers. Please, he deserves a great round of applause from all of you. Let's move to our next panelist here, the lady on the panel, Dr. Lalu Joseph, a great friend. So let's first see what our team has prepared for her.
Hi everyone. So Dr. Lalu Joseph, very befittingly known as the Queen of Quality or the Mother of Quality in India. Because of her, quality has a new meaning in healthcare across the country. We have so many people who have had the opportunity to learn more and to share and network more in the industry. If I can say something about Lalu, as I said, a wonderful human being, never shying away from responsibilities, never shying away from any kind of difficult situations, a know-it-all, a do-it-all, always, bold, but always with a smile. She watches over people to ensure that they are all well taken care of and everybody is happy. We are very proud of her and very proud to be associated with her.
I have the opportunity to work with her in various areas and institutions. NABH Secretary General for CAHO and also coordinator of the Technical Committee on Grading for the Quality Council of India. Dr. Lalu Joseph continues to champion quality implementations and accreditation processes nationwide and globally, shaping the future of healthcare excellence.
Dr. Lalu Joseph is known to me more than 12-13 years or so. One of the most energetic leader, one of the most intelligent at the same time strong-minded leader I have seen in her. Whatever CAHO is today is largely because of her work, her target-oriented effort, and at the same time, the way she is popular among the CAHO activists. That has made CAHO today whatever we are. Today, CAHO is not only restricted to this country, but it has been known beyond this country as well as many of the accreditation bodies.
These two people in quality in healthcare, without whom I cannot imagine how the healthcare scenario would be in India today. The first is Dr. Giridhar Gnani sir. He's also fondly known as the father of quality in healthcare in India. And second is Dr. Lalu Joseph, madam, who is the Secretary General of CAHO. They've broken a lot of myths about the so-called quality, and they have clarity in thoughts about what quality means and what is the patient's perspective about quality, and why leaders in healthcare should, along with working inside the hospital, they should have dedicated time to work on the hospitals. And I congratulate both Dr. Lalu and Giridhar Gnani sir for doing such fabulous work in quality in healthcare, and I find myself terribly lucky that I've got a chance to know them and learn from them.
Thank you so much. Let's have a round of applause for Dr. Lalu.
Thank you so much.
I think you already have so many admirers. This was actually supposed to be an 8-minute video that we had to cut it down to 3 minutes.
Thank you.
So you understand from there. She's also the lady who is very good at her one-liners. So I would hope that you would answer my questions quickly. Started as a mechanical engineer and now we are here. Which requires more fine-tuning, machines or medical protocols?
I think with machines you can do anything. Medical manpower, very difficult. I think the most important thing is fine-tuning medical manpower, which is extremely difficult. So have I answered your question?
You did.
Thank you. That's all of you.
Do you ever find yourself conducting home audits to ensuring everything is up to the standard at your home?
All the time. When I started my journey, my children and my husband almost threw me out. You know, you go looking at every single bit and piece that's lying around. I think I've matured now. So, yeah, I would say I'm better off today.
So
Maybe systems have got...
is it changed from daily to now, let's say weekly or quarterly?
Probably.
Okay, so that's probably the change. After countless accolades, including the ACHS International Medal, which award made you say, let's get a bigger shelf?
I think the time hasn't come as it. Maybe, Gaurav, when you give me the Lifetime Achievement Award...
Oh,
at
I'll give you
IVF,
really?
I would then say that. Thank you.
Between your roles at CMC, Vellore and Kaho, how do you find time to unwind? Any of the secret hobbies that we don't know?
No, if I say that, it's going to be...
No, but we should know.
All right. Every evening, I sit and watch all the Tamil serials in Hotstar. Just within 30 minutes, I watch 5 serials.
Okay.
And when there is Big Boss, I never miss it.
So, Big Boss fan. Great. From teaching in Toronto to leading in Vellore, which experience taught you more? Handling students or hospital staff?
Certainly hospital staff. Students, it's difficult, but at least manageable. Hospital staff, I think you really need that perseverance. My skin has become very thick. I was admitted in ICU and they just couldn't take the blood out. It's become very thick. So I think managing hospital staff is a difficult thing.
That was an interesting one. So you recently celebrated your golden milestone. I am putting this as a question because you put it on the Facebook. So it's not something that I was supposed to share or not supposed to share. But then I'm putting it back from the Kaho's team. So did the Kaho team surprise you with a quality certified cake?
They really surprised me, Gaurav. They put up a video and that went into LinkedIn and I thought, you know, after that I put up my video, by the way. So it went all over the place and they announced to the world I became 50 years young. So it's still not old, but they did one. They are an amazing group and I'm very, very proud of Kaho Secretariat.
That's interesting as well. What's tougher, achieving NABH accreditation or maintaining an accreditation?
People may have different views, but for me, coming from CMC Vellore, a 125-year-old organization, taking that organization for accreditation was the toughest. Starting from, the facility round that lasted about 1.5 hours to reach to the rooftop and finding a dead crow on top of the water tank, to the systems, processes, and the way we are monitoring 470 plus outcomes today, I think achieving that, getting there was the toughest one. Yes, of course, you now know how to break the code.
Interesting. How does your engineering background influence your approach to healthcare quality?
Yeah, that's a very interesting question. I think many people keep asking me that. To me, everything is systems, processes, and outcomes. So even if I'm doing an audit of APML or AML, it's all about the system, process, and outcome eventually. I think that mindset has really, really helped me. Engineers, by the way, are very smart people. Engineers can adapt to any environment, and that's...
So are you saying doctors are not smarter?
They are smarter. I just said we are smart people.
I was just fighting from the doctor, though I'm not a doctor, but I was just fighting on their behalf. And we have 2 sitting here, so...
No, we can adapt.
Okay, great. As an ISCO expert, what's one international practice you would like to import to Indian hospitals ASAP?
I think it should be the outcome monitoring and measurement. Though we do a lot of outcome measurements thanks to NABH, we've got mandatory indicators, but I think we have a lot of work to do there, and benchmarking ourselves to Indian hospitals, sharing our data, benchmarking to regional and international practices is the need of the hour, and that's something that I think we must adopt from the West.
Interesting. So I see that Kaho is like a factory now of training programs, and obviously you are also involved in crafting these multiple quality programs. Which one do you consider your magnum opus?
I would certainly say our advanced CPQH training program. That's where we started. The residential training program, which is now approved as the Health Sector Skill Council's first National Quality Assurance Manager training program. We kind of almost live with all the participants for about 4 days. And that's created the traction in the country. They are so committed to this journey of quality, patient safety, and accreditation. And they come with a lot of passion. So the 700 plus people across the country, 30% of whom are clinicians, are still part of us, so they come for every event. And I think I'm very, very proud of the Advanced CPQH training program. And recently, I developed a training program at CMC called the Fire Safety God Training Program. So to see the 20 kids who got trained in that, who are just 10th and plus 2 pass, they are appointed in many hospitals today as fire safety officers and guards. So that was a very, very proud moment. So I think there are 2 programs.
Interesting. What's the next big thing in healthcare quality you are most excited about?
There are several things. I think it's predominantly to do with technology and AI adoption. AI is certainly going to change the way we are going to be functioning in hospitals and also how we are going to be monitoring data. So there's a lot of learning and unlearning to be done. So I'm very, very excited to look into the opportunities with AI.
I think every person has been talking only about AI, and I guess all of us are excited about AI. Where can it make a difference, from actually your room controls, where you live, where you stay, to hospital controls, to controlling a curtain, to making sure that when the medication errors could potentially happen, or when the needle stick injuries could potentially happen. So I think, yes, a very important point that you brought out. If I may ask you the similar question that I asked sir about a few minutes later, if you had to put your life's mantra on a hospital wall, what would it say? Don't say keep calm, carry on.
I think there are 2 things. One, as a hospital, the mantra should be ethics, ethics, and ethics. I think that should be the focus on medical ethics, clinical ethics. I think that's the focus in my mind. Of course, we can talk about patient first, empathy, kindness, all that. And as a person, individuals, I think it's perseverance to whatever you are in your job or what you're committed to. So perseverance is the key, and healthcare is a very, very difficult sector to navigate, hospitals particularly, so perseverance is the key.
I think for all the freshers, students, and the newcomers to healthcare who are sitting here, I think this is a very, very important message for all of you to, move forward in life and be successful. How has CMC Vellore embedded a culture of quality and patient safety into their day-to-day hospital operations?
So I would certainly say it is the culture in CMC that whatever we do with the right intent. So even when it came to accreditation, thanks to Dr. Girdhar Gyani, he actually pushed us into accreditation, I must say. He in fact invited me for the assessor training program even before I had enough experience in healthcare. But when we started with this exercise, it was very, very difficult. 14,500 staff and 4,500 beds. But whatever we did with the right intent. And we never did anything for the sake of closing a non-compliance. And we never showed any data of zeros or hundreds. So that actually has created the culture. And all the department quality managers in CMC, 189 of them are middle-level faculty, and they are with us for 3 years. And today our boardroom is filled with all those who were department quality managers way back in 2010 and 12. So quality has actually kind of, it's within the system today. So I think the culture has, and we really went in like camels, slowly with the head, and today we are there inside the tent. So the culture has certainly come into the system, and I'm very, very proud of it.
I'm sure. Thank you so much for that. And my last question for you is, what role does training and capacity building play in improving patient safety, especially in resource-constrained settings?
Yeah, so let me take the context of India. So when Kaho is one of the best examples of actually setting up capacity building in the country. As Dr. Agarwal always says, NABH is there to accredit hospitals. But who would actually go in, find out what the hospitals need and build? 60,000, 70,000 hospitals in the country. Many of the larger hospitals have quality managers, people who are appointed for the purpose. So the whole idea is to actually build capacity in the country. And the way it has grown and the kind of response for the training programs across the country, people are joining today, thousands. So that clearly shows that upskilling is the need, and people are waiting for somebody to actually talk to them in Tier 2 and Tier 3 cities. So I think upskilling and capacity building is the norm, and we need 10, 15 Kahos to do that, along with HPA and all the not-for-profit societies that we have established. Long way to go, miles to go before we see.
Agree. Thank you so much for those candid answers. She really deserves a round of applause.
Thank you so much.
Thank you so much, Dr. Lalu. Let's move to our last panelist for this session, but not the least, definitely Dr. Manish Mattu. Again, a great friend. We work together at Apollo. He's one person who is always so approachable. He's not like, I mean, I'm not saying here, but they're not like many other CEOs who don't respond or who think what they think is right and, others don't know. But he's always been very approachable, very helpful. Keep making sure that quality, patient experience, safety is always at the forefront. So thank you always for doing that, Dr. Manish. Can we have an AV for Dr. Manish, please?
Namaste everyone. I'm Lekha Maria, Lead Operations at Apollo Hospitals, Bangalore. It's my honor to speak about Dr. Manish Mattu, CEO of Apollo Hospitals, Karnataka and Central Region. Dr. Manish's leadership is defined by his operational excellence, ability to transfer knowledge, encourage innovation, and lead by example. He fosters an environment where new ideas, technology and consulting management are not just welcome but actively encouraged. Under his exceptional leadership, we have seen tremendous growth both domestic and internationally, reaching new milestones in our business. The best thing about him is that he also ensures to take care of people who works with passion and deliver the best. As we all know, we work with a shared mission to prioritize patient safety by ensuring a perfect patient-centric ecosystem. What truly sets him apart is his ability to achieve highest standards of operational efficiency while inspiring his team to deliver excellence every time. His positive influence impacts all of us, creating a culture of growth, care, and achievement. We are fortunate to work under his guidance, and it's a privilege to be a part of this journey with him. Thank you.
Namaste, my name is Sophia from Housekeeping Department, Apollo Hospital, Bangalore. I take this moment to thank Manish sir for everything he does. I feel lucky to work with him. One thing I really admire about sir is his leadership quality. He knows how to guide and keeps us motivated. He makes us everyone feel heard and valued, which makes lots of difference. Thank you for being an amazing boss. I really appreciate his support and guidance given to our team.
Namaste, myself Vasudeva, Security Supervisor. I have had the privilege of observing our CEO Dr. Manish sir. Their commitment to maintaining the highest standard of safety and security of our premises. And I am grateful for the support and resource they provide to our security team. Please convey my appreciation to our CEO sir for their outstanding leadership and for making our hospital a great place to work. Thank you.
I think you would know more about him, or rather what he is exactly, when you have people like from housekeeping, security talking about what kind of a leader you are. I think that's really it's amazing, and I think he really deserves a round of applause from all of you, please.
Thank you.
So Dr. Manish, coming to a few questions for you. You have transitioned from being a doctor to kind of an administrator. What has been more challenging, diagnosing patients or diagnosing hospital operations?
So Gaurav, first of all, thank you for this opportunity. Really pleased to be here. But my only submission is that between the father of quality, the mother of quality, and the young leader, veteran of quality, I hope there's too much pressure on me. So I hope I'd get passing marks. But coming to a question, when I was an anesthetist, I just had to take care of the patient, the surgeon, my boss, and everything was fine, right? As a hospital administrator, right from the drug inspector to the parking vendor to the MLA, to the patient, of course, and so many stakeholders, it's far, far tougher. So no question about it. But it's tough, but at the same time, extremely gratifying. So ever since I made the transition to the administration, I think there's not been a single day that I've not enjoyed it thoroughly. So happy, very happy to be here in this space.
Thank you for that candid answer. You recently led a walkathon, I think on October 2nd, 2024, for breast cancer awareness. Did you clock the most steps that you took that day?
Unfortunately not. I was unwell and I couldn't join. But my usual step count is about 8,000 to 9,000 per day. But that day I was in bed, so it would have been probably 100 or 200, not more.
Between managing multiple hospitals and initiatives, how does Dr. Mattu relax on a Sunday?
Sunday. I
If
love
you get a
Sundays.
Sundays?
Yes, yes. I mean, I love Sundays, especially in Apollo. But squash is a stress buster for me. I love playing squash.
I heard scotch.
Yeah, occasionally that too. But mostly squash. My son, he's an angel. I try and soak in the sun as well. And of course, I'm a movie buff. I love watching movies. Like Dr. Lalu said, she watches TV a lot. Whenever there's an opportunity, I love catching a movie, an old one or a new one. So you ask me about a movie and I'll know most of the times if it's Hindi, I'll know more about it.
That's really great. Are you tech savvy in your personal life as well, or do you prefer a good old paperback over a tablet?
So I think I've compartmentalized how I use technology. At work, I would like to think I'm tech savvy. So whether it's Power BI, WhatsApp, and other data that's available, I try and use it as much as possible. But at home, I'm very old school. I try and stay away from screen as much as I can. If I possibly can, if I don't get calls, phones, texts and all. So that's how I like it to be.
Not so long ago, Apollo Hospitals performed a robotic mitral valve replacement in just 29 minutes. What's the next big tech leap we can expect?
So interesting question, Gaurav. I think we're at the cusp of a tech revolution. And that patient actually, was back on the golf course in about a week's time, which is, I think, remarkable, thanks to the fantastic skills of Dr. Satyaki and team. So I think on the tech side, I think the medtech piece of it will grow incrementally. We'll have more robots and all. But I think the next leap, at the cost of sounding repetitive, is going to come from AI, clinical decision support systems, clinical intelligence engines. So I think the software, is where the next leap is going to come from. And it'll be a challenge for us and an opportunity for us to see how we integrate that into health systems.
So you also implemented 5G-enabled ambulances. Did they truly transform your emergency care, or there are still bumps on the road?
I think technology, whether it's 4G, 5G, is an enabler. So every time we increase 1G, it definitely is helpful. But unless we change the bottlenecks on the ground, right? Paramedic availability, training of nurses, traffic issues and all, I don't think we can really transform. And the other challenge that we have is scale. We have 4 or 5 ambulances in, say, Banagata, for example. Unless we have at scale, then I think we can transform. So we're also limited by scale and the training issues and the operational issues, which don't allow the tech to give the outcome that it's supposed to.
Are you in favor of doctors consulting AI for second opinions?
I think that's going to be a question that we'll debate for a long time, all of us. No perfect answer. But in my opinion, personal opinion, anything that improves patient safety and outcome, I think is welcome. So definitely AI, when it aids the doctors, is definitely welcome. But we must realize that AI currently at least lacks the intuition or the experience, or doesn't think beyond, doesn't have the unique patient context that a doctor has. So as long as doctors are using it as an aid only, I think it's great. But I think current AI, of course, doesn't allow us much more than that.
Since you spoke so much about AI, what's easy to manage? Managing doctors or managing IT professionals?
I think the answer is obvious. Managing IT professionals is far easier any day. Manage doctors, of course, a couple of notches more difficult. But I think what's more difficult is managing doctors with technology.
Yeah, I guess.
So I think, and as it's a fast-changing landscape with robotics, with AI, EMR, I think going to be very prevalent. So I think it's going to be a very different animal that I don't think many of us have an answer to.
Agree much with you on this. you have been juggling with multiple hospitals. So what's your secret to keeping everything in sync?
The secret is to pretend that you have all the answers and hope that nobody's sensing the tension in your voice. But on a serious note, I think there's no alternative to being hands-on in operations and the way we are running hospitals. But at the same time, what I've learned over a period of time is to have a great support team, right? The admin team, the EA, and the works. Also being able to manage my time better, prioritize, initiatives, and over a period of time, I've become better at saying no to several things. So I think that's helped a lot.
Can you just very quickly talk about any one patient experience strategy or a process that you would have implemented?
So, in the last couple of months, I think we've been fortunate enough to, and I'll link it to the kindness score, which was started last year. We started two initiatives. One was a concept called Ward as a Unit, where we had cross-functional teams which had ownership of each ward. Instead of patients reaching out to nurses, medical services, housekeeping for issues, we had those cross-functional teams going to the doorstep of the patient and solving their issues immediately. That was quite transformative as far as patient experience was concerned. The other thing that we recently did was, not recently, I think several months back, was, we got this feedback that patients felt disconnected once they were discharged from the hospital. So we want to kind of continue that connect with them. So we started making post-discharge calls. It was done, from a centralized call center. And, the patients felt connected, whether, we could help them with appointments, a home physiotherapy session, and so on and so forth. It was really well appreciated. A lot of the old timers who came back to the hospital gave us that great feedback. So these two things, and hopefully that's reflecting in the kindness score, that I think is a great initiative and, is really a composite score of everything that we do for the patient. So kudos to you for that as well.
By the way, his unit was identified as the best unit for the this current year, the current financial year, very recently on 5th of February.
Thank you.
So congratulations again on that. If you had to put your leadership mantra on the hospital wall, what would that be?
My leadership mantra is lead by example, manage as a boss, listen as a friend, and execute like a maniac. That's my leadership mantra. But for a hospital, I think, if I have to put a mantra for the overall hospital, like, Dr. Gyani and Dr. Lalu said, it would be lead with empathy. I think that would be the key that we should have for everybody.
I think, yes, that's really an interesting one. As a CEO, how do you ensure that patient safety remains a top priority while driving business excellence and operational growth?
Very, very interesting and important question. Well, I think business growth and profitability are extremely important in today's world. So there is no running away from it. And I think there are many opportunities within the system. I don't think we are the most efficient system while we are the leaders, but there's a lot of work to be done there. So there's an opportunity to enhance profitability there. But when it comes to patient safety and quality, I think it starts with embedding that in the culture, right? People down the line, or everybody in the hospital should know that it's not just a tick in the box. It's actually at the heart of what we do every day, right? Second thing that, is important is leveraging data and technology, right? For example, patient monitoring systems today that we have. All our non-ICU beds today in the hospitals, and not just BG, but across Karnataka, are, aided by something like a DOSI or other systems that we have. So every patient is getting monitored 24/7. And that's brought down our adverse events by a big margin. So I think those are big enablers. Third thing that I personally do is talk to the front line a lot of time. We have this initiative called Care for Caregivers, where I, along with other vertical heads, we meet, the front line across verticals, and we try and understand what their concerns are. Once their concerns are heard and they feel heard and important, and we are able to solve their problems, day-to-day problems, not having 3 pairs of scrubs, not having a changing room, those issues, once they feel heard, they feel empowered, I think our patients are in safe hands. And the last but not the least is the fact of building a culture of accountability and transparency. Whether it's heeding to the safety reports, whether it's ensuring quality audits are done from time to time, whether it's taking feedback from clinicians, whether safety as we see it is actually being perceived on the ground or not. I think those things are very, very important and get appreciated by everybody, and also in the end help the patient.
Thank you so much. Last question for you. How do you motivate and align your teams across departments to work collectively towards a shared goal of patient safety, quality improvement?
It's not easy to be honest with you, but the fact is, especially in a diverse matrix organization like Apollo or any other healthcare system for that matter, but to say that, I mean, it's obvious that Apollo has done the best by far as far as any healthcare organization is concerned, as far as patient safety and quality is concerned, no question about it. As far as my teams are concerned, I think the important thing is not to impose that alignment on anybody, but actually have a shared, inspire people to have a shared mission, vision about patient safety and quality. And I personally do it by, trying to explain the whys to everybody. The old timers understand it, but people who are new in the organization have to understand why quality and patient safety is so important and why we must work together. The other is, and you'd agree that in hospitals, people tend to work in silos, right? So the important thing is to break the silos, build bridges, have shared goals, share metrics of performance, which are not, so quality is not to be driven by just quality and quality team, right? It's everybody's business, right? So have metrics where it's embedded in everybody's KRA, that quality patient care is everybody's goal. Second thing is to have joint task forces, right? I mentioned what is a unit. It's a great example of cross-functional teams coming together and working towards one goal, right? And we have, we have competition among these teams that whose ward performs the best every quarter in terms of patient experience and safety. So that's that helps. Third is, of course, have these interdepartmental huddles. We have the quality huddle, we have the VOC huddle, we have the what is a unit huddle. So those huddles definitely help. And it's also setting tone from the top, right? As if I regularly am part of tiered huddles or CQI meetings, then it sets the tone at the top. So that's very important as well. I think third thing is also, incentivize people who drive patient improvement initiatives on the ground and effectively drive them, right? Give them bigger responsibilities, rewards. I think it's very important to do that. Fourth thing I would say is empower people, right? Train them, retrain them, give them access to technology, like I had said, remote patient monitoring systems, right? So that they know that they have the skills as well as the resources to make a difference. It's important for the frontline to know that they can make a difference to the patient's life, because I feel 80% of our job gets done as far as safety and quality is concerned if the frontline feels empowered. And some of the feedback that you say is a reflection of that everybody feels it's my job to make the patient happy as well. I feel the day everybody in the hospital feels that every patient in the hospital is my relative, that's the day we'll be at 100%. We still have a long way to go, as Dr. Girdhar said. That's the key, if you ask me, to motivate people to feel that. And last but not the least, I think it's important that we keep on celebrating some milestones, these, that we achieve, like you said, make people a part of that celebration, but not ponder too much about failures, but learn from the failures and move away from blaming each other for any issues that might happen in the hospital.
I think very well said. Empathy, empowerment, really, one of the, or two of the most critical and important words that you said, and it's really very important. So thank you so much for your time. Thank you so much, all of you, for your time. Thanks to our panelists. Please give them a big round of applause for their candid answers and for being a part of this panel. Thank you.
I think I will say one thing. He didn't take any input from us. The kind of questions he has framed, 3 cheers for Gaurav.
Absolutely.
Not at all, sir. I would actually like to give this contribution of this completely to my colleague Nishant, who's sitting there at the back, because he really worked hard on it for this whole session. So thank you, Nishant, for that.
Sorry, one question I had for sir, if I'm allowed.
Please.
Sir, who's your most favorite healthcare leader and who's your most favorite actress? You mentioned Nargis, but you can...
Devanand used to be my favorite all the time, as an actor. But, healthcare, I think there are so many inspiration leaders, which I learned from them only, to be very frank. I don't know how to name, some of them are sitting here. But my inspiration leader, guru, is Abdul Kalam. Without that, I couldn't have done this,
Lovely.
Thank you so much. That was a lot in depth awareness of each one of you. So we would like to have a photograph and an autograph. Right, so can we also have your autographs, please? The cameraman will come to you to actually post in yours. So there we are getting a photograph and an autograph from the Dr. Giridhar Gyani. There we get the autograph. Moving on to Dr. Lalu Joseph with her autograph. And there we have Dr. Manish Mathu with his autograph. And of course, Mr. Gaurav Loria giving away the autograph to us too. Thank you so much. Thank you so much for the panelists and the delegates to be in here. As we transition to the next session, that is, we are breaking up for lunch, and the lunch was located at the exhibition hall 14A ground floor. Before you all leave, I do have very important informations. Two information. It's a kind reminder that you are requested to come back to the same hall by 4:30. You will be witnessing interesting talks with Sister Shivani and Honorable External Minister S. Jayashankar. Please return to the same hall at 2:30 is when the session starts, but the Sister Shivani's interesting session starts at 4:30. Please expecting you all to be back on time here at 2:30 for other interesting sessions.
Before you leave, we will quickly announce the bingo words, 2 sets of bingo words. Please stay back. People who are there with us playing this game, I would request you to strike off the words as we announce 2 sets of awards. 2 sets of words. Indeed, an award in return.
Exactly. You are going to be rewarded for all the bingo words you've been crossing off. The first word is medication safety. Medication safety. Followed by clinical governance. Clinical governance. Followed by patient rights. Followed by policies. Best practices. And training. The words for now for bingo crossover is medication safety, clinical governance, patient rights, policies, best practices, and training. Please enjoy your meal and expecting you guys to be back on sharp on dot at 2:30 to resume the session. Have a good meal.
Just one more thing for all of you before you leave. As Sulakshana said, please be here by 2:30. Do not forget to put your names in the lucky draw bowl at the IPSC stall. You may stand a chance, you definitely stand a chance to earn a MacBook. So please make sure you do drop that. Please look at all the activities. We will be giving away prizes later on that. Thank you.
Also, if you have finished your bingo card, please place the card in the boxes which are placed at IPSC counter. We will be picking one lucky draw coupon from it, announcing as a winner. If you have finished your bingo cards, please drop. We have one set of more words remaining to be announced. But if you have finished it, please drop the box. Please drop the coupons there at the IPSC counter, the box which is located there. Thank you.
Everyone deserves safe, reliable, and high-quality healthcare. ACHS International Accreditation recognises commitment to world-leading healthcare standards and continuous quality improvement, building trust with your patients and partners. The Australian Council on Healthcare Standards, ACHS, is Australia's largest, most trusted and experienced hospital and healthcare accreditation provider. At ACHS International, we're proud to share the standards of one of the world's best healthcare systems. Our services extend beyond accreditation. We're your trusted quality improvement partner. Gain unique access to ongoing support from top industry experts to stay at the forefront of innovation and deliver sustainable, quality, patient-centred care with confidence. Our distinctive partnership approach includes bespoke quality improvement programs, connection and shared insights with a global network, unparalleled benchmarking of performance and outcomes globally, increased staff competencies through exceptional education and training, and international recognition for dedication to excellence. We are committed to identifying and implementing continuous quality improvement, tailored to your needs. Join our global network and showcase your commitment to excellence in healthcare. Partner with ACHS International.
The Apollo Enhanced Connected Care project has redefined patient care by leveraging AI-enabled remote monitoring to save lives at scale. The impact of this project has been remarkable.
The ECC project has led to an 80% reduction in code blue incidents and actually about 23% fewer ICU transfers, ensuring better patient outcomes. We looked at how can we reduce the nursing times, and Dozy came in as like a savior at that point of time. So with this particular project, we could bridge the gap between non-ICU and ICU level monitoring. We do have centralized command centers in Chennai and Hyderabad. Our medical teams can monitor patients across multiple hospitals.
Patients in high dependency area and patients who are in intensive care, they get monitored 24 hours, 24/7. Same thinking has not been applied to the patients in the ward who might be vulnerable. Hence, we thought that if they were to be monitored continuously, we would be able to pick up deterioration much earlier.
We started with a single hospital pilot and the results were clear. Early detection led to significantly better clinical outcomes and reduced the workload for nurses. Within months, the project expanded rapidly. Today, ECC is operational across 31 Apollo hospitals, covering 1,800 non-critical care beds, making it India's largest remote monitoring initiative. Dozy, as a key partner, played a pivotal role in helping implement this initiative at scale.
We also conducted a study and mapped to some extent some of the parameters. We actually presented the same study at ISQA conference last year. This project has resulted in about 80% lesser code blue incidents, obviously fewer ICU admissions, and improved patient survival rates. About 1949 life-saving alerts for the timeline that we looked at this project for, enabling timely interventions. About 70% reduction in nurse workload. It did help in 26% cost reduction in hospital ward operations, optimizing how do we utilize our resources effectively. Our vision is to expand this model across all of our units, driving into a new era of AI-enabled, proactive healthcare that saves lives at scale.
We found that we were not only picking up deterioration much early, but also Our code blue calls, which is the emergency calls in some of the hospitals, came down to 0. But also we found that our readmission rate, so patients who left ICU went back to ward, many of them come back to ICU because things get deteriorate in the wards. That rate of readmission reduced significantly. So that gave us the confidence that this is the right way to go. We started this as a pilot. We have implemented it in our system, and we made our safe care even safer.
Of our minds, fears lurk. For some, it's the fear of closed spaces. What if there is a solution? Introducing Fujifilm's Open MRI, breaking the chains of claustrophobia. The open design accommodates everyone, from the littlest to the strongest, because everyone deserves care without compromise. Inclusive healthcare that knows no bounds.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
Hear the warm melodies of family gathered around. Baby's very first word, making mama proud. All the things that seem to make us grow, and all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come. Winter makes the summer shine brighter. Spring and the fall make the colors lighter. Looking forward to whatever may come, knowing full well that all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come. Open up our eyes and see the sunrise. Yeah, the best is yet to come. Eyes and see the sun. It's been great, but the best is yet to come. It's been so great, but the best is yet to come.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
It's been ages since I've seen Ma smile like that. Thanks to these two incredible women, Parvati and Ipshitadi. They rise every morning, embarking on a mission that brings smiles to countless faces. They go door to door, spreading awareness. Setting up camps and educating about breast cancer. It was then we understood the root of mass pain. Didi advised us to visit a diagnostic center for a mammography. We met Polumidi, the compassionate soul who supports the mission with technology. The process was comfortable thanks to Fujifilm's mammography equipment. The mammogram revealed a lump. Dr. Sholkar assured us that there's no need to fear and advised us for treatment. Thanks to Fujifilm's outreach campaign, early detection led to early treatment. Inspired by Fujifilm's initiative, we also joined their mission to bring hope and smiles.
For 175 years, Pfizer has been discovering, developing, and delivering breakthroughs that change patients' lives. Our first breakthrough in 1849 was a groundbreaking way to treat parasites. Years later, we delivered life-saving supplies to the Union Army. We continued on to become the world's largest producer of the miracle drug penicillin during World War II.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine and invented a needle that would be a key tool in eradicating smallpox.
The disease has been wiped off the face of the earth.
From discovering innovative therapies to treat heart disease and breast cancer, to delivering the first mRNA vaccine against COVID-19, Pfizer has changed the course of history. The world has changed a lot over the last 175 years, but one thing that has not changed is our commitment to our patients, the center of everything we do. To date, we've reached billions of patients with our medicines and vaccines, and we're just getting started. Expanding the limits of science, harnessing unprecedented technologies and groundbreaking therapies. And through our heightened focus on oncology, Pfizer is driven to become a world leader in the fight against cancer. And together with our patients, advocates, partners, and colleagues, we are determined to outdo yesterday.
There's a world of innovation in every medication from Pfizer. For more than 170 years, Pfizer has demonstrated its high standards for clinical and manufacturing excellence in a wide range of therapeutic categories. We currently offer patients one of the industry's largest and most diverse portfolios of anti-infectives, more than 80 medicines, including therapies that help address areas of greatest unmet medical need, such as the treatment of gram-negative bacterial and invasive fungal infections. In 2022, Pfizer manufactured more than 150 million doses of antibacterial and antifungal medications. Driven by a passion for safety and quality, Pfizer adheres to rigorous manufacturing practices for all products, including IV anti-infectives. High-quality IV anti-infectives begin with high-quality raw materials. Our dedicated team ensures our suppliers meet Pfizer's highest standards. Every Pfizer product is thoroughly tested and analyzed to meet or exceed local requirements during manufacturing. During the manufacturing process of IV anti-infectives, key control points are continuously monitored, including air and water supplies, ensuring that every step of the production process is tightly controlled. Pfizer expert teams continuously work to ensure the safety of our products. Our sterile injectable products, including IV anti-infectives, have been produced under these high standards. Pfizer is committed to responsible manufacturing practices that minimize impact to human health and the environment. We are driven to achieving the voluntary net zero standard for greenhouse gas emissions by 2040. We also significantly reduce hazardous waste generation in some of our largest manufacturing facilities through efforts such as decreasing water withdrawal. We are proud to celebrate a decade of green chemistry leadership. Why do we hold ourselves to such high standards? Because we know that people around the world rely on Pfizer medications no matter where they live. For more than 170 years, many things have changed, but one thing remains the same. You can always trust Pfizer to provide patients with the quality medications they deserve. Thank you for watching this video.
Portso plays a huge role in determining the ease of operations within any hospital.
Hello everyone, I'm Dr. Tausif Tangalwadi, Vice President of Operations and Medical Director at Red Health, and I'm proud to be a part of the International Patient Safety Conference this year. As an emergency physician, I know firsthand how critical, timely and effective interventions are in saving lives. Patient safety isn't just about protocols. It is about rapid response, seamless coordination and leveraging technology to ensure that every second counts in an emergency. At the IPSC, I look forward to discussing how innovation in emergency medical services can bridge critical gaps, enhance clinical outcomes, and ultimately build a more resilient healthcare ecosystem. I look forward to meeting global experts, exchanging insights, and working together towards a more safer and effective solution to emergency care. See you at the IPSC.
Let's talk nanotechnology, the heart of Thermaisan's fabric. At its core, Thermaisan's fabric is powered by nanotechnology. By engineering materials at the atomic and molecular levels, we've developed a textile that's not only stronger, but smarter. Nanomaterials are embedded directly into its fibers, giving us an unmatched degree of control over the fabric's performance, durability, and adaptability. This is a textile that has been optimized at the molecular level to resist wear and tear, to stay light yet incredibly strong, and to respond to changes in its environment. 3 ways nanotech enhances our fabric. Antimicrobial protection. Our fabric also integrates advanced antimicrobial properties that actively protect the wearer by disrupting pathogens on contact, with effectiveness lasting through over 100 laundering cycles. Smart response to temperature and moisture. What truly sets this fabric apart is its dynamic behavior. Nanotechnology allows it to respond to its environment, whether it's regulating temperature, managing moisture, or adjusting to changes in humidity. It's a fabric that doesn't just sit there. It interacts with the wearer, working to maintain their comfort at all times. Durability. With nanomaterials embedded into the textile, we've enhanced the tensile strength of each fiber without adding unnecessary weight. This gives us a fabric that's incredibly resilient, holding up through countless uses without compromising on comfort or flexibility. Field testing and real-world performance. Thermaisan's fabrics have undergone rigorous testing in diverse environmental conditions. They consistently perform, maintaining antimicrobial and thermoregulation efficacy in extreme environments, making them ideal for high-demand industries.
May I have your attention, please? Explore a wide range of resources and insightful information available in the exhibit area. Engage with cutting-edge research through the poster displays. Take a moment to review and gain valuable insights. To ensure a comfortable and distraction-free environment, please refrain from eating inside the session halls. Participate in our activities and contests throughout the conference for a chance to win exciting prizes. Don't miss out on the fun. Stay with us until the valedictory session. Prizes will be awarded, and we have special surprises in store for you. Engage with fellow attendees, share your insights, and be part of meaningful discussions. Let's make this conference interactive and memorable. May I have your attention, please? Welcome to the 12th International Patient Safety Conference. Please pay attention to these important instructions. Plan your agenda in advance to ensure you don't miss key sessions. All sessions will begin on time. Please be seated before the session starts. As a courtesy to our speakers and fellow delegates, keep your devices on silent and avoid any distractions. To participate in Q&A sessions and access exclusive content, download the conference app. Let's make this a valuable and enriching experience for all.
Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section, start collecting points, and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section, start collecting points, and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check scratch coupons. Section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app, and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code. Then
Good afternoon. Good afternoon, everyone. I hope you all are back after the lunch. Okay. The first session, post-lunch, we have on future-proofing patient safety in a new healthcare era. For this, we have two session chairs with us, followed by our esteemed speakers. May I have the honor to invite our session chairs first, followed by our speakers. The first session chair for the session is Mr. Arunesh Punetha, Regional CEO, Apollo Hospitals. May I please request you to join the stage, sir? Mr. Arunesh Punetha. Okay, welcome, sir, on the stage. A healthcare professional with over 30 years of experience in healthcare, over assignments that include P&L management, operations, and marketing in healthcare, with specific domain expertise in healthcare provider organizations. I welcome you, Mr. Arunesh, here on the stage. Along with him, we have another session chair for the... May I invite Dr. Surinder Singh Bhatia here on the stage, please? A big hand of applause. Mr. Surinder Singh Bhatia, Director, Medical Services, Apollo Multispeciality, Kolkata. We really are honored to have you here on the stage, sir. Please take your seats. Followed by, I'll invite the speakers for the session, Dr. Bhupendra Kumar Rana, Chief Executive Officer, Quality and Accreditation Institute. May I please request you to join the stage? He has many honors to his credit, including an appointment as ISCO expert. Because of his unparalleled mastery and knowledge, he took part in WHO's International Steering Committee for Patient Safety and served also as external consultant for World Health Organization, WHO, on setting hospital accreditation program. I welcome you here on the stage, sir. Can I have a big hand of applause as Dr. Bhupendra Kumar Rana joins the stage? May I have the privilege to introduce the next speaker to you all, Ms. Nadira Chaturvedi, Co-Chair, Patients for Patient Safety Foundation, PFPS. May I please request you to join the stage, ma'am? Instrumental in establishing auto-ancillary units with foreign collaborations. Additionally, she is the founder of Asim's Library, an NGO dedicated to operating inclusive libraries and creative learning centers for marginalized communities. Professor Chaturvedi has also been a professor of business studies at Fostama Business School in New Delhi for past 15 years. Ladies and gentlemen, please give a big hand of applause for all our panelists here. Now I would request the session chairs to please take forward the session. Thank you.
Namaste and a very good afternoon. I'd like to welcome everybody to the session on future-proofing patient safety in a new healthcare era. We've been having some exhilarating and exciting, incredibly insightful sessions in the International Healthcare Dialogue. And across all the three sessions all the three tracks that we've been a part of, there's been one common thread, which underlying thread, and that's been coming out again and again, and that's about having to be future ready. As healthcare leaders, how are we integrating and employing, strategies, for our systems to be future ready from a patient safety point of view, whether it be technology, whether it be risk management, whether it be supply chain or, any patient-centric approaches. What is it that we can do, say from future-proofing our processes to ensure that we avoid or prevent unintended patient harm? And I guess, a lot of this we'll be hearing from our esteemed panelists today. And we have Dr. Bhupender Kumar Rana, and we have Madam Professor Nadira Chaturvedi, both extremely eminent personalities who've been a part of this entire 2-day sessions, and I was just speaking to them. And I'm sure all of us will look forward to hearing them out today. You have you start first.
Okay, thank you so much. Thank you, Chair. May I have my presentation? Thank you, organizers, for having me here today. Thank you, all of you, after lunch, to join this session. I can see many of you. And, and I always believe in people who really care for subject to the speakers they are coming to listen. Whether they are 1 or 1,000, I don't mind. So people who are present here, whatever number they are, the most important people for us, which can drive change in healthcare quality and patient safety. So may I request for my presentation, please? So the topic is future-proofing of patient safety. The future-proofing actually in healthcare means how individuals and organizations can keep a pace with changing situations. And they always remain current and contextual. They are not getting obsolete. So that's what future-proofing is, and how this can be achieved. I will try to touch upon those things. May I take this? Yes. So I'm not going through, because the time is a constraint. QAI is a new accreditation body. It started off 2017, it's a very young baby, but rapidly growing organization, and having developed 18 sets of accreditation standards in the last 7 years, making us, I think, the only AB having developed so many standards in that much of time. We are nationally recognized by CGHS for empanelment as equivalent to NABH, and also internationally recognized by ISCOA, External Evaluation Association, as an accreditation organization. So we try to comply with whole care continuum of patient, including the standards for pre-hospital care, hospital care, and post-hospital care. We are emerging as a specialist accreditation body, and QI is one amongst 3 Indian healthcare accreditation bodies. So I'm not going to read each and one. This is our menu. We have 18 standards, 18 accreditation programs available, starting from a single doctor clinic to a tertiary care hospitals, ambulance care program, emergency medical services program, post-hospital, home care, telehealth, transition care, care homes. We have the standards. And we have specialized standards for stroke, dialysis, IVF, and so on and so forth. And the latest one is in the process at the moment is hematopoietic cellular transplantation, HCT, which is just on public consultation. Anybody can read from our website and put your comments forward. We have 150 organizations accredited. Thanks to all our partners who had a trust in us, in our programs to quality improvement and accreditation. And we are really thankful to Apollo Group of Hospitals having Apollo Fertility, Home Care, Apollo Hospital for Stroke, Emergency Department, Dialysis Program. They are clients. And you can see the bigger names there. They're all our clients for one or other accreditation programs. Coming to the topic, patient safety. And I picked this from, and Neelam knows very well, because she has been the leader for driving this change as Patient Safety Action Plan. The beautiful book on the right side, you can download from WHO website. It talks about a framework of patient safety, which comes through creating cultures, processes, procedures, behaviors, technologies, and environments to lower risk, enhance the occurrence, or reduce the occurrence of avoidable harms. And that's what important is. Those harms which are happening, they are avoidable, preventable. And that's why we should be starting thinking how we can reduce them. And if they occur, or likely to occur, how we can reduce the impact of those. So patient safety today and patient safety tomorrow, do you think there is a difference in that? What we think, what we perceive patient safety as today would be same tomorrow or day after tomorrow? Maybe I leave this question to you. But what future-proofing is talking about? You have systems, processes, technologies, devices, equipment, many, many things which you have in your organization. But when you change over a period of time, you still remain effective and relevant. And that is what future-proofing. You are not getting obsolete, but you have to keep a pace with that. So in other words, if I say usually what we believe in reactions, we are mostly reactive. We take correction. Something goes wrong, we correct it. That's it. So that we do corrections, which is very short-lived. What we should be doing is moving to the proactive approach, which is long-lived, long-lasting, which believes in prevention. It's not believing in something goes wrong and then you correct it, but you think about how you can prevent that things to happen and make changes, which are sustainable changes, to keep you effective and relevant too. So if you look at this picture, patient safety at the core, in the center, so it derives from the definition, the cultures, processes, procedures, environments, technologies. Are they interlinked? Are they going to make changes? Are they going to impact patient safety in time to come? So how can we do this when we talk about the future? So I say, can you try to see into the future? Can you look into the future? I see future many times when I draft standards. What does it mean? Perhaps we can't see in future, but we can imagine future. And that's what I put forward. So try to look into the future, that what may go wrong in my organization as a healthcare facility. Can patient sleep here? Can patient get electric shock here? Can patient fall here? Can patient get infection here? Can I have the financial problems? Can I have the resource problems? Maybe what may go wrong in my organization in next 3 years, 5 years, 10 years. It depends on how futuristic you are. And then look at what you can do in your processes, procedures, system, environments, and so on and so forth. These are just some of the list. If you look at this picture, I put how I see the future. I go to the risk management. I see, okay, these are my 15 future potential risks. Then I use the risk management methodology. What does it mean? I identify risk looking into the future. Okay, COVID-like pandemic may come in next 10 years. How I'm going to be ready with that? That's my potential risk. So I identify risks and then do the analysis of those risks. And based on those analyses, I frame my mitigation methodology. And that's about it. Is that all? Is that all? Yes or no? Is that all? No voice coming. Yes, no. No, that's not all. That's not all. You have to monitor on a continuous basis. You have to review your risk again and again. Is that all? What happened? You didn't have lunch? There was fantastic lunch. You must have good energy. It's not enough. You have to review again. You have to monitor and review. No, that's not all. You monitor and review. You have to do it again and again and again, because your risk might change. Risk might change. New risk may come. The old risks may go. So you will have these exercises again and again. Again, pick that from WHO report, not from WHO, from OECD 2022 report. How do hospital workers in OECD countries feel about patient safety culture? And if you were there in the morning debate session, there are a lot of cultures done. Lot of cultures, right? Bacterial culture, fungal culture. Unfortunately, at the wrong temperature, they were incubated. Bacteria were incubated at 22 degrees and fungal were incubated at 37 degrees. What will you get? Nothing on the plate. So that's what is culture. We have to believe in culture, practice it, imbibe it, feel it. Okay? So this says nothing goes more than 50%. 40% of hospital staff think staffing level is at their workplace is not appropriate for patient safety. 46% healthcare believe that important patient care information is transferred across hospital. 54% do not believe that. So if you look at this report, we have to go a long way. So I try to put some strategic objectives again from the Global Patient Safety Report 2024. These are 7 pillars, 7 strategies: policies to eliminate avoidable harm, high reliability systems, safety of clinical processes, patient family engagement, healthcare worker education skills and competence, and safety, information research management, and synergy, partnership, and solidarity. You can pick a risk associated with any of these 7 objectives. 7 strategies. You can try to find out what risk you can accompany with. I'm not going to read it, but again from the report it says nothing goes beyond 40%. Nothing goes beyond 40% is 4 years of patient safety action plan in place. 2021, 2030. 4 years gone, we have not even reached 50%. But if we continue growing like this, maybe in 10 years we may reach 80 to 90%. That's a good sign, but we have to work together and continuously basis we have to move forward. So moving forward in patient safety, you need to have adequate financial provisions, health workers' well-being and skilling, risk management, networking, advocacy, patient safety awareness, most important thing. Patient, staff, leadership, and community, all four verticals need to be aware of. How many of you know the International Patient Safety Day is celebrated every year? 17 September. I'm happy to see at least a couple of things. I get disappointed when I see there are 100 people, none of them knows about it. Awareness, we have a lot of work. All of you together, we have a lot of work to create this. Patient-centered design, continuous education, training, coordination with stakeholders, environmental sustainability. A big talk. Now, whatever standards are being devised now, we are putting a component of environmental sustainability to make a change. Integration of patient safety and quality. They are not two different things. People think quality and patient safety. I am doing quality, you do patient safety. That won't work. You have to walk together. So Rana Hospital is ISO certified. And ISO is not a correct statement. This is awareness. You will find many hospital websites ISO 9000 certified. No. ISO 9001 you have to say. ISO is not a certifying agency. They are a standard developing, but people use that. That's the lack of awareness. Phlebotomy practice. This is the example I always give for patient safety. You use a lot of alcohol rub to clean the place of phlebotomy when you are going to collect the blood from. And after changing the color of the skin to the red, you do a nice dab to feel. So you've done your job, irrespective. So this is awareness, what should be coming through. So finishing with the technology-based interventions, including AI and ML, everybody is talking about. We need to use technology, but manual intervention stays. They are not going away. Technology will help us. Patient safety to be addressed at individual level, institutional level, health system level, national level, and also international level. So there are different levels to provide accessible, affordable, safe care to people. And accreditation standard supports patient safety. That's the beautiful thing. They are the key drivers because power of accreditation standard is to make as enablers for desired changes. You won't change, standard make you change because standards keep revising to provide safer care. So accreditation standards are dynamic. They keep revising, reviewing, regular review, revision, imbibe changing healthcare systems, learn from experiences, what works, what doesn't, and support leadership to self-empower. Yes, I can go for this. I can decide this. I can choose this. So standards give them that opportunity. In the last, efforts towards ensuring patient safety should be considered as an investment and not as an expense. In your budget sheet, it should become on the first half page rather than the lower half page as an expense. Thank you very much, ladies and gentlemen, for giving me this opportunity. Thank you.
Thank you, Dr. Rana. That was very insightful. Thank you for sharing the framework for risk stratification. I think this is something that all of us are doing in our workplaces, but whether we're doing enough and how can we continuously evolve that. And I was yesterday, someone was in one of the sessions, there was one panelist who was saying that are we asking enough of whys? Is the present too fixated on the past? And probably that's where all of us as leaders need to constantly question our own processes. And I think somewhere you brought that out. Dr. Bhatia,
Yeah, I think well covered, but one important aspect which I feel these standards which are being made, we find that more and more patients would be going home early, and it is relevant that the home care standards need to be developed on priority, yes, but at the same time, those standards would require people who are using those standards, providing healthcare services at home, those need to be certified and classified in a manner that the people are setting up ICUs at home And because the future, I think, lies in definitely in home care to shorten the hospital stay. So I think that would be very relevant, sir. So anything that is being done, you have these standards?
So we have the standard. In fact, 2017, we started QAI. That is the first standard we developed for home care, and we got it accredited by ISCO as well. We were the first in the world to get ISCO accreditation for home care standards. And that continues, and that gives the power to the organizations to really deliver credible and quality care to the patient at home. And then we come out with the out-of-hospital care standard, transition care. Patient come out of the hospital, don't go home, stays in a place and look after, and then when they're fit, they go home. So that's why I said it's whole patient care continuum we're trying to cover. Thank you.
Thank you.
Professor Nadira, we request you to share your perspectives.
Good afternoon. Is this working? Could you all hear me? I couldn't hear you. Good afternoon. Thank you, first of all, for letting us in. I am not a doctor, and neither is anybody in my foundation a doctor. I represent Patients for Patient Safety Foundation, and I'm delighted and privileged to be in this hall with the leaders who started these two words called patient safety. Frankly, I did not know the meaning of patient safety or medical errors in that sense 3 years ago. Our organization is young, but I think learning, attending these conferences, learning from the experts, listening, and reflecting on our own probably 5 or 6 decades of caring and medical experiences has brought us to this point today. And I'm happy to share what we do, and I'm happy to provide a small suggestion for the future proofing. A lot of work has been done, and I've been listening since the morning, since yesterday. We heard Annie, we heard physiotherapy, we heard ambulance, we heard emergency care, the morning's debate on incident reporting. I mean, there's so much of strategy, top leadership, et cetera, et cetera, et cetera. There wasn't a single station, there wasn't a single session where we, the recipients of care, were panelists, except this one. So thank you for letting us into this session. And that is exactly the point that I'm trying to make. There was one interesting item that came up just, I think, 2 hours ago, and this was in emergency care and the changeover of a patient during a shift. The losses in, everybody knows, you lose electricity in transmission, so also you lose communication and information in transmissions, whether it's human or digital or anybody else. One suggestion was overlapping shifts. I love that statement, overlapping shifts. Now, traditionally, what did we do? We just looked after everybody, and that's what it was. There's a lot of work that has happened, but I want to ask you to close your eyes for just 10 seconds. Only 10 seconds. Don't go to sleep. I'm still here. And think back. Your best experience and your worst experience. When I mean a best, I mean safe, and I mean unsafe, because that's the parlance that we're talking about in these 2 days. Just think as a person, not as a provider. As a human being, as a husband, as a son, as a sister, as a mother, as a daughter. I don't want to hear it, but just keep it in your heart. And I'll come to that in just a few minutes. There's been a lot of progress. I don't mean to be negative at all. I mean, mortality rates going down, lifespans going up. Earlier, we just had one physician, one GP. He had that origami sheet on a bottle. This is your first dose, this is your second dose, and we were happy. One medicine cured all our ills. One ointment cured all our wounds and bruises. But the world has changed. The bacteria have changed. I think they're growing faster and developing much more than we are doing it. There's been talk of AIs and collective knowledge and learning and etc. And my compliments to Apollo Hospitals and the leaderships here for taking so much work, including NABH, to take this forward, including the global patient safety work. We learned a lot from that. All of you have done so much. Impressed, happy, relieved, and yet harm happens. We did not cook up this slide. We were shocked and surprised to see that so much harm is happening. Medication, wrong site surgery is patient identification, infection, dialysis, blood. I mean, you know it much more than us. I may have an anecdote, but you have tons of it. So who is the perpetrator? Why is it still happening? And when we honestly analyzed it, twice as much harm happens by us as a patient or a caregiver or a negligent family member than the healthcare providers. You're getting the flack of it for the last 2 days. You're getting interesting knowledge and strategy bites. But am I really doing my job? Am I only asking for my rights? Don't I have any responsibilities? Yes, I do. And that's where our foundation, and that's the future to me, to get me as a partner in your strategy, in your operations, in your education, in your empowerment, whatever the semantics, whatever your favorite word is. Because why? When they talked about the shift change, it struck me. What is the continuity? Who is the continuation factor? It's the family, it's the patient himself or herself. Imagine a ward, 4 patients, a cranky one, an acute one just wheeled in from surgery, a clued in one who's conscious, and a passive one. The nurse comes in, she doesn't know which one to attend. The clued in one, she educates, she engages, and that person takes over her job to look after the patient. Maybe there's more time, she also looks after another neighboring patient. So the nurse has time and focus on the person who needed the acute care. Medication errors came down because she shared something. What did she share? How do we go on? How do we make this better? That is the strategy I want to put forward. Just 2 simple ones. Better communication, better awareness. I think these 2 are lacking, will always lack. The more we grow, the more people we are overburdened, but we need to come back and focus on these 2. And when I mean 2-way communication, I mean it with empathy. People come in, they don't even tell us who they are. I later realized there's a cardiologist because I saw the bill, his fees in my bill. I mistook him for a technician, sorry. He may have been the best clinician, but he didn't speak to me, he didn't announce his name. I don't know why he came. He came for my betterment, I know that now, but I didn't know it then. A nurse comes in and she's talking in her local language, and I feel left out. Well, maybe she's talking about my medication or my blood or my urine, I don't know. But I feel left out. Simple things, a smile. 2 days ago, I was watching a K-drama. Simple. There's a hostess in a hotel. She gets the best prize for smiling. And they ask her, why did you get that? Why that fake smile? She said, no, in my heart, I wanted every guest to go back happy. The smile was a byproduct of that emotion. It wasn't the other way around. So it has to come from your heart. It has to be sustained. You have to live it through and feedback. Tell us, we will listen. Be bothered about our family. Educate us. Hear us, not just a tick in the box. A TikTok, white shirt, black suit comes. How are you, ma'am? All good? The nurse is trying to get my vein. She can't find it. My head is pounding. I need to go to the bathroom. My heart is hurting. I said, everything is fine, just get lost. That is not feedback. Feedback is when you really understand my problem and when you really explain to me what my problem is. So let's see how we can take that better. Is there any advantage? Yes, there's an advantage. An aware patient, an educated patient, or a family can contribute to patient safety and help you in your own KPI, in your own metrics of a hospital, of a department, of a section. And every one of us is responsible. Asking questions, bringing reports, being candid about not hiding that I have something wrong when I go to the bathroom, not hiding that I pass blood in my stool or my urine. We are afraid. We don't want to share it. We're ashamed at times. But if I really am being honest, then I think I can be a better provider and a better carer. So can it be better? Does it really happen? Yes. Where should I do it? So many places of education. A quick short story again, and it happened in Apollo, so I want to give 3 cheers to Apollo. This was on the 2nd day of my last chemo. I was used to it, my protein sandwich, my paneer sandwich, which I hate even today, because I had so much of it at that time. I settled down for that intravenous toxic chemotherapy cocktail. My daughter's with me in the room. And she settles down with her phone, and she's ordered the best of the chicken or fish, whatever. It's always a picnic in a hospital when it's the whole day long. And I settle down as well. Before I know it, actually I didn't know it. That's a wrong statement. I begin to perspire, I become red, I become to faint, and I start to lose consciousness. My daughter was not looking at her phone, she was looking at me. She pressed the bell immediately. The nurse came in, 101 doctors were attending a conference just like this. There was no doctor on call, no resident, no junior, no senior, nobody. But the nurse was sharp, she was trained. She brought some revival injection, which I came to know later. She revived me, my heartbeat came back, my pulse rate improved, and I'm standing here in front of you, talking about that incident, and loving that nurse. 3 cheers to her. But what went right? It was the engagement of the patient's family that the nurse did before she went out, before she settled me down. She had told my daughter, look out for these signs. Let me know if something goes wrong. My daughter was sharp enough. Don't take us for fools. We're not dumb. We're intelligent as well. We may not be doctors and nurses. I come from a 3-generation doctor family, but that doesn't make me a doctor either. But I'm caring. I love my person and my family, so I will be bothered. And that two-way engagement, that knowledge, that empowerment saved my life. There was a root cause, why did it happen, what had happened. But it doesn't matter to me. What matters is that that hospital saved my life. So how and when and what is the meaning of empowerment? More than that, why the education? It begins even, am I going back? Sorry. It begins even before I enter the hospital. It begins even before I come to your place. It begins even before I enter. And there's lots, wish I had something gone wrong. Anyway, so it begins right when my appointment is taken. Yesterday I came to this hall. Everybody knows there were security issues. We asked everywhere how to go up, how to go down. A nightmare. Today I came early, it was so simple. There were signages, but we're Indians. We don't look at the signages, we ask. And then we go wrong. Somebody says right, somebody says left, and we go right and we go left, or the other way around. So we need to know where the doctor is sitting. But usually he sat here, how come you change his room? What report should I bring? What test report should I carry? What symptoms? I don't even write down my symptoms. I hurry up and come to you. The test, why should I take that diagnostic test? You're just making money. It's a bad impression. But why an MRI? Why another CT scan? You just took my X-ray. I'm not going to take it. Okay, I've seen my report. It's fine. I'll just take a medicine. My chemist is great. He gives me medicines here. I self-medicate. And I'm back in the hospital, worse than ever. So at every touch point, and these touch points came in from a group of 80 doctors that CAHO had assembled in July last year to find out the different areas, points, touch points where harm happens by patients, where harm could happen by the providers. It was a great learning experience. We put it together. It's available on our website. And then we said, all right, let's make a simpler version of it. Let's have a checklist of before coming to the doctor. Let's have a checklist of what I as a patient, I as a family member should do. The right blue one tells me to ask questions, when to take a second opinion. If I don't understand, I need to find out. We are Indians, we sit quietly. God is great, the nurse is great, the doctor is great. Of course they're great, but you need to be there to ask for that greatness. A classic example, I come into the OPD hall, doctor, this is the problem, he looks at the computer, doesn't look at me. I go back, I forgot to ask him, I come back, barging in again, the next patient is already there, he's polite enough to answer me. I go back, I come back with my third question, and he's impolite enough to say, ma'am, come next time. So preparations begin at every stage. Harm happens at every stage, whether inside or outside hospitals. Inpatient, the lady comes, she smiles. I don't know what she's doing, but if she explains, I've already given you the example, it might help. Consent forms, discharge processes, a nightmare. I just signed the consent because I want to get treatment fast. I don't know what I'm signing up. I don't know whether it's chemo or whether it's something worse or just standing on a treadmill. Discharge, it happened to me. The nurse said, my husband was sick, very sick, and he was on a oral feeding. He couldn't eat, he couldn't drink, he couldn't swallow. So there was a tube, somebody calls it Ryle's tube, somebody calls it whatever you call it. Fortunately, I bought 2 G bags, I went home. I did not know the thickness of the fluid that can flow into that bag. It got stuck, it got stuck, it got stuck. I wasted 3 hours. He was nearly a readmission. It could have been fatal. I ended up just giving him protein powder, milk, because it was easier. So it's not the recipe, it's how you do it. A better experience? I'm going back. I'm worried about cooking at home. My son is waiting for me. This laundry piled up. The nurse is kind. She gives me 5 packages for 5 days, morning, noon, night. I do not know the meaning of BD, OD, TDS. I don't know that. I know morning, I know before breakfast. If I didn't know it, I can take it anytime. It's just medicine. Wherever I take it. I feel better, my fever goes down, I don't come back for a follow-up. So you need to tell me why I must come back for the follow-up, not just come back for the follow-up. And we are doing this a lot in our foundation, preparing the first metal, patient education material. It's available on the health library in all the languages. We made newsletters, we made text, nobody read. High literacy, we don't want to read. Pictures, yes, everybody saw. When they got interested, they went into the text. But now, after a year and a half, I think I'm happy, people are asking questions. Self-medication, same pharmacy, don't prescribe to somebody else. A lot of errors, I believe 50% errors are medication errors. And don't blame the doctor for it. First aid, emergency care. That golden hour, what you call the golden hour. Now there are hospitals which are equipped. I was loving the ambulance session. So well equipped. Progress is tremendous, but I don't know about it. Dr. Rana mentioned so many standards. I don't know about it. How do I practice it? How do I bring that concept and concretize it? And how do I imbibe it? I am responsible. I need to know as a caregiver, as a person who's really suffering. Teach me, I'll learn. Science, women's problems, they begin so early. So who should do it? This is what we can do, but who should do it? You see 3 people here. So all of us, the frontline workers, the clinical, the non-clinical, and the family, all of us are responsible. Not just people who are here in this conference, not just the delegates who are doctors and nurses or the policymakers. We are equally responsible. So teach us our rights, teach us our responsibilities, and that is exactly what we are propagating. You call it policy, you call it advocacy, I just call it simple education. I call it my health, my responsibility. My health is not only your responsibility, it's mine as well. So we are spreading awareness of early symptoms, preventive, protective. We do not give clinical advice, but we do tell you when to go to the doctor. We do tell you not to stop going to the doctor. And I think a lot of our friends, we've seen traction in this, and it's helping. You talked about family and patient engagement. Dr. Dhingra planned it. NABH has put it as a patient advisory council in, I didn't know this beautiful BFAST. It's great. Putting up this ice chart in the house. You're at work, your husband's at work, your children are at school, the maid is at home looking after the grandparents. Just a simple advanced information, which hospital to go for a heart, which hospital to go for just a diarrhea would help. I call it in case of emergency chart. So doing our homework in advance, before I end up in the hospital, we talked about home care. After I go back is what I really mean. So enlightening not just the rights, but the responsibilities on both the sides is helping as a partnership to reduce errors, and that's what it is. But can it only be left to people? 1 person, 2 persons? Is there a better way of doing it? Yes. Patient advisory councils came to us again from the Patient Safety Network, and it's also thanks to the Dr. Kochar, it's come into the 6th edition of NABH 5J. We've been pulling at it, pushing at it, and we've also made a step-by-step guide of how we can create one. It's not yet been created, but I heard Dr. Mathu talking about it in a different manner. There was huddles, there were interdepartmental. We're talking about inter, extra, everything. And celebration of successes, motivation of the frontline workers. We salute you. Please include us in your work. And thank you for being what you are. Thank you for caring for us and looking after us. We promise we'll do our job. Thank you.
Thank you, Ms. Nadira. I think it is a wonderful lecture. I think we heard Mr. Doug Bernard from Kaiser Permanent, which is a hospital chain in the United States. I think future proofing may not be very easy for any one of us, but the three most important things were that he spoke about. First was that the cognitive and the capability, competence of the doctors and the nursing and the healthcare staff. Second was patient and family education. And the third was, of course, development of post-hospital care, which was extremely important. I think these are top priorities to future-proof our systems. But yes, I think the family education, patient education is extremely important. We do get patients who do not comply to the medication, who do not agree on taking the proper care, who do not agree on consenting on critical treatment portions. So I think a large portion depends upon somebody to educate them. Thank you very much, ma'am. And I think future-proofing may not be easy, but definitely an attempt needs to be made there. Thank you. Anything, sir?
Thank you, Professor Nadira, for a wonderful account, patient and a caregiver's account, and also reminding us that patients can also be partners in care and not only being recipients of care. So I think that was very, very insightful. I think at the end of the day, like what you also mentioned, whether it's today or whether it was yesterday or tomorrow, the heart of everything that we do is the patient, and it begins and ends with the patient. We do everything that's very patient-centric. So thank you, everybody. I think
JCI gives a lot of importance to patient and family education. We at Apollo Calcutta are very keen that the patient and family education is given its due place.
See, just one question to everyone. Who develops the accreditation standards? Who develops accreditation standards? Anyone? Who develops accreditation standards? Of the stakeholders. People, this is an accreditation body job. Yes, we are the facilitator. You all are to be contributing towards the developing the standards. We put standards, almost every accreditation body put standards for public consultation, but very few people only comment. So you need to be part of the standard development process to give your feedback, what you are looking for, what you want in the standards. Otherwise, we become a group of technical experts who put their wisdom into it, not the collective wisdom which you all have. So I would request everyone to be part of the standard development process of any accreditation body giving opportunity. Thank you very much.
Thank you, Dr. B.K. Rana. Thank you, Dr. Ms. Nadira. Thank you, Arunesh. I think we'll close the session. Thank you all.
Thank you so much. That was Ms. Nadira Chaturvedi, Dr. B.K. Rana, Mr. Arunesh, and Dr. Bhatia. Thank you so much. There's a kind request to all the delegates here. Could you all please occupy the spaces which is in the front? A kind request to all the delegates who has been occupying the last rows, please come forward to the front rows. It's a kind, humble request. You're not even visible from here. It's a kind request to please come forward and occupy the front rows. It's a kind request on this side too, please. The delegates who's been seated at the last rows, please occupy the rows in the front. And the verticals here, the aisle here, please, it's a kind request, please come onto the forward rows. Hi. Thank you. And from that groundbreaking discussions on future-proofing healthcare to exploring cutting-edge innovation that truly matter, this conference has reinforced the importance of our shared commitment to making healthcare safer, smarter, and more resilient. And to talk about this, ladies and gentlemen, let me welcome Dr. Anupam Sibal, Group Medical Director, Apollo Hospital, to share his insights on Let's Talk Safety. Over to you, sir.
Good afternoon, everyone. What we're going to do is we're actually going to have a conversation. So it's not really going to be about a speech or a talk or a presentation, but we're actually going to have a meaningful dialogue. So we're going to have 4 or 5 ladies and gentlemen who are going to walk with microphones So I'm going to request you to chip in and comment as we go through actual cases. So we're going to go through with 2 cases. Could I have the first case, please? Mr. SM, a 52-year-old gentleman, admitted for an elective splenectomy for a mass in his spleen. Right? Happens all the time. 52-year-old for elective splenectomy. Site marking is done prior to the surgery, so it's important for me to get a sort of a sense of how many of us here belong to accredited hospitals. Right? So about most of us. So everybody does site marking, right? So site marking done a day prior to the surgery, as is the norm. All of us in accredited hospitals would do a timeout. So a timeout is performed. The surgical assistant led the timeout. The timeout has to be led by someone, so it's led by the surgical assistant. And the surgery happens. And this is what happens. So what do you think possibly explains the look here of the operating team, the scrub nurse? What do you think happened? Any guesses? Right? Could we have microphones, please? And they need to fan out. Yeah, anyone? Yeah, what do you think? Okay, give me one microphone as well. I'll burn some calories. Yeah, what do you think happened? Closer.
So possibly the site marking has been wrongly done?
So you think the site marking has been wrongly done? Anyone? Gauze. Okay, so you are talking about closure and finding disconnect, yeah?
They are touching all the other things, so the sterilization has been...
Okay, nice. But I think they're doing that because they can't believe what they're seeing.
I feel that the timeout was not done properly, so they don't know how to start.
No, I think they started. They started.
Sir?
Yeah.
Excuse me. I'm here, sir.
Where?
Here, sir. Upstairs, sir.
There we are. Go, you've got a mic, yeah.
It may done for wrong patient.
Wrong patient, yeah?
Yes.
Definitely a possibility. Wrong patient, yeah. Yeah.
Is there any the direction the spleen may be located in the opposite?
Sorry? So what you're saying is? The site may be wrong. And you are?
Dr. Raghu.
From?
From St. Peter's
There is a possibility there
One
is no
second.
spleen.
From St. Peter's?
Hospital.
And where is that?
It is in Tamil Nadu, near Bangalore.
Yeah. Okay, great. Anyone else with
Maybe
any?
the patient is post-status splenectomy. They can't see the spleen there.
Okay, possible. Yes, happens. Things happen.
Wrong site marking, sir.
Wrong site marking, right? Amazing. Such bright people. Anyone else?
It could be the wrong scan of the patient.
Wrong scan of the patient. Okay. So a lot of things can go wrong, right? And very interesting that we actually had someone who figured it out. The surgeon actually found the liver under the incision. Now, why would that happen? Why would that happen? You're operating, you're going in for the spleen, but you find the liver. Wrong site. I think everybody would normally know which side the spleen is on, so I think they would have got the incision right. Yes, as Doc from St. Peter's Hospital in Tamil Nadu guessed it right, what we have is a condition called situs inversus. So here the organs are on the opposite side. So the liver is going to be on the left side, the spleen is going to be on the right side, right? So that's why there's a huge degree of surprise on the faces of everyone in the OT. So let's put our hands together for Doc. So what went wrong, right? And please add on, but I think everybody would agree that there was a preoperative verification failure. Now, when they had reported that there was a mass in the spleen, they would definitely have said that, listen, the spleen is on the other side. But clearly, detailed imaging studies were not reviewed to confirm the location of the spleen, right? So basically, the pre-operative verification process did not go the way it should have. What else? Was there a problem with the timeout? Now, can anyone here tell me what is supposed to be a part of the timeout? What are the steps of a timeout? Or what are the ingredients of a timeout? Come on, everybody said accredited hospitals? Or was this only the night before the accreditation? Yeah. No, you've already got one.
So in timeout, they first decide who is going to do the first incision, how it's going to be performed, what will be the circulatory nurse's job, and who's going to close the incision, and all the details.
Okay, please, Neelam, you didn't hear that. She'll put it in the next JCI standards and all of us will lose it. What you described as standard operating process for the surgery, not the timeout. Neelam, you didn't hear that. Don't change the standards.
Sir, timeout should have imaging,
One second.
images displayed.
Right.
And, the right patient should be on the table.
Okay, what else?
We should discuss about the incision, the site
What about the
marking.
incision?
Site marking, sir.
Okay, what else?
Then surgical prophylaxis.
Okay.
Sir?
Yeah. Okay. Listen,
So
now
may
you go
I-
ahead. Yeah.
So along with these marks, any critical step which involves in surgery, it has to be explained, told by the surgeon.
Right.
So can I?
Yeah.
So
No, I have to take the mic away from you there.
Sir, name of surgery.
First, we will.
Yeah, just one sec.
In the timeout, whether the right patient is there, name of the patient along with the UHID number or unique identification number.
Yeah.
Then all the team members will introduce themselves. Then whether the position of the patient is right or not,
Yeah.
supine or prone.
Yeah.
Then whether the site marking has been done.
Right.
Whether the availability of implant is there.
Right.
Whether the images have been displayed.
Right.
Whether the antibiotic prophylaxis which is supposed to be given is done. Whether as per the JCI 8th edition, the regional, if
Neelam, note 8th edition, right? Okay.
So if the anesthesia is being given by the for the regional block, then the anesthetist also has to do the site marking. That should be there. If DVT pump is required, that should be there. And after doing the timeout, the time of timeout should be noted down, and the time of incision should be noted
Fantastic. And you
Sir, I
are-
want to add
one second,
two
one
more
second. We're coming there.
down. Sir, I am Dr. Shweta from Max Vishali.
Okay. And did you top your batch? Because, you went really by the book, by the standards, by the measurable elements and the intent. Fantastic. Very well done.
Sir, I am a quality manager.
Fantastic. You should have done medicine in addition.
Sir,
we
may
had
I-
someone saying something out there,
yes, sir.
right?
I want to add two more things.
Who was that?
Sir,
Oh, yeah, good.
Whether consent has been taken.
Yeah.
And anticipated blood loss.
Nice, very good. So, clearly the intent of the timeout is not lost, but it's a question of whether it's done or not. And one thing that nobody mentioned, who should be actually leading the timeout? The guy who's going to operate. And actually, this is a serious lapse on that person. He asked his assistant to do the timeout, and the medical legal responsibility actually rests with him or her, not the assistant. But nobody pointed that out, and it goes back to what we were discussing in the afternoon, that the higher up you are in the scheme of things, the more likely you are to get away with things that shouldn't be done. And see, it wasn't top of the mind for anyone. The fact that the poor person, the assistant, is really going to be held accountable when it's really not his or her responsibility. So how can this be prevented? How can this be prevented? Right? Anyone? How can this be prevented? Well, first of all, the site marking has to be done with due care in letter and spirit. It shouldn't be a random, do this at 10 o'clock at night, wake up a patient, somebody in the team, the junior most person does this, because that's where the problem starts. If the site marking had been done properly, this would not have happened. So the site marking needs to be done properly. Anything else on what can be done to prevent this from happening? Anyone? Right, definitely. But what is important is that everything that is meant to happen in a timeout should happen. Problems happen when corners are cut, when somebody is in a hurry. It's like the most famous surgeon coming and operating and someone else will do it for him. It's really when you do not do the timeout, and basically what we are trying to do in a timeout is very simple. You want the right patient to have the right procedure done. The patient has to be identified correctly. The procedure has to be right. Everything else that is needed for the procedure should be available, and it should be done with a team concept, with everyone in the team participating in it, whether it's anesthesia, whether it's the scrub nurse, whether it's the assistant, or whether it's the main surgeon. So moving on to case 2. Miss NR, 45-year-old lady, admitted for abdominal surgery, happens every day in every hospital. And she's given post-operative medication, right? So she's been given a prescription for morphine, 2 milligrams every 6 hours, and tramadol, 50 milligrams every 8 hours, right? Pretty standard based on what the pain protocol might be in that particular unit, in that particular hospital, depending on the risk stratification for pain management and all the assessments. Day 2, post-op, the nurse observed a decrease in oxygen saturation, and the patient became lethargic 5 minutes after administering morphine. Code orange was activated. Different units, different hospitals have different codes, but basically what it meant was that there's a deterioration, interventions needed. So the question is, what went wrong? Anyone? No, you've done your bit. Someone else. So what went wrong? The question is, what went wrong?
Probably because we used 2 medicine from that belongs to the same class. Both opioids.
Right, sure. Happens sometimes, you use more than one, but what do you think really went wrong? Okay. So the Dr. Fauziya believes that the orders were not correctly written, right? Okay. Oh, no, Sanjeev, you can't ask. Clinical pharmacologists can't answer this question. No, but try. Go ahead. Educate all of us, yes.
Probably,
coming there.
Probably nurse could not calculate 2 mg appropriately from that ampule.
Okay, so you believe there is a dosage issue.
Calculation
No,
error.
you've already done. Let's give others a chance. Yeah, go ahead. No, I know you haven't. A tongue fall, respiratory depression, sure. Anyone else? The nurse observed a problem after 1 injection, so she was quite clear on that. Given too fast, yeah?
Probably the PAC was not properly done.
You are an anesthetist.
Hello?
Right? Yes, because you keep bringing anesthesia up, right? Great to have an anesthetist here.
Sir?
Yeah. Where?
This side.
Code was wrong activated, sir.
Yeah, please go ahead.
Could be pulmonary embolism.
Could be pulmonary embolism. Okay, right. Yes. Anyone else?
Code was wrong activated, sir.
No, but why are you worried about the code? What code would you want to activate?
I think code blue, sir.
Code blue. Okay, you feel that the deterioration was... So, like I said, which code to call, what the codes are called varies from hospital to hospital. But at least they called someone. Yeah.
Maybe, as sir said, someone said dose was wrong and maybe double check was not done.
Okay.
Because high risk medicine.
Right.
So it may have been extra dose given or not diluted or faster administration like that.
Okay.
Maybe it was early warning sign for that patient because saturation was deteriorating.
Yeah, sure. Early warning, definitely.
Sir, post-administration monitoring of this morphine injection, it should have been done as per protocol, like half an hour early or 15 minutes.
It happened in 5 minutes. The patient deteriorated within 5 minutes. So we didn't get the time of 30 minutes,
sir.
right? Anyone else? Could be DVT. Yeah, I mean, what do you mean by ADR here? I mean, you've given morphine, right? And a patient goes down. So something's happened, right? Clearly related to morphine. And morphine, we know will sedate. We know it can cause respiratory depression. So I'm not sure we could call it an ADR because it's unexpected. You're using it. And it goes with it in terms of what it does in terms of pain control. Anyone else? Yes.
Hi, sir.
Yes, Vikrant. Anaphylactic reaction. Yes, Vikrant. Oh my God. Chronic pancreatitis. And how do you want to correlate this, please? Enlighten us. You can't give both the opioids. Okay,
opioid
pancreatitis.
analgesics.
Interesting. But why on earth would you operate on acute pancreatitis that's playing with fire anyway?
Sir, can I please answer?
Who's that? Where?
Yes, sir.
Yeah, please go ahead.
So actually, whenever we are giving morphine or tramadol, there is an important scale that is to be monitored, is pain scale.
Right.
And before giving any of the medication, it is very necessary to assess the pain first, and then accordingly the dosage should be given. And if that is not done, there are chances of overdose of any of the medication.
Sure.
So that
Yeah.
is one.
What do you want to say? Yeah.
Before starting next opioid or sedative, one should be stopped and assessed for the need.
But यहाँ तो सिर्फ morphine ही दी थी यार.
उसके बाद tramadol.
I mean the reaction happened after morphine.
So morphine is a high alert medication.
Yeah.
And before giving any high alert medication, there should be double check. And also there could be a lack of medicine reconciliation before giving the medicine.
How often do you do audits in your hospitals? When you're going around, people must be petrified. So the nurse actually realized that she was given 20 milligrams of morphine instead of 2. Happens. 2 was prescribed, 20 was given. So patient was transferred to the ICU for close monitoring, further management. Luckily, intervention at the right time, no harm in terms of medium or long term. So what really went wrong here? Inadequate verification. The nurse did not cross-check a prescription of this nature with another member of the team, which is really standard practice for high alert medication like narcotics. Everybody agrees? Okay, how many of you here are nurses? And how many doctors? And other than the 2 chartered accountants, how many of you here are from ops? Right? Okay, so we have very few administrators. Okay, nice mix of clinicians and administrators, right? And clearly there's an issue with staff training because, with narcotics, things can go wrong. So it shouldn't have happened that this injection was given in the dose that it was. So clearly an opportunity in terms of understanding the risks associated with a high-risk medication, pretty evident. Anyone here seen a case like this? All those who've seen deepening of sedation because of medication, please raise your hands. Right. So the others have either got excellent systems or have systems that ignore what can happen. Interesting. Anyone seen very serious side effects because of this, like needing to ventilate a patient or actually losing a patient? So why don't you tell us about that patient? You don't, it obviously has to be anonymous, but do tell us about that patient. What happened?
Yeah, actually, keeping the anonymity.
Yeah.
Patient was not operated, but taken for a procedure, and sedation was administered. A scopy was performed and sedation was administered during the scopy because patient was not cooperating, and but patient had muscular dystrophy. So patient came for scopy because had some esophageal and gastric problem, but proper history and examination and calling an anesthetist, something was definitely missed. And this I have experienced as a part of, not as a doctor, but I faced it as a patient's relative. So the patient had muscular dystrophy, so definitely respiratory muscles were weak and everything. This was not considered by surgeon because just came for scopy, like that.
How old was the patient?
60s.
And then what happened eventually?
Went into deeper sedation.
and then went on a ventilator and then couldn't come off the ventilator because of muscular dystrophy. For those who are not clinical, muscular dystrophy is a condition where you have to be super careful because these patients will never come off the ventilator. So really sad that came in for an endoscopy and ended up getting onto a ventilator, never to come off a ventilator. Really sad. Just goes to prove that one injection can do this. Thank you so much for sharing that. Anyone else wants to share any similar kind of case that they might have experienced so that there's learning for everyone else? Yeah, please.
What I'm going to share is not a story. What many a times we have experienced that once a person is on ventilator and getting a regular dose of intermittent sedation or pain medicine, sometimes the doctor will forget to stop it in writing. And for a new staff, she may continue giving it 1 or 2 doses. That has happened. So we should be very careful. We cannot take it for granted that everyone knows everything in the same level, the concept. So we have to be very careful doing small things. Thank you.
A great point, because sometimes everyone doesn't recognize the fact that you could have a trainee nurse who's first month on the job, or you could have a junior doctor who's never really looked after a patient like this, and you assume that everything's being looked at, but that is not always the case. And this also highlights the importance of really looking at a drug chart in great detail every day. So tell me honestly, how many people believe that in their hospital the drug chart is looked at adequately? How many people believe that the drug chart is looked at properly the way it should be every single day? Wow, not even 5%. Not even 5%. That's really, really alarming. Sanjeev, pharmacovigilance. We seriously need to look at that, because these are all accredited hospitals. And if they believe, and because this is anonymous and nobody's being named, they believe that they are not satisfied the way a drug chart's looked at, which means people spend fewer minutes than they should looking at it and do a superficial job. And that can really have disastrous consequences. Great learning there. Yeah, please.
This is a real story, just not to mention any hospital. I work for that hospital. One of the patients who actually was going home that day, CKD treated, then he was actually prescribed for hepatitis B vaccination, which comes as a Senvac, as a trade name.
Yeah.
And pharmacy dispense Senvac, which is a muscle relaxant. And it was administered, patient was actually ready to go home and administered just in front of us in daytime. And he, all of us, we know, he immediately had arrest. We have to shift him immediately to ICU by his sons, and team was very good actually. Code blue was announced, so patient was put on ventilator. After 2 days, he came back because it was muscle relaxant. And digging like we did, RCA of course, and then we found out dispensing error led to administration error. And we have to tell to the relative because they were absolutely not knowing about what was going on. So that's a real story, sir. This happens.
And a very sad story, but with a good ending. Thank you so much for that. And I think for all the pharmacologists here, I think we should put together a note of these medicines, look alike, sound alike. It is, the list of such medicines is absolutely huge. I mean, imagine a similarity between a muscle relaxant and a hepatitis B vaccine. Neelam.
Thank you, Anupam. So while we are discussing LASA, I just wanted to mention that WHO issued guidelines on localized sound-like medications very recently, just a couple of months back. So it will be good for everyone to search for those guidelines. And can I also share a story?
Please, please.
So this is a story of Louis Haskell, and I took permission from Helen Haskell to present this in another meeting. And this is her son, 15 years old, young, athletic, soccer player, musician, actor, went for elective surgery. And I was actually searching on the net, and it says that her life became before and after. for Louis. And so when he went for elective surgery, the surgery went okay, and he was given opioids as well as ketorolac. And because he was 15 years old and there was no pediatrics dose available, he was given adult dose. And because he was otherwise healthy, no special attention was given to him, and he actually bled to death and passed away. And so that's another, because we were sharing medication safety stories, and I thought this was really a heartbreaking story, which Helen has shared with the world on the web. You can search, and with her name and photographs, it is also published on WHO website. But this is something which should never, ever happen. Yeah. And also it brings to attention that we need to develop pediatrics doses for children and adolescents.
Absolutely.
Yeah. Thank you.
Thank you, Neelam, for sharing that. And again, really an eye-opener in how things can go horribly wrong. But while the World Health Organization will have the list on Lassa, they won't have possibly anticipated that you can actually have drugs so dissimilar. Imagine a muscle relaxant and a hepatitis B vaccine. The permission should never have been given for a license with that kind of a name. And I think this is an additional problem that we have, which I think we need to address. I think, Sanjeev, we really should address this. Do a search, and I think we should send this to the ministry in terms of, we really need to get this sorted, because this can have such devastating consequences and so unnecessary. Yes, Yatish.
So basically, since most of us feel like, we are all patient safety champions here, I thought of sharing it across. Reason because how much sometimes we put across everything to identify allergies. We put a ID band. I just give a real time story here. Thing is, a patient is allergic to NSAIDs. Patient has got, I take this story to tell all my residents every time. Thing is, since that's the reason I bring it up. He is allergic to no, and it has been referred by Sri his reference. And he has got a shoulder dislocation, got pain. At 8 o'clock in the evening, the doctor went to his dinner. The nurse called, he's having a lot of pain. So you just give him injection and is over on. That's what the nurse blindly went and given that. And all sort of whatever we call about communication, checks, allergy band, everything, nothing worked. And finally, a registrar who's next door, he came and he rescued the patient. That's what's happened at my place.
Yeah. And this is again failure on multiple levels. We have a policy in terms of, we have a policy on oral orders. We have a policy on communication. We have a policy on what to do and what not to do, and yet, this happens. And you had a band, so which means the nurse did not look at it. And what is pretty evident is that whenever things go wrong, it's usually not one thing. It's usually a systemic failure at multiple levels, because all of us pride ourselves in having a system where there are multiple levels to prevent harm. And quite often, multiple things go wrong, and that's when, you have an end result like you do.
Even the system alert was there, even the system alert is there. Patient has been captured as allergic to NSAIDs, and dispensing is not likely to happen at our hospitals, but still it's happening.
Yeah, right. Anyone else with, yes?
Hi, everybody. So this is a story happened with me. I'm a nurse by profession. So I was maybe 6 months old after finishing my course. So I was in a burns ward. So patient was prescribed for heparin. So, but then I went to the fridge. It was look-alike. So I took injection Actrapid. It was looking alike. I was thinking that I'm overconfident, so I just went to the medication preparation area, followed all the procedure, took 1 ml. That is 40 units I took. And I went to the patient. I was explaining that I'm going to give medication to you. That's when my senior staff found in the medication preparation area that I have taken an Actrapid at around, I think, 10 o'clock or 11 o'clock in the morning. She found that why an Actrapid is sitting in the medication preparation area at 10 o'clock. So that's when she found me. She just called me and said, come here. She didn't shout in front of patient, nothing. She called me and asked me, what are you loading? Then I said, I'm just going to give heparin. But then it was found that it's actrapid. So the teaching was given to me that I'm supposed to see while loading and while keeping it back also, I'm supposed to see the vial. So, which I missed. And since then, even while teaching to my students and everywhere, I quote this because it is my personal experience. So, training, yes, of course, but practicing and the attitude change of everybody should be inculcated. Patient safety should be within everybody.
Thank you so much for sharing that, and a great lesson there. One, that the way your senior dealt with you, and she didn't yell, she didn't make a spectacle, she didn't show power play. And that's why you are able to tell us this story, and you have used that teaching and used it for the benefit of other nurses. But I also want to ask you another question. If this had happened at 10 p.m. at night, what would have happened? Would you have been the only nurse at that time?
Yes, usually it is less staff during nights, and it would have been chaotic actually. And basically I was thinking the patient may not know, or even I wouldn't have known that it's because of actrapid only. I'll be thinking that I have given heparin and patient has gone into hypoglycemia. I wouldn't have even known. So thank God that it happened in the morning and it was a near miss event.
And this again highlights a very important point, which is that if you look at all the accreditation standards and medication management, they talk about uniformity around the clock. And in many, many hospitals, the staff is not at the same level in the evening and the night shifts. And quite often a pharmacologist is not available to look at appropriateness of the prescription, and mistakes happen. And this is where I think all of us need to ramp up, because when a family puts a patient in hospital, they believe that their patient is going to be looked after 24/7 with the same level of care. And actually, if the patients were shown staffing patterns, they would be really horrified to see that how thin the staff is on Sundays and holidays. And so therefore, and I'm not saying that you will be able to provide the same level of staff, but the care has to be similar. So that's where technology comes in, and you have to have a system where there should be an alert when you're dealing with medication like this. Anyone else with anything that they'd like to share in terms of medication or any other?
I'm Dr. Manisha Karmarkar. I'm an anesthetist by profession. We were doing a 90-year-old man for a TKR surgery. The surgery went on well and everything was fine. We put the patient on a syringe pump because I had personally done it under epidural anesthesia. So made a pump with 0.75 sensorcaine with fentanyl in the infusion pump, shifting him to the ICU because he was a 90-year-old man. I went to the ICU, I saw that all the connections were good. And prior to starting, I had put in a central line also for measuring the CVP because he had some cardiac problems. Fine, I went home. In the night, something must have gone wrong in the ICU, so they shifted his bed from one bed number to the other. So the sister in the ICU connected my epidural infusion to the central line. And next morning when I come, at around 8 o'clock, just to see how my patient is doing before I start my OT. I normally see my patients pre-operatively and post-operatively. So I just realized, I said, what is this? What is attached here? Because I had switched off the CVP line, and I saw that my syringe pump was attached to the central line. Luckily, there was no cardiac toxicity. My patient was absolutely fine, but we know that sensorcaine cannot be given intravenous, and at least I think 12 hours. Cardiac toxicity is one of the major complications, but I think luckily patient did well. But this was a major, major mistake on the part of the ICU.
In a 90-year-old hand of God, clearly, because this was a recipe for disaster. And I mean, seriously. And again, it goes back to the bed number. And that's why numbers should never be used in any sort of communication in a hospital. Bed numbers, room numbers, that is an absolute recipe for disaster. Anyone from this side?
Sir. Yes, sir.
Where?
Sir, here.
Oh, yeah. Please.
Sir, this is the real scenario of one of my hospital. We were working in a oncology unit, and we had one patient, 30-year young old boy, who was recently married 1 month back, and he suddenly happened to diagnose with Hodgkin's lymphoma, and he had to undergo treatment of ABVD regimen, where V stands for vinblastine injection 10 mg, which usually we give to the patient. But the nurse indented wrong vincristine. Again, it is a sound alike. So vincristine 10 mg, which is the maximum dose of 2 mg we supposed to give to the patient, but it was given in 10 mg. And next day patient was about to discharge, and suddenly that patient has to stay back. He developed intestinal obstruction and psychosis and ongoing other problems, and he had to be ventilated on mechanical ventilation, and finally that patient died, sir.
Really sad, but thank you so much for sharing this. And again goes to prove one mistake sometimes you can get away with it, like the 90-year-old. Sometimes you actually put the patient into a state of a chronic vegetative state, as in the case of muscular dystrophy. You never came off the ventilator. Sometimes you cause harm that might be short-term, and sometimes you can actually have a loss of life, all of which could be prevented. And it just goes to prove that how careful we all need to be every single day, because we don't quite often realize the power we have with interpreting a particular report, a particular prescription, and by doing something wrong, the harm that can ensue. Anyone else, as we come to the end of this session, anyone else with, yes, Mr. Shiv Kumar. Incidentally, Shiv is the managing director of Apollo Delhi and is a chartered accountant by training. So keep that in mind when you hear the question.
It's been a great session. I think we've been very frank, we've been truthful to ourselves, honest to ourselves, and that's a wonderful sign. And culture of safety is all about being honest with whatever mistakes that we make. But on a slightly more lighter note, hearing all these stories, I don't want accreditation agencies like Joint Commission International withdraw their privileges for our country. So I'm worried about that. So Anupam, do you have anything to say on that?
Yeah, absolutely. No worries on that. No worries at all, because JCI, or for that matter, any accreditation body talks about transparency, talks about a culture of safety, talks about being upfront, talks about speaking up, talks about not putting things under the carpet, talks about monitoring, talks about checklist reviews, talks about learning from mistakes, talks about RCA. So actually JCI is going to say what a transparent organization these guys have put together, and what wonderful clinicians and administrators and nurses that we have here who are willing to talk openly about how we can have a better health system. Yeah. Yes.
Hello, sir.
Sorry, we are here, then we are coming there, and then we will bring this to a close, right? We need to close. Yogmaya? Yep, okay.
Anupam ji, actually I am not a doctor. I run healthcare solutions company. I am Naveen Patel. I want to tell a success story that I have gone with the hospitals. That is Apollo Hospital, Jubilee Hills. Is a real story, happened with me in 16/1/2000. And road accident, I lost my father, and all family was in car and got multiple fracture and burns in the car. That patients have taken from that spot 100 kilometers far from Jubilee Hills, Apollo hospitals. Patients all shifted in the tempo, the people who were there surrounding. I was 26 years old, today I'm 52. Thing is, I have saved all the 5 patients, my mother, my elder brother, sister-in-law, my wife. My son was 1.5 years old. He was gone out with safe, he came out. The thing has happened, it burns ward was there in Apollo, Jubilee Hills. All the doctors, Jairam Chandrapingle was orthopedic surgeon, Dr. Swain, plastic surgeon, and from Neuropath, Alok Ranjan, that all have saved my family. The thing, still, I believe Apollo Hospital, Jubilee Hills. I do social service for that, and my son has done Master's Hospital Management from Jubilee Hills. Now he's working as in marketing division. Thank you. This is the life has made me. Apollo Jubilees. Thank you.
Thank you so much. And I think it's words like these that give energy to everyone in healthcare to work ceaselessly 24/7, 365. Last comment, then, of course, the final word to Air Marshal Pavan, and then we close. Please go ahead.
One thing I just want to add to it, this is about my niece. She was 3 years old. She had little fever. They took her to the hospital, and she was given antibiotics. After 2-3 hours, she developed Stephen Johnson's, and then she was admitted for around 12 days in the ICU. That small little 3-year-old girl. So I just want to understand that in general, in India, when we get admitted to any hospitals, drug allergy tests are not done. Doctors keep asking us, do you have any allergy? We say we don't know. So I don't know whether, I'm completely from a non-medical background, but is drug allergy test supposed to be done for every individual who enters the hospital?
Great point. I'm going to ask Sanjeev to answer this. SJS is a very tricky situation. You can't really predict who's going to get SJS. You can get SJS from paracetamol. You know, and that just goes to prove the level of gap that we have in the way we should be aware of things and that we are not. And I for certain believe that in 5 years from now, most of us would have had a whole genome sequencing done, and we will know what we should avoid and what we should have. Because honestly, other than that, it's pretty hit and trial. But Sanjeev, you're the expert.
Very right, sir. Probably right now, we consider paracetamol very safe drug. All of us consider. But I have seen severe anaphylaxis with oral paracetamol. So that doesn't mean that we test before paracetamol everyone. So probably it makes our life very difficult that every drug you test and then give. And there is no uniform. Even with test dose, you may have anaphylaxis with test dose also. So there is not clear-cut guidelines we are not able to make because of this throughout world. There are different views, different school of thoughts on that. Probably what sir is saying, genomic, and when we know how you'll react to those drugs, probably answer will for this question is in the future probably.
And in fact, if we go with traditional Indian wisdom, which is really think twice before you take any medication and see if you can manage without any medication, because honestly, there is no way of predicting how your body is going to respond to that medication. So think twice, don't just pop in a pill, go to a pharmacy and take an antibiotic because you have a sore throat, or for that matter, any medication. Pavan.
Sir, sorry, I have already received a mic, so just last
fine.
Sentence.
Yes.
Okay. So connecting all this discussion just to the morning debate, because everyone shared here so many incidents, including myself, both faced as a doctor and as patient side. But how many of those incidents were like reported? And if Kapoor sir is going to answer, and even Anupam sir. So what is about that? I mean, in the morning we had so much fun listening both of you, but then...
No, I think the crux of the matter is people are scared to report because they believe they'll be penalized, and quite often it's not their fault, and therefore there is a cultural shift that needs to come in. And we are seeing that, and there is a degree of openness that is coming about, but there is a long way to go. There is a long way to go because people are very worried about how they're going to be judged. A young student nurse, first month, how is she going to be judged by someone who's 5 years in the profession? Or how is a senior doctor going to judge that girl? This whole thing about how will I look? How will people look at my career and they will say, I'm so irresponsible. And everyone in healthcare is supposed to be super responsible. And I think that is something that we have to dwell with. Pavan.
Thank you very much, sir. And I think what I wanted to say, she covered part of it. An excellent session, but everybody got up to speak up what happened with them, share their experiences, because somebody here inspired you to share their experiences in public. Do it in your hospitals also. Okay, forget about the debate, that is over. Number two, I would like to share two incidences related to your first case and the second case a bit indirectly. When there was no surgical safety checklist, no lookalike sound-alike medications, no prior labeling of the pre-prepared syringes, year 1979, I was an intern in Command Hospital, Pune. all of us were busy as interns looking down the belly to identify which is the intestine and which is the liver, which the surgeon was trying to show us. And suddenly we found that an anesthetist is down, flat on the ground. And we were all shocked what has happened to the anesthetist. So everybody forgot the patient. They started looking at the anesthetist. And none of us could find out what has happened to the anesthetist. Suddenly my surgeon was a very smart man, never forget him, Wing Commander that night, DP Sarkar, many of us from armed forces know him. He said, my God, this guy is a bloody pathogen addict and he has labeled 2 syringes, one of succinylcholine, other of pethidine. By mistake, he injected himself with succinylcholine. Whoa. No labeling done. No surgical safety checklist, same case. I was looking in the GI surgery ward, he was a case of chronic cholecystitis. He put up a conventional, we had no lab chole,
Yeah,
conventional cholecystectomy, but a case of situs inversus. No surgical safety checklist those days. You know what the surgeon wrote? It was General Anand, not R. Anand. He was the Surgeon General Anand, and he wrote on the case sheet on top in big red, case of situs inversus, liver is on the left side, incision to be put on the left side. He put it on the top of the case sheet in red. And when he went there, and what he correctly said, that he was the operating surgeon, he said, wait on, let me check. This is given in the case sheet on top. Let me check we had no ultrasounds. We had nothing of those sorts. He checked everything again, personally, physically in the OT. And then he started operating. So maybe that was a good practice that time. And we may need to think beyond the surgical safety checklist. And why do it only time out? Why not is written on top in such unusual cases that you should have some unusual good practices.
Thank you so much. So what can we do to prevent this in the future? Emphasize double-check protocols on narcotic prescriptions to be verified by 2 staff. Standardize prescription practices, high alert medication should have clear, bold notations with opportunity of misinterpretation being minimized. Enhance post-administration monitoring, and we are all familiar with what needs to be done, and staff training, regular training. And I cannot help but, given the fact that we have 2 bright financial visits sitting here, Mr. Tyagi and Mr. Shiv Kumar, and I see how accountants go about, and every single entry that they do, they put a little mark that all the chartered accountants do, and perhaps we in medicine need to learn that. How do we even know that someone's checked? Whether we have that check digitally or we have it physically, we need to do that, because how do we assume that someone else has had a look? There is an opportunity definitely for us to learn from other industries, from other sectors, and quite often if we focus in the right direction, I'm coming to you, if we focus in the right direction, perhaps we will not miss out a lot of things that we actually do. Going to request Shiv for his closing comments. Yeah.
No, these are not closing remarks.
Yeah.
Fabulous session, Anupam, and it's not that accountants don't make mistakes, but we have a chapter called rectification of errors. So
Unfortunately for us, sometimes rectification is rather complicated, so we better look at prevention. Thank you so much for this fabulous interactive session, which over the years has become rather popular as Let's Talk Safety. The idea was to learn from each other, and I think there was a lot of learning for each one of us. Thank you so much for being so candid and for sharing your experience, because I think each one of us has benefited from that. Thank you so much, and over to you.
Thank you, Dr. Sibyl, for such an engaging session. Ladies and gentlemen, 2 incredible days of learning, collaboration, and innovation at the International Patient Safety Conference 2025. Now it is time to reflect on the memories we have created and the path we made in our collective mission to enhance patient safety. Out of all those memories, we have created a small video for you all. Let's have a look at the recap. May I request the AV to be played, please? That was wonderful. Now it's time to give away a few awards. Over the past 2 days, we had many fun-filled activities organized here, and we are honored to now reward those who have won different activities which we kind of created for all of you. We are excited to announce the winners of our Play and Win segment. With an overwhelming number of delegates participating, we had an incredible engagement in Play and Win competition. May I request Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals, to please be here on the stage to reward the winners. Along with him, may I please request Mr. P. Shivakumar, Managing Director, Indraprastha Apollo, to please be here on the stage to reward all the Play and Win Winners Award. Thank you once again for your roaring participation. Please welcome Mr. P. Shivakumar and Dr. Anupam Sibal here on the stage. We'll start with the stall activity. So the top 3 scorers in stall activities, we had basically 2 functions, 2 activities there, Expo Explorer and the scratch coupons. We have 3 winners in this category of stall activities. The first winner, Lakshi Tyagi, Amity University. May I please request you to be here on the stage to receive the award. Lakshit Tyagi. Lakshit Tyagi, Amity University. May I please request you? So Lakshit is from IIHMR University. Ladies and gentlemen, please give a big round of applause for Lakshit Tyagi. May I call upon the next winner, Mr. Amit Sharma. Mr. Amit Sharma here on the stage, the winner of the stall activity, Expo Explorer and Scratch Coupon. Amit Sharma here on the stage, please. So we have Mr. Amit Sharma here. May I please request everybody to welcome the winners with a big round of applause. Thank you. May I please request the winners to be there at the center of the stage to have the pictures captured appropriately. Now we have a next category of awards, Vision 2030 statements. We had received many different statements for Vision 2030, and out of all those statements, we have selected the best 2. May I have a privilege to announce the winners? The first winner is Arya Ajit. May I please request Arya Ajit to be here on the stage with us, please? Mr. Arya Ajit. Okay, moving forward, we have the second winner, Ritu Parna Das, Fortis Hospital. Ritu Parna Das from Fortis Hospital. All right, moving next to the photo editor activity. And in this, we have got 2 winners. The first to invite here on the stage, Mr. Piyush Chan, Amity University. Mr. Piyush Chan, the winner of Photo Editor Award, ladies and gentlemen. Please welcome him with a big round of applause. If Piyush Chan is here, I would request him to please join the stage to receive the award. The second winner in this category, we have Ms. Surekha Khatri, RML Hospital, Delhi. Surekha Khatri, may I please request you to collect the award from our esteemed guest here. I would please, okay. Sure. So Piyush Chan is here. Congratulations, Piyush. We don't have Surekha Khatri here. So on behalf of her, ma'am is collecting the award for Surekha Khatri, RML Hospitals, Delhi. Ladies and gentlemen, please give a big round of applause for RML Hospital, Delhi. Thank you so much. With that, there are few more awards which we will be announcing by the end of Dr. Jay Shankar's session. So please stay tuned, do not go anywhere. We have the following upcoming awards. We have special jury awards, we have paper presentation awards, we have poster presentation awards, and a very exciting award where people would be winning MacBook and iPads. So please stay tuned, and we'll be following the rest of the sessions now.
Respected ladies and gentlemen and delegates, we are awaiting a very wisdom-rich session with Sister B.K. Shivani. In a very short while, I would request all of you to have your seat, all you to be seated. We are just waiting for her to join us in a couple of minutes, and followed which we also have our Honorable Minister, Dr. S. J. Shankar, also joining us. So hold on to the seat, and we are expecting a very fun-filled or a very interactive sessions upcoming with us. Thank you.
Who do you call first when you feel unwell? Your mom? Your wife? Your friends? The doctor in the family? What if your familiar support system is not readily available? What if you are new in the city? What if the fever won't go away or the pain won't stop? What if you're left with more questions than answers? Then, who would you ask for help? Ask Apollo. Introducing a smart and innovative healthcare ecosystem that revolutionizes patient care. It is powered by India's first AI platform to leverage 40 years of patient data and Apollo's global clinical expertise. Using patients' past health records and real-time data, it offers accurate personalized care, predictive insights, tailored recommendations, enabling unparalleled precision in diagnosis. With seamless voice, text, and image interactions, Ask Apollo's intuitive platform ensures patients receive advanced healthcare from the very first step of their health journey. So go ahead, ask Apollo. What can I have for my nagging headache?
Can you help me understand my lab report?
Who are the best cardiologists in the country?
Why do doctors have bad handwriting?
Ladies and gentlemen, as we navigate the complexities of healthcare and patient safety, one aspect remains at the core of everything we do: our state of mind. In the midst of challenges, high-pressure decisions, and the pursuit of excellence, the power of mindfulness becomes more important than ever. Today, we have truly honored to have someone's wisdom has touched millions of lives, and that is Sister B.K. Shivani. And we also have Dr. Anupam Sibal to actually welcome her and take the session forward. Over to you, sir. And also we have our Dr. Sangeeta Reddy also joining us.
Respected Sister Shivani ji, Om Shanti, Dr. Sangeeta Reddy, colleagues, friends who've been with us for the last 2 days. You know, a toddler laughs about 200 times a day. Adults laugh about 3 times a day. Why do we forget how to laugh? All of us want restful sleep, if not 8 hours, 7 hours, maybe at least 6. But how many of us get restful sleep? All of us crave to be happy, to be calm, to be composed, to find joy in every moment. But how many of us are present in the moment? Are we not thinking about what's going to have half an hour from now or later on in the evening or tomorrow? How is it that we can all find happiness, joy, and calm in today's world? Who better than respected Sister Shivani ji to guide us? Sister Shivani is an engineer by training and has been a practitioner of the Raj Yoga meditation of the Brahma Kumari for decades. Her television program, Awakening with Brahma Kumaris, for more than a decade, helped countless number of individuals deal with emotional stress, depression. In fact, she is the Goodwill Ambassador of the World Psychiatric Association. Sister Ji has written 3 books: Happiness Unlimited, The Power of One Thought, Being Love. Sister G was once asked, and I quote, and she was asked about being calm, kind, or happy, and what she said is truly deep. And her reply was, if I'm one, the other two automatically happen. Calm is who I am. Kindness is my nature. And if I'm calm and happy, then I will definitely receive blessings. And when I make it my aim to receive blessings at work, at home, in my relationships, then being happy becomes a way of life. Let us put our hands together to welcome Sister Shivani Ji for this session. Sister Shivani is going to be speaking on embracing calm, the power of mindfulness. But before we invite Sister Ji, may I please request Dr. Sangeeta Reddy to felicitate Sister Ji. So let's put our hands together for Sister Shivani. On kare? May I request the AV team to get all the lights on, please?
Om Shanti. Let's take a minute of silence. Just everyone to sit straight. Gently bring your attention to the center of the forehead. This is a little exercise which we can do every couple of hours. A 1-minute exercise which increases concentration, stops negative and waste thinking, and makes peace and power a natural way of living. We can switch off the screens. We don't need to see screens. We've all got so used to looking at screens that even while standing next to each other, we look at screens. So we can switch off the screen. We can switch on the light. Just have a normal people-to-people interaction. Photo baad mein karte hain baki. Bring your attention here to this point. And just visualize there, in the center of the forehead, a tiny point of light, like a little star. It's the energy I, which is the master of this body. Keep looking at yourself. I am this energy, the creator of every thought and feeling. And while you keep on looking at yourself, gently say to yourself, I am a powerful being. I am a powerful being. I am calm and stable in every situation. I am calm and stable in every situation. I am a peaceful being. Situations may not be my way. I respond through my nature of peace. I am a loveful being. Love and respect, care and compassion is my nature. People may be my way, may not be my way. They may be my way, they may not be my way. I respond through my nature of care and compassion. I the powerful being. I, the peaceful being. I, the loveful being. I am a radiator of peace and power while in action. Visualize yourself in the hospital, in your office, in your department, doing everything that you are doing. But while doing what you are doing, the being is radiating peace and power. While I'm radiating that peace and power, I'm radiating healing energy. That healing energy is strengthening minds. Shanti. In a healthcare setup, while we are dealing with disease, while we are dealing with crisis, there's one more thing that we are dealing with, and that is minds which are troubled, which are upset, and now probably confused and fearful once they are diagnosed with an illness. So for those who are in the direct line of treatment, whether as a doctor or whether as a nurse or any supporting staff, or every person actually who is in a healthcare setup, you are actually in a vibration of stress, fear, pain, insecurity. It's in the air. And the more the world is creating stress and fear, the more they're going to come with that baggage into the hospital. And we in our own life have started saying that stress and anger and fear is normal. So they are coming with their vibrations, we are creating our own daily vibrations. And when we are exposed to them coming with that emotional infection, not the physical infection, they are coming with their emotional virus. But because we are not taking care of ourselves, our emotional immunity is low. And so we are a victim to that emotional virus that people are carrying around us. And so day by day, our stress levels start increasing. And the more our stress level will start increasing, the more they will receive that energy of stress from us, and it's gone into a vicious cycle. Just think for 10 seconds. Infrastructure, we know what a hospital should be. Let's just ask ourselves, what should be the vibration of a hospital? What should be the vibration of a hospital? Vibration means what should be the energy of a hospital? What's the word that comes to your mind? What should be the vibration of a hospital? Anybody? Which means, just close your eyes, enter into a hospital in pain, as a patient, enter into the hospital in pain, physically, or assisting a family member. You're going there for healing. What's the energy that should be there in the hospital that's going to make healing easy for you? Say out all the words. Let's collect all those words because we want those words as the vibration of the hospital. Just say out whatever word comes to your mind. What should be the vibration of a hospital? Think of it as a patient or think of it as a caregiver. You are walking in. What would you want as the vibe? Like, look at this room. Every room is not just infrastructure. It's not just technology. It's vibration. Today, 3 to 3:30, I was in one room. 3:30 to 4, I was in another room. Same building. And now 4:30 to 5 in this room. Same building, same infrastructure, same technology, 3 different vibrations. First room, 4 to 4:30, conference is on meditation. So everyone over there practicing meditation. Room energy was completely different. Next half an hour, room of young children, students, energy completely different. And now third, energy completely different. We never look at the vibration of a place. We only keep looking at infrastructure, technology, people. That is only what is visible to the eye. But I, the being, am creating vibration, radiating vibration, and most important, I'm absorbing vibration throughout the day. So now, just share your words. What should be the vibration of a healthcare setup? empathy, positive, calm. Anything else? Kind. See, talk about vibration, huh? Not behavior. Behavior is there. Vibration. See, I can be kind to someone even if I'm stressed. Yes or no? Yes or no? Of course I can. I can be troubled about something that's going on in my place at home, but I'm very, very kind to everyone I meet who I'm healing. So I am kind in the doing, but I, the being, am creating stress vibration in the hospital. So let's separate the doing from the being. Now look at the vibration of the being. What should be the energy of a hospital? What will aid in healing? And most important, what vibration will keep those who are going to live in that hospital every single day for the rest of their life? What's going to energize them? What kind of vibration? Because a very big reason why those who are working in a healthcare setup feel that stress, it's not because of what you're doing. It's because of the vibration in which you're living from morning to night. So if we change the vibration of the place, even if you're dealing with crisis throughout the day, you will go home in the evening energized. It's not the doing which is creating the stress. You are expert at what you're doing. You can wake up in the middle of the night and go and operate somebody. You are skilled at that. It's not the doing, it's the vibration. So positive, peaceful. How many of us feel we can create a happy hospital? Which means an energy of happiness means I walk into, I open the door, I walk in, I'm coming with all my, and suddenly I come into the hospital and say, I'm feeling nice after coming here. Possible to say I'm feeling nice after coming here? Yes? And if you feel as a patient, I start feeling nice after coming here, don't you think my body will start responding faster? So now, when I want to create a vibration of positive, happy, peaceful, powerful, so who's going to create it? Those who are coming into the hospital or those who are living in the hospital? So which means, where are they living now? Right now, where are they? Here, in this hall. But everyone in this hall has now created a life which is saying stress is normal, anger is normal, fear is normal, irritation is normal. And nowadays we meet youth which is saying depressed is normal. So all these emotional complications that we are creating complications in the physical body. So let's take it up as our moral responsibility. Because the word patient safety. So the patient safety not just in the doing, but giving the patient that higher vibration which will keep the patient emotionally safe while the healing is happening. Let's take one step today. How many of you can commit 10 minutes to yourself every morning? Kar lo. And how many are too busy, can't give 10 minutes to yourself? The other day I read a very nice quote, and that quote went, everyone should meditate for 20 minutes, and those who are busy should meditate for 1 hour. So I kind of read it twice to say, what is trying to say? So I said, yeah, right. Because those who are not doing much, it's okay if they meditate only for 20 minutes. If I use the phone battery less, I need to charge it less. But if I'm going to use it more, I need to charge it more. Today we are using the mind more, but we are saying we don't have time to charge it. And so the depleted emotional mind was still managing with life going on fine, and suddenly we were flooded with content, and with that little time that we found, we thought that was our de-stressor, sitting with our phone. How many of you get time in the night to sit with your phone? Such bolna. How many of us get time? Because obviously we all need to de-stress, right? But now we need to pause and check whether that content consumption that I am exercising in the night before going to sleep as a de-stressor, is that a de-stressor or is that actually the main cause of my stress? Last whole 10 days, the country has been talking about the responsibility of content creators. It's time come to talk about the responsibility of content consumers. If content consumers start consuming healthy content, we will be flooded with healthy content. So let's do one step today. Content is not a time pass. We are using content as a distractor. But when we use content as a distractor, we are only silencing our overthinking mind. We are saying, I don't want to listen. Right now, as in the class with students, they say, she said, I can't listen to my mind, so I just immediately pick up my phone. So I'm using it as a distractor. I'm using it as a distractor. Thank you so much. So let's not use content as a distractor, because the distractor is becoming a depleter. And when a distractor becomes a depleter, then it becomes an addiction. And once it becomes an addiction, I get depleted more. And when I get depleted more, I need the distractor more. Just for 1 month, experiment and see, 10 minutes before you go to sleep, if you want to consume content, don't consume content which is a distractor, but consume content which is an energizer. What we watch, read, listen becomes the source of our thoughts. And our thoughts become our sanskar, and our sanskar is the vibration which we radiate at home and at work. So can we consume highest vibrational content for 10 minutes before we go to sleep? How many can do that? Because when we go to sleep, then the next 6-8 hours, that high vibrational content is going to process not just in your mind, it's going to vibrate to every cell of your body and heal your mind and body both. But if I'm going to consume crime, thriller, gossip, criticism, ridicule, comedy just before going to sleep, then that is what is going to process on my mind, and that is also what is going to radiate to every cell of my body in the next 8 hours while I sleep. So as a healthcare professional, as one who is in the field of healing people, we cannot consume lower vibrational content because it's not here, it's in my aura, it's a part of my vibration, and it comes with me to the hospital every morning. And for those of you who are doctors and you prescribe the right diet to your patient, prescribing diet of food is not enough now. You'll have to prescribe the diet of content consumption to them, because they cannot be healthy only with the right food. They'll have to be healthy with the right content consumption. So at least as a healthcare professional, that's our responsibility. That 10 minutes to just cleanse everything that got created here in the day, consume high vibrational content. That vibration which you want to be your aura, and that vibration which you want should be the energy of the hospital the next day. Second thing, just 5 minutes, sit in silence. Can we sit in silence for 5 minutes doing nothing? Is that possible? Even if we don't know how to meditate, how many can just try this? Just sit 5 minutes in silence. A lot of thoughts will just flood up here. It's like a cupboard which gets opened. But that will give you the chance to see what are your thoughts. And then gently, instead of suppressing them, because suppressing the thought creates a wound in the mind. And very soon that wound after a few years becomes a trauma, and that trauma creates a disease in the body. So just write out few of your thoughts which are not the right energy, which are painful, and just below that, gently start writing the correct thought. And as you gently write the correct thought, you are shifting your thought process from the normal way of thinking to a higher vibrational thinking. Today, neurologists teach us that neurons that wire together, fire together, right? So why not we change what's going to wire together, it's going to fire together. Every day we will consume the same, think the same, speak the same, then the same is going to happen every single day. Let's take out your phone, let's write down a few thoughts that we can say just before going to sleep. 10 thoughts for us just to say before we go to sleep. Can we type? Or can we record? Yes? Come, let's do it. First thought, I am a powerful being. Every single night before going to sleep, I am a powerful being. And when we are saying I am a powerful being, we are saying I am untouched by situations, I influence situations. I don't react, I respond. I am a powerful being. Second thought, I am calm and stable in every situation. I am calm and stable in every situation. Third thought, I am fearless, I am confident. The hospital has a lot of vibrations of fear. And to remain untouched by that vibration, I need to say every single day, I am fearless, opposite, nidar. Fourth thought, I am always happy. I am always happy. Fifth thought, I am easy, I have more time than I need. Opposite of our normal vocabulary, which is a lower vibrational vocabulary. I am easy, I have more time than I need. Next thought, I'm an instrument of the supreme power who's using me to heal the world. I'm a giver. Not just physically, vibrationally, emotionally, I'm a giver. I'm a radiator of peace and power to the world. I'm a radiator of peace and power to the world. My body is perfect and healthy always. My body is perfect and healthy always. My every relationship is smooth and strong on the foundation of trust and respect. That would mean relationship at home, relationship at work. It will mean patient relationship with us. My every relationship is smooth and strong on the foundation of trust and respect. And most important, envelop yourself with a higher vibrational energy circle. It's like a PP kit. Envelop yourself, and then you can walk into a lower vibrational place. So the highest vibration, God's power and blessings, or the supreme power and blessings, is a divine circle of protection around me. Draw a high vibrational circle around yourself. And you can draw that same high vibration circle around your family. You can draw the same high vibration circle around your hospital. Every night before going to sleep, it will take 1 minute or less than that to repeat these thoughts. But remember, neurons that wire together, fire together. So if we repeat this every single night before we go to sleep as our last thoughts, then these are the thoughts that will get processed in the night on the mind and the body both. And then when we wake up first thing in the morning, wake up on the highest vibrational frequency of gratitude. Just begin the morning with first thought of gratitude. Sometimes we begin the morning with, oh, I'm late. Lowest vibrational thought to begin the day. First vibrational thought, gratitude. Gratitude to the supreme power, gratitude to my mind and body, gratitude to my people, gratitude to this opportunity that I have to heal the world. Just gratitude to nature. There's so much for gratitude. Just wake up, open your eyes, only singing the song of gratitude, gratitude, gratitude. And as you're getting out of bed, you're going to the washroom, keep saying, I'm a powerful being, I'm always happy, I'm calm, I'm stable, I radiate peace and power to the world. Keep consciously creating those high vibrational thoughts repeatedly every single day. And when we repeat the same thoughts, which are high vibrational thoughts every single day, very soon they are not just thoughts. Thought starts becoming my reality. And then that starts becoming my personality. And then my personality starts vibrating into where I am working and I'm living. And just by creating a shift here, I start shifting the vibration of the place. Just by creating a shift here, I create a shift in the people who I'm healing. So at any level in the hospital, right from the person who's at the security gate to the doctor who's operating on me, every person I meet is a vibration. So if I am exposed to a vibration which is very caring and peaceful and calm, by the time the treatment of my body starts, my mind has actually started becoming very comfortable with itself, and that starts healing the body. So complications in the mind increase the complications in the body, and we all have enough evidence of the power of the mind in healing. All miracles in the medical industry, all miracles in the healthcare practices are actually the power of the mind. So if we start using the power of the mind, and power of the mind is not always just the power of the mind of the patient, it is patient, caregiver, doctor, sister, and everyone in the healthcare facility. So if we start taking care of the power of the mind, then creating miracles will start becoming a normal way of living. It'll become a normal way of living because your power will make them powerful and their power will create miracles with the body. All if I just start taking care of my mind. And during the day, a very powerful technique is like you keep sanitizing your hands so that infection from one doesn't go to the other, every hour if possible, or every time you take a pause to have a glass of water, 1 minute or 30 seconds. Just sit back and while you're drinking your water, don't even take out separate 30 seconds. While you're drinking your water, that 1 minute meditation, I'm a powerful being, I'm peaceful, I'm happy always, I radiate peace and power while drinking water. Just while drinking water. So using those 30 seconds here and there throughout the day, this part of my life starts getting energized. And when that happens, and here comes a crisis, I don't react to the crisis. I, the powerful being, will respond with calm and stability. It will come natural to me. It is not something I will have to do at that time. It will come natural to me because I have prepared my mind to be that way. So just taking care of the content that I consume, which is very, very important. And while driving to work every single day, if you can use that driving time, wherever, however we are driving, whether it's in the train, bus, driving my own car, if we use those 15 minutes, half an hour, 1 hour, to not listen to the world news first thing in the morning. I'm going for healing. I cannot have those words into my energy field. My energy field is like the perfume you use. You use a perfume, but when you walk into your place, everybody gets that fragrance. So take care of what you're putting into your aura before you reach your hospital. So use that travel time, nothing extra, but use that travel time to read, watch, or listen, again, high vibrational words. Any content, a self-change book, a self-transformational video, audio, music, anything. Use your travel time in the morning. It's very important because then you're entering into the hospital in the highest vibrational state. Now, this is going to be a gift not just to you, but this becomes a gift to everyone who's working with you, and this becomes a gift to everyone you are healing. And all that I have to do is take care of myself, and self-care automatically starts taking care of people around me. And most important, when you do that 1 minute every hour or every 2 hours, when you come home at home in the night, you're going to come at your highest vibrational state. And those of you who are operating or conducting procedures, a lot of doctors are doing it. You can do it and see the results are beautiful. Collectively, as a unit, when everything is ready, just take a minute of silence. Just a minute of silence when everything is ready, but just before you start touching the patient, when you're operating, just a minute of silence, collectively one thought, I am a powerful being, I'm an instrument of the divine. I am being used to create miracle with this person lying there, and this surgery will be a divine experience. 4 thoughts, 10 seconds, everyone together, collective energy of the incomplete unit, miracles start happening. And when we complete the procedure, again together for 30 seconds, gratitude, gratitude to the one who's lying there before us, and most important, this person will be healed and back home very soon. So not just working on the doing, but working on the being with the doing makes miracles a natural way of being. And most important, the miracles first starts with you, because every time you're repeating these high vibrational words, it is you who is getting healed. Let's take a minute of silence again. And you can also repeat these words just before having your meal. Food is a very important part which influences our mind. You are what you eat. It's not that the body is what we eat. It is I am what I eat, which means the mind gets influenced by what I eat. So just before eating, take 10 seconds. No phone and TV at night while eating. No TV while eating. You are just going to allow your food to be absorbed by very low vibrational words, and that will affect the mind and the gut both. So bring your attention to the center of the forehead. Again, point of light in the center of the forehead. I am the master of my mind. I create only high vibrational thoughts. Every word I speak is a high vibrational word. I'm a radiator of peace and power. I am a healer for the world. My vibrations heal the world. Om Shanti. Shukriya.
Ladies and gentlemen, with the arrival of our guest of honor, now it's time to hear out from our global change makers. Please join me in inviting Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals, to steer the session. Over to you, sir.
Thank you very much. Namaste, good afternoon. Thank you so much, Sister Shivani. It's such a privilege to welcome the Honorable Minister of External Affairs, Shri S. Jayashankarji. He served as our ambassador to China, to the United States, High Commissioner to Singapore, Foreign Secretary, and then, of course, the Minister of External Affairs. I don't know how many of us are aware, but His Excellency speaks Russian, English, Tamil, Hindi, Japanese, and Chinese. No, this is an opportunity, Your Excellency, we have to, because many of us are big fans of yours, so I cannot let this pass. We have to acquaint everyone with an amazing person that you are. His Excellency has written 3 books, prolific author, and under his leadership, the stellar contributions of the Ministry of External Affairs have been recognized globally, whether it's BRICS, the Quad. In fact, he's just come from the G20 Foreign Ministers Summit in Johannesburg, landed today and come here, and we really appreciate that. So thank you so much, Your Excellency, for finding time for us. May I also take this opportunity to invite our 4 distinguished health ministers from countries very friendly to India. May I invite Honorable Dr. Frank Anthony, Minister of Health from the Government of Guyana, Honorable Mr. Rubunwa, Minister of Health and Medical Services from Fiji, the Honorable Health Minister from Maldives, Honorable Abdullah Nasim Ibrahim, and the Honorable Health Minister of Eswatini, Mr. Matsubula. Dr. Sangeeta Reddy, our Joint Managing Director and Managing Director of AHLL and Chairperson of G20 Empower India, may I please request you to felicitate our guests. May I request you to felicitate our chief guest, Mr. Jayashankar, the Minister of Health from Fiji, from Maldives, from Fiji, and from Eswatini. May I take this opportunity to invite Dr. Sangeeta Reddy for her opening remarks. Dr. Reddy.
Respected Jayashankar ji, a role model in so many ways, an inspiration, and truly someone who is leading us to the new levels under the dynamic leadership of our Honorable Prime Minister. Excuse me. Honorable Ministers, Your Excellencies, delegates, scientists, technologists, doctors, nurses, ladies and gentlemen, it's with such great pleasure that we address our minister and all of you at the conclusion of a 2-day, extremely exciting, transformational gathering. I'm going to take a minute. In 1983, when we opened our first hospital in Chennai, after the opening, Chairman called together his team and he said, if this hospital has more than 1 million bricks, we've had more than 1 million problems to make this hospital happen. So we said, yes, sir. He said, from designing to equipment to manpower to staffing, where does the gas pipeline go? What's the safety feature? He said, I don't want other people who are creating healthcare infrastructure to have to suffer the same. We must teach. We must share this knowledge. We must continue to help others put up hospitals. We started our project consultancy division, which has worked across many hospitals in India abroad. We started programs like these. And over the last 15 years, we have done this program again and again, sharing the latest in technology transforming healthcare and international patient safety norms with partners like ISCO, our Joint Commission, various universities, other partners across the world. The only thought process is, sir, that we must do our bit towards a healthier, happier world. And therefore, with 7,458 delegates, over 375 speakers from 30 to 40 countries, we were privileged to discuss AI-driven patient safety, digital transformation, cross-border collaborations, future of healthcare systems, and underscore India's critical role in helping to, number one, as our Honorable Prime Minister says, heal the world by treating patients who come to us from over 140 countries. Heal from India, to use technology and remote care to be able to serve remote areas of Africa like we've been doing for so long, but Indonesia, Fiji, and many, many others, the Maldives. And then finally, to use the latest technologies as well as the training capability and the power of the Indian demographic so that Indian healthcare workers, through what I may request our honorable ministers, a harmonization of degrees and an understanding and appreciation that our healthcare workers can move across borders to help to save the world. It is a very special moment for us because in one of the seminars, one person stood up and reflected what they were feeling. They said, we go to many conferences, but here we find answers. How are we going to stay together? So I'm extremely happy that today we launch the not-for-profit International Health Dialogues Society. This is a dedicated platform that all of you can share, so we keep coming together to continue to share information and knowledge. Honorable Minister, we look forward to your continued support in this vision of healing and seeking to help the world. We thank you for your presence here, which signals that you recognize the importance of the healthcare worker in India's medical diplomacy and the fact that we also believe that Vasudhaiva Kutumbakam, we are one world, we will continue to come together to share ideology, knowledge, healing, caring, scientific innovation, new breakthroughs, artificial intelligence, and each one of them will be given from a position of respect, from a position of knowledge, and most importantly, with this ideology that we can all come together to cure and care for the world. Your Excellencies, thank you for your presence and our promise on behalf of everybody in this hall that we will continue to work together. Thank you.
Thank you so much, Dr. Sangeeta Reddy. And may I now have the privilege of inviting our chief guest, His Excellency, the Honorable Minister, someone that many of us have not had the privilege of hearing in person, but of course, follow him very, very extensively on social media, and everything you say gets registered in our minds. So let's put our hands together for the Honorable Minister.
Dr. Sangeeta Reddy, Honorable Minister Matsibula, Honorable Minister Ravanava, Honorable Minister Ibrahim, Honorable Minister Dr. Anthony, Dr. Anupam Sibal, Excellencies, ladies and gentlemen. It is a great pleasure to address the valedictory session of the 12th International Health Dialogue. Now, some of you would be wondering why the External Affairs Minister is doing so. And the answer is that we, in India, envisage health as central to development, and development as key to international cooperation. In recent years, many of our global initiatives have revolved around health security. This is a domain where India has been the first responder, a development partner, a supply chain link, a health solution provider, a knowledge center, and in many ways, especially in the last decade, an exemplar. Allow me to dilate on these different dimensions. When the COVID pandemic started engulfing the world, the initial deliberations, and I was myself present at some of them, envisaged India as potentially the biggest concern. Ironically, India ended up not only looking after its own needs, but actually stepped forward to contribute to the world. We provided medicines at that time to 150 nations, vaccines to 99 countries and 2 international organizations, as well as masks, PPE kits, gloves, ventilators, you name it. Equally important, India chose to do this when its own vaccination program was still unfolding. A large number of developing nations received Made in India vaccines, either through our Vaccine Maitri initiative or other global programs. Now, this was in contrast to many developed countries who had stockpiled vaccines to the multiples of their population. Indian medical teams also went out in the Indian Ocean region to deal with pressing situations in some smaller countries. But this was not just an exception made during the COVID era. In fact, it is part of our approach to the world, both before and after. Recently, we dispatched 66.5 tons of medical supplies to deal with the humanitarian crisis in Gaza. A little before that, a consignment of 1,400 kilograms of anti-cancer medicines were sent to strengthen the medical capabilities of hospitals in Syria. Even in Afghanistan, India has stepped forward with 300 tons of medicines in the last few years, as well as the dispatch of specialists to a hospital that we had built in Kabul. Now, I can give you numerous other examples, whether it was to Sri Lankan hospitals during the economic crisis in 2022, to Ukraine as the casualties and the conflict spiked, or to Myanmar when it was struck by Typhoon Yagi. And the contributions themselves, they could be Bhabha cyclotrons to treat cancer, as in Mongolia, Kyrgyzstan, and Kenya, or the Bhishma cubes for first line of care, which we gave to Ukraine, or for that matter, APIs and antibiotics, which we supplied to Cuba, or the MEDVAC services and sea ambulances ministered in the Maldives, or even the Jaipur Foot in Cambodia, or the dialysis machines in the Pacific Islands. In this pursuit, Indian diplomacy has worked with partners, big and small, islands and landlocked, close and distant, but united in their desire to ensure a better life for their citizens. Friends, India today has delivered more than 600 significant development projects in 78 nations across the world. Now, many of them are in the health sector. In parallel, the private health industry of India has also contributed to facilities and capacities in different geographies, and I want to say today that we value this industry as a partner. From specialty hospitals to primary health centers, we have sought to make a difference across a wide spectrum. The COVID experience was a reminder to many nations to develop national capacities in this crucial domain. Here too, Indian companies have, as well as obviously the Indian government, we have sought to localize production and to strengthen capabilities. One of our significant efforts in this direction has been the E-Arogya Bharti initiative to train medical students and paramedics in Africa through online classes. By diversifying the production of medicines and expanding the scale of medical professionals, we are strengthening the ability of the Global South to address its core concerns. But today, I also want to make another point. It's not just the Global South which requires a stronger medical partnership. So does the Global North. There is an acute shortage of doctors, of nurses, of health workers in a very large number of countries in the Global North, in North America, in Europe, in Japan, in the Far East. And when we today negotiate mobility partnerships, one driver of this is actually to help them address their growing health needs, which obviously has to take into account an aging population. So that said, there are these situations where the need for specialized care requires mobility. Indian hospitals have responded both outwards, as I said, but also inwards by developing modules to treat international patients. We see this particularly as a notable contribution to Global South societies for whom affordability and accessibility are key criteria. Through the Heal in India initiative, our government is committed to promoting medical value travel and making it easier for foreign patients to obtain treatment in India. Friends, as we seek to balance tradition and technology as the twin forces of national progress, it is also natural that we will explore the relevance of our own heritage and culture to the health of our people, and by the way, encourage other societies in a similar position to do so. Especially during the COVID period, there was a sharper realization of the utility and efficacy of traditional medicine to preventive healthcare, recovery, and wellness. India has the privilege to host the WHO Global Center of Traditional Medicine in Gujarat. As a government which created a department called Ayush to promote these very practices and treatments, we look forward to greater international cooperation in this sphere as well. This should be appreciated also in the larger context of an integrated view of human well-being. India has promoted the International Day of Yoga, the Lifestyle for Environment Initiative, LIFE Initiative, and more nutritious practices such as the consumption of millets. But at the end of the day, a lot that India contributes is through its own progress and example. The Ayushman Bharat initiative, as you would have heard from other speakers, is today the world's largest government health insurance scheme. About 750 million of our citizens have received Aadhaar IDs, and they have access to 360,000 healthcare facilities and 570,000 healthcare professionals. To do this on such a scale at our level of per capita income is actually a testimony to the power of digital public infrastructure. And that in turn reflects the deep commitment to good governance of the Modi government. For many citizens, the cost of medicines required for treatment of chronic ailments is also a particular anxiety. Here too, we have demonstrated through the 14,000 Jan Aushadhi Kendras, the People's Pharmacy, that caring policies and smart inventory management can bring down the costs of medicines for a common person. These are experiences I flag because they have a relevance and an application to others in the Global South. So, ladies and gentlemen, let me conclude today by underlining that in this day and age, healthcare is a fundamental right. It's not just a privilege. The global south cannot be a hostage to uncertain supply chains and the vagaries of the global economy. The COVID period was a real learning experience for all of us. We must be prepared for the next challenge. All of us want to strengthen healthcare systems, enhance patient safety, and ensure affordable access. These goals would be better achieved if we collaborate more closely. And to the world, therefore, my message would be of the importance of international partnerships. That is the purpose of this gathering, and I'm sure that we will all leave with a stronger sense of purpose, a greater awareness, shared experiences, and surely a better networking to achieve that in practical terms. I thank you for your attention.
Thank you so much, Your Excellency. May I request for a photo with all the honorables? Yes. Yep. Thank you so much, Honorable Minister, for finding time for us. We are most grateful. And we in healthcare were so excited when we noticed that in the New Delhi G20 declaration, there were 5 mentions on healthcare. So thank you so much for making healthcare center stage. And even the India CARICOM Summit, M alludes to medicine. So thank you so much, Honorable Minister. I believe the Honorable Minister has to leave, so I'm going to request you for a release of a logo, which is on the international society that we've set up. Could we have that logo, please? Thank you so much. The purpose of setting this society, and we've named it Ishq. So for our foreign dignitaries, Ishq means love. But the idea really is to collaborate with each other in a not-for-profit format so that the benefit of advances in healthcare can reach to every corner of the globe. And we have representatives from several countries who are part of this initiative. So thank you so much, Honorable Minister, Your Excellencies, for releasing that. Thank you.
Come.
Please, Your Excellencies. So we move on, and we have the privilege of hearing our guests from overseas. So it's a privilege to invite Honorable Dr. Frank Anthony, the Minister of Health of the Government of Guyana. His Excellency studied in Russia and then Israel and was the Executive Director of the Health Services Development Unit at the Ministry of Health, responsible for control of HIV, TB, malaria, and also served as the Minister of Culture, Youth and Sports. For those of us who know little about Guyana, the only English-speaking country in South America, entirely covered by rainforest, one of the fastest growing economies in the world, and also known as the land of many waters. Your Excellency.
Thank you very much, Professor Sabal. My colleagues that is sharing the podium with me, distinguished ladies and gentlemen, of course, the Apollo family, and other distinguished persons who are here. I'm indeed very privileged to be here this afternoon as we conclude 2 wonderful days of conferencing. And I was very pleased to hear the External Minister of India just now and the work that India has been doing around the world. And indeed, what we just heard about India's role during the COVID pandemic is quite a remarkable story. And I must say that we in Guyana and in the Caribbean, we were extremely grateful for the gift that India gave to us during COVID. Because when we were looking for vaccines for our frontline healthcare workers, even if we had the money, there was no vaccines on the open market to be bought. And when we turned to India, India was the first country that actually donated vaccines to us. And because of that donation, we in the Caribbean, we in Guyana, we were able to vaccinate our frontline healthcare workers. Thank you to the government and people of India. I want to say that for patient safety, it is the heart of quality healthcare. And in the 21st century, as we continue to have medical advances, we have to see how we use these advances to make sure that patients are kept safe. Patient safety is not just about avoiding harm, but it's making sure that we build healthcare systems that are resilient, healthcare systems that are transparent, and that we have systems that are continuously improving. And today, I think I would like to highlight just a couple of things that we should focus on as we close this year's workshop on patient safety. I think it's important for us to think about how we can foster in our respective healthcare systems a culture of safety. And one of the things that we started doing over the last 2 years in Guyana is to make sure that we have huddles where our doctors can come together and to talk about the key things that they've learned during the day and to hand over our patients. But by doing that, we are also making sure that this knowledge is passed on and passed around. And we have seen by just doing that, we have seen a significant improvement in the quality of health care that we are delivering around our country. The other thing is, how do we leverage AI and all the other systems that are coming into being? For us, we have just started the implementation of electronic health records, and we feel that by doing so, it would help us to reduce the amount of errors that we have in our system. And by also introducing things like clinical decision support systems, we would be able to reduce those errors. So the point here is, how do we use the technology to make sure that we are improving our patients' safety? We also, many healthcare systems and many of our colleagues, we are guilty of just focusing on the disease and perhaps not focusing enough on our patients. But if we are able to empower patients, then we have a partner that would help us to make sure that we are delivering better care. And I think that's something that we have to focus on, especially in healthcare systems around the world. We also must ensure that we use the data that we are getting from our electronic records and everything else that we are doing, and use the analytics to help to improve patient care. And I think if we do that, we'll be able to see better patient care. And over the last 2 days, we have seen how different systems can actually work and how that has worked here in India. And the examples they have given us is something that I think can be easily adopted in our systems. So we look forward to partnerships and collaboration, and the way that perhaps we can work with you to ensure that we develop our systems in our respective countries. And finally, I think what is also very important is that we focus some attention on our clinicians and the healthcare staff, because very often, while we pay a lot of attention on what needs to be done, the people who are delivering care are sometimes ignored, and they can suffer from burnouts, and if they're not doing their jobs optimally, then that can have an impact on the care that we give to our patients. So I think by focusing on some of these areas, these trends, I think we can see an improvement in care for our patients. So as we wrap up this session this year, I just want to once again thank the Apollo Hospital Group for facilitating this wonderful conference and integrating technology so that we can improve the lives of our patients and improve our healthcare systems. And we look forward to this continuous collaboration. Thank you so much.
Thank you so much, Honorable Dr. Frank Anthony. May we now call upon the Honorable Minister of Health and Medical Services from Fiji, the beautiful country with 300 islands, the soft coral capital of the world. And what is so fascinating is that 9% of your population is a registered rugby player, which is absolutely unbelievable. We thought we had 60% registered cricket players in the country, but to see that in Fiji, you have such a great amount of interest for rugby is truly fascinating. Thank you so much, Minister.
Thank you, Chair, distinguished guests and esteemed delegates, ladies and gentlemen. Bula Vinaka and a greeting to you all. It is an honor for me to be present here this weekend and share my insight on the theme of this session, Transformation on Patient Safety. Health services in Fiji. Fiji is a small island nation with more than 300 islands and a population of a little bit less than 1 million. There are 3 tiers of health services provided, obviously primary, secondary, and tertiary health care, delivered in more than 214 health facilities distributed throughout the country. We have 3 main divisional referral hospitals that provide tertiary health services and 2 national specialist hospitals that provide specialist care and intervention program for mental health, rehabilitation, leprosy, and dermatology, and also tuberculosis. Health services in Fiji is fully subsidized by our government for our citizens, and non-citizens are required to pay a fee for service. Public health sector remain the main provider of health services for our people, while the private health facilities gradually expanded in the last decade with 3 private hospitals providing secondary and tertiary level health services and giving those that can afford an option for health care to access. Patient safety through clinical governance framework. The concept of patient safety is well established in health ministry in Fiji. Clinical governance was also introduced to the ministry in 2005 and was referred to then as a risk management policy and framework. In 2019, this has revamped with an engagement of a consultant and clinical governance lead, and from 2021, the subsequent appointment of a national manager for clinical governance in May 2023. Despite the challenges of implementation phases over the year, significant progress has been made over this period that include the strengthening of national clinical governance approach through the development of clinical governance chapter and metrics, digitization of incidental reporting system or the unusual occurrence that happened in our clinic, training and upskilling of staff, infection prevention and control program, including infection outbreak response, and also try to bridge the gap through interventions to support high priority clinical governance issues such as infrastructure requirement, medical supplies and consumables, and medical equipment. The greater focus on patient experience through regular patient satisfaction survey and mandatory family conferences for aggrieved patients and relatives, as well as for sentinel events that may occur. Positions have been established for staff in our clinical governance unit, and they have now migrated from project position to become permanent staff members in the ministry, taking into consideration the importance of sustainability of this critical initiative. Oversight through the National Clinical Governance Committee has also been strengthened, with meetings held and a quarterly schedule to monitor the implementation of clinical governance operational plan at each health facility in Fiji. A project called Between the Flags program have been piloted in many of our health facilities, which focus on identifying every clinical sign and any deterioration of clinical status among our admitted patients, and initiating the necessary and appropriate response which are earlier to arrest the further deterioration and improve clinical output for our patients. Learning from the pilot project will be used to improve the project before rolling it out to other health facilities. Clinical Governance Network, or CSN, was established in 2008 for the clinical disciplines of the ministry and have been operating with its membership comprising of specialists in the discipline across the country, both in private and public sector, and also including our training institution. And their role includes the review of clinical policy and guideline and treatment pathway under the respective discipline of the subspecialties. In 2024, Emergency Medicine CSN launched the first ever national quality standard document for emergency department for Fiji, which is now being implemented across Fiji health facilities. Like any new initiative, ladies and gentlemen, ongoing challenges continue to be faced in understanding and awareness of the program among the new recruits or the new graduates into the healthcare workforce. And it is critical that consistent commitment by clinical leadership, availability of clinical software, the updating of indicators and data analysis, including budget availability for financial support. The importance of changing person perception too is important in moving away from culture of blame to a culture of improvement through the identification of Process Improvement Plan, or PIP, and the Quality Improvement Initiative remain a challenge that we will need to address daily. Now looking to the future, ladies and gentlemen, there is no doubt that patient safety framework is necessary for building a resilience into our health system. Also, our experience from COVID-19 pandemic and the outbreak of nosocomial infection in hospital requires that we continue to build capacity in clinical governance through our infection prevention, control, at all levels of health services in Fiji. The threats of transnational movement of infection and disease with our international borders open for daily movement of international travelers means that our health system and hospital must be geared towards addressing disease and organisms that are endemic in our country, including those that may be introduced through our borders. The disease surveillance and prevention and diagnosis will require continuous updating and improvement to successfully and provide us with better health outcomes. The advent of digital health also provides the opportunity to enhance the scope of engagement under patient safety. In our 5-year digital health strategy, the ministry is focused in strengthening its digital health infrastructure to improve patient care and patient experience. This includes the setting up of telehealth, as I talked about yesterday, and the telemedicine capabilities in the ministry over the next 2 years. Our population is also well educated and well informed. Literacy rate in Fiji is estimated to be at 99.1% with equal distribution to males and female. Internet penetration in our population, someone said in health, our goalposts keep moving. That means that the standard or expectation constantly changing, demanding new research and adopting new acceptable standard and continuous mitigating strategies as we move along, and we thank Apollo for assisting us in that manner as well. On that note, the Fiji Ministry of Health continue its endeavor to collaborate and develop partnership with partners to transform patient safety and clinical governance in our health facilities. And this weekend has been very informative for me, and I thank you for all the collaboration and all the small meeting discussions that has happened in the last 24 hours. Thank you, Madam, for inviting us and for giving me the floor. And once again, I must thank you for being a great audience, and thank you most sincerely, the Apollo Group, for the invitation and collaboration and the wonderful hospitality accorded to us. Thank you, Vinakavalevu and Dhanyavad.
Thank you so much, Honorable Minister. Friends, Guyana is 14,000 kilometers away. Fiji is 12,000 kilometers away. And now we will call our Honorable Minister from 2,000 kilometers away from our neighbor Maldives, the beautiful island nation which has been rated as the world's leading destination for 5 years in a row. May I call upon Honorable Mr. Abdullah Nazim Ibrahim, Health Minister from the Republic of Maldives, second time over to address us. Thank you.
Bismillahir Rahmanir Rahim. Your Excellencies, distinguished guests, ladies and gentlemen, Assalamu alaikum and a very good afternoon to you all. First of all, I would like to thank Apollo Hospital Group for hosting this important conference on patient safety and digital health. It's a privilege to join this distinguished panel and contribute to this vital discussion. The healthcare landscape is constantly evolving, and patient safety must remain paramount. This session offers a valuable platform to exchange knowledge, forge research collaborations, and redefine patient safety standards as we explore the transformative potential of digital health, guided by the principle of first do no harm. According to a recent WHO report, unsafe medication practices and medication errors are a leading cause of injury and avoidable suffering in healthcare systems across the globe. This stark reminder highlights the global challenge of patient safety and why discussions like this are so vital. I want to focus on key aspects of patient safety, particularly its intersection with digital technologies drawing on the Maldivian experience. While digital health offers immense promise, we must ground our enthusiasm in fundamental patient safety principles, adapting them to diverse healthcare systems. The 1999 to ERI, the prevalence of medical errors and the need for systematic change. Despite technological advancement, core patient safety challenges persist. Medication errors, healthcare-associated infections, and diagnostic errors remain too frequent. Digital health can mitigate these risks, but it's not a cure-all. We must be aware of potential new errors within digital systems, especially if implementation lacks a focus on human factors. Cultivating a robust safety culture is critical. This involves more than checklists and protocols. It requires empowering healthcare professionals to report errors or near misses without fear of reprisal. It's about fostering a learning environment where we analyze events, identify root causes, and implement evidence-based changes. This requires a shift from blame to learning and continuous improvement. The Maldives strongly believes in learning from every patient safety incident and is actively working towards a comprehensive patient safety incident reporting and learning systems. Our relatively small healthcare system offers a unique opportunity to cultivate this culture. Our 2019 National Patient Safety Framework was a pivotal step promoting a collaborative and transparent approach. For a system to be truly safe, identifying our gaps is paramount. To this end, the Maldives became the first country in the South Asia region to conduct the WHO's harmonized health facility assessment. This gives us the leverage to objectively target improvement initiatives. Active patient engagement is another crucial element. Patients are active partners in their health journeys, possessing valuable insights. We must create a system that allows them to share these insights meaningfully, genuinely involving them in their care. The National Patient Safety Committee in the Maldives has 2 members representing the public as members from the patient side. In the Maldives, with its dispersed islands, engaging patients can be challenging. However, we are actively addressing this. Telemedicine and digital tools can bridge this gap, enabling remote patients to participate and provide feedback. Our primary health care initiative facilitates patient engagement at the grassroots level, ensuring all voices are heard. Human factors are also critical. Technology's effectiveness depends on its users. We must invest in training and educating to ensure healthcare professionals can use digital health tools safely and effectively. This includes technical proficiency, data interpretation, error recognition, and troubleshooting. Beyond technical skills, we must address human factors like fatigue, stress, and communication breakdowns, all of which can contribute to errors. In the Maldives, where healthcare professionals are often work long hours, addressing these factors is crucial. While we talk about patient safety, we should also remember the safety and security of the healthcare professionals themselves. We must take care of them well. Every death, every single incident, every patient concern creates a second victim, the healthcare worker. For the patient to be safe, we need our staff, our healthcare workers to be taken care of well. The Maldives faces unique challenges, as I have mentioned before, due to its geographical dispersions. Access to specialized care is limited, and inter-island transport can be challenging. Accomplishment is the establishment of a health facility in each inhabited island, resourced with at least one doctor and couple of nurses and a community health worker. Digital health, especially telemedicine, can significantly impact this. By connecting remote patients with specialists, we can improve access to timely care, enhancing patient. The Maldives Digital Health Blueprint, focusing on a federated digital health architecture and a national telemedicine initiative, is a vital step. Finally, global collaboration is essential. We must share best practices, learn from successes and setbacks, and collaborate on standardized metrics and reporting systems. This is especially important in digital health, where data can be readily exchanged. By working together, we can accelerate progress and ensure all patients have access to safe and high quality care. Before I leave this podium, I would like to once again thank for organizing such an important conference themed under very important two topics, and more importantly, inviting us to share our thoughts and allowing us to learn a lot from your experience. Thank you very much. Wassalamu alaikum.
Thank you so much, Honorable Minister, Mr. Ibrahim. Through the continent of Africa, to the beautiful country of Eswatini. Many of us knew it as the Kingdom of Swaziland. Beautiful country, well recognized for wildlife reserves, colorful festivals, and of course the rock shelter, which is 4,000 years old. May I call upon the Honorable Minister, Mr. Matsibula, who's been a seasoned civil servant before he became the Minister of Health, to address us. Your Excellency.
Program Director, colleagues, Your Excellency, the Ministers, Apollo Hospital, Development and Implementing Partners, all health practitioners, and all protocol observed. Good evening. Thank you for the opportunity to say something on challenges and opportunities in patient safety. Patient safety is a crucial value of healthcare that aims at preventing harm to patients during the provision of care. It is a fundamental pillar of Eswatini's healthcare system and is essential to achieving universal health coverage. Eswatini has made significant strides in reducing medical errors, improving healthcare quality, and ensuring patient-centered care through strong health policy, regulations, and quality assurance programs. Our ministry is committed to patient safety, hence the annual commemoration on September 17, which is also a global observance aiming at raising awareness about patient safety challenges, opportunities, while promoting best practices to prevent harm. Challenges in patient safety include the following. 1, inadequate human resource for health, which often result in human errors at service provision level. This is crucial and needs to be addressed. When health workers show signs of burnout, the patients are no longer safe. Documentation is compromised in the care process, which exposes the patient to omission of critical steps, duplication, and poor accountability. Medication errors often occur, leading to adverse health outcomes. In Eswatini, we are putting more efforts to ensure adequate staffing across all cadres and retaining them against lucrative green pastures abroad. 2, technology-driven supply chain. Maintaining appropriate stock level is essential to avoiding shortages of medicines and crucial supplies in patients' care. Manual systems in managing inventory are difficult and often fail when dealing with population level. Hence, technological systems are needed. Eswatini has experienced this challenge where patients had to buy medication out of pocket due to stockouts. We are now in the process of introducing electronic logistic solution for monitoring stock from our central medical stores to the patient, as well as from reporting on the stock levels in the health facilities, and also monitoring the consumption rate. 3, the antimicrobial resistance is another challenge. The growing burden of antimicrobial resistance, AMR, poses a serious threat to patient safety and public health. This global challenge has potential to regress the gains achieved in healthcare over the years. Our ministry has introduced programs to address AMR, and they include education and training, surveillance and data sharing, antibiotic stewardship, patient engagement. Through these efforts, Eswatini is ensuring the continued effectiveness of life-saving medications while protecting public health. Opportunities for improving patient safety following. Implementing health standards for patient safety to ensure the highest levels of safety in healthcare facilities. Eswatini has developed and implemented various health standards such as quality of care standards, pharmaceutical standards, laboratory standards, infection prevention and control guidelines. These standards are reviewed and updated periodically to align with global best practices, ensuring safety healthcare delivery across the country. And 2, strengthening patient engagement and feedback. Meaningful patient, family, and community engagement enhances healthcare quality and safety. The Ministry of Health has introduced an electronic client feedback mechanism to capture patient experiences and identify areas for improvement in service delivery. Obtaining feedback from healthcare service users, that is the customers, helps improve trust, safety, and responsiveness to healthcare. 3, research and innovation for safer healthcare. Eswatini encourages evidence-based, research-driven solutions to improve patient safety. Partnerships with research institutions and international health organizations support innovation in treatment, diagnostics, and infection control. Leveraging digital health technologies for safer prescription management, patient records, and diagnostics accuracy. In conclusion, Patient safety is a shared responsibility. Healthcare providers, patients, policymakers, and communities must work together. The Ministry of Health remains committed to strengthening policies, enforcing standards, and improving healthcare practices to make hospitals and clinics safer for all. Through continuous improvement and collaboration, Eswatini is building a resilient, high-quality healthcare system that prioritizes patient safety, dignity, and well-being. This is our commitment to our mandate. Let us all reduce the occurrence of avoidable harm and reduce impact of harm when it does occur. Thank you for your attention.
Thank you so much. On behalf of the Apollo Hospitals Group, International Health Dialogues, IPSC, THIT, we record our deep gratitude. You gave us so generously of your time, and I was just calculating, you gave us 6 days, 3 days of travel and 3 days here. So thank you so much for giving us 6 days. Thank you so much.
Thank you so much, everyone. We would like to thank Honorable Minister of External Affairs, who was here previously, His Excellencies who were there on the dais, Dr. Sangeeta, Dr. Sibyl, for the inspirational talks. We continue with the awards in a minute. We'll start with the Special Jury Awards. And for that, I would like to request Sangeeta ma'am to please give away those awards.
Special Jury Award, we will quickly start with what we had under the category of Excellence in Patient Safety. The first award goes to Tamanna Wearables for AI-based fall prediction using wearables. Do we have Tamanna Wearables? Oh, may I request Dr. Anupam Sibal to please give away the awards to the winners? We have Mr. Gaurav Loria giving away for Tamanna Wearables under the category of Excellence in Patient Safety. A big round of applause, please. Can we have the next winner, SBLD Ayurved Vishwabharati Hospital in Ayurveda Hospital, under the same category, Excellence in Patient Safety. We also have our Dr. Sangeeta ma'am joining us for giving away the awards. Can we call upon the next person, Dr. APJ Abdul Kalam Education and Welfare Society, Konara, Rajasthan, under the category of Excellence.
Ladies and gentlemen, now it's time to draw the lucky draw, and we have Dr. Sangeeta. Ma'am, may we please request you to draw a chit from there? Yes, this is the most exciting one, and we will be getting to know the winner very soon. The award goes to Divya Murthy. May I please request Divya Murthy to be here on the stage, please? The lucky draw winner. The check was taken out by Dr. Sangeeta Reddy, and we found your name there. Divya Murthy. She wins a MacBook, but it seems she's not here, so somebody else would be winning it.
Rashmi Rekha Diori.
Rashmi Rekha.
Are you there? You need to shout if you are there or run.
Rashmi
Okay, she's
Rekha.
coming.
If you're
She
coming to
gets a-
join us, please
she
wave
gets
your
iPad.
hand. Yay,
iPad.
we have Rashmi Rekha here. She wins a MacBook, ladies and gentlemen.
Wow. Deepak Charu, mobile number 9899426192.
Deepak, if you're here around, please join us here on the stage.
Deepak.
Very special person to pick up the next one. Raji, please come here. So Raji is one of the most senior members of the Apollo family. She's been with us for 38 years in chairman's office, and she will be giving out the award and picking the awardee. Here you go.
Miss Raji here, taking the next chit out of the box.
Before I request all of you to please give Gaurav and Ashish from the other side a big hand, and the entire team of organizers who made this happen. Let the movement of quality continue. Let the bonding of patient safety and the healthcare professionals, let's stay together and help heal the world. Thank you all so much for being here. God bless you and namaste.
Thank you, ma'am. Ma'am.
So the winner is yet to receive the MacBook, and she's thank you. And she is yet to receive it.
Yeah. The last one.
Ladies and gentlemen, please give a warm round of applause.
Natasha Bangari. Natasha Bangari, is she here?
Natasha, if you're here around, please join us here on the stage. You have won the lucky draw.
Yeah, ma'am. To give a MacBook. This is a MacBook, so looks like people were interested but not there now.
Vanshika Basra, you get the MacBook. Are you here? Vanshika Basra.
Maybe I'll take it home. I need one. I know. Himanshi Malik. Himanshi Malik, are you there? Himanshi Malik. Sir. Okay.
Himanshi Malik, last call. If you're here, please join us here on the stage.
Okay, the last three only. If someone
have-
gets it, great. Otherwise,
we
I'm
have
taking it.
Mr. Malik here running to grab the prize.
Okay, we'll wait for 2 minutes if she comes. Otherwise, someone else is gonna get lucky.
Now we move to other set of activity. So we played bingo throughout the last 2 days. We announced different words, and you were made to strike off those words. And
Dr.
here,
Jatin Jain. Dr. Jatin Jain for the bingo.
the bingo winner, Mr. Jatin J. Please reach here to the stage. Mr. Jatin J. Ladies and gentlemen, a warm round of applause. We have another bingo winner.
Dr. Gunjan Gera, are you here? Dr. Gunjan Gera.
Dr. Gunjan, if you're here around, please join us here on the stage. Dr. Gunjan.
All of you
here.
get smart rings.
She's here. We missed out calling two names during our last segment. The Vision 2030 winner, Arya Ajit, if you're here, please reach to the stage to collect your award. Arya Ajit, if you're here, please reach to the stage.
If you're there, raise your hand. Are you coming? Okay, she's coming.
V. Gayatri, the winner of stall activities. We missed out calling your name. If you're here around, please come here to the stage. Dr. Miss V. Gayatri, Fernandez Hospital, Hyderabad.
Gayatri. So Gayatri was previously with Apollo. Congratulations.
The winner of stall activity. We have Arya Ajit also joining the stage. Vision 2030 winner, Arya Ajit. Ladies and gentlemen, please give a big round of applause. Arya Ajit. Top scorer. Top scorer.
We have one more award that is for Supreme Scorer.
Sulakshna, have we given all the jury awards?
So, we have the third set of award here. The person winning iPad and the set of activity which we conducted. The activity was Super Scorer.
Shiv sir.
And the award goes to
Request you to please come here.
Aditi Shukla, IIHMR, Delhi. Aditi Shukla,
Good deal.
the winner of Super Scorer. If you're here around, please join us to receive your award. Congratulations, Aditi. And the award which is going to her, it really deserves a warm round of applause, ladies and gentlemen. It's an iPad.
So the grandest award of the MacBook, I don't know how fast did she ran from wherever she was, but many congratulations, sir.
Congratulations to all the winners of Play and Win.
She gets
Now
a
we
MacBook. Your name, Himanshi.
So Himanshi receives a MacBook from our team dignitaries here available.
She really deserves an applause for being so lucky.
Congratulations.
Continuing forward with the jury awards. In next category, Best Practice in Patient Safety Oriented Workforce, we do have Bellevue Clinic for Allergy and the Color of Safety. Do we have representatives from Bellevue Clinic? If we have representatives from Bellevue Clinic, please raise your hands. Or we will move forward to the next. In the same category, Best Practice in Patient Safety Oriented Workforce, we have Government Kamaraj Hospital, Chidambaram for empowering obstetric caregivers for sustainable strategies to combat burnout. A big round of applause for Government Kamaraj Hospital, Chidambaram. We are moving forward to the next category, Excellence in Digital Innovations. Excellence in Digital Innovation. The first winner is NU Hospitals for digitization of HR services. In the same category of Excellence in Digital Innovations, we have Anvika Healthcare Private Limited from pixels to prosthetics, pioneering in digital innovations in 3D printing. We request the representatives of Anvika Healthcare Private Limited to please come up to the stage. And a big round of applause to them. In the same category, Excellence in Digital Innovations, we have Fortis Memorial Research Institute for Quality Management System. Fortis Memorial Research Institute for Quality Management System. Congratulations to the team. In the last category is Incidents and Safety Events. In the category of incidents and safety events, we have Narayana Health for enhancing procedural sedation safety for procedures performed under sedation outside the operation theatre. Under the category of incidents and safety events, we have Narayana Health. Moving forward to the paper presentations, in total we had 200 papers and we have selected 7 winners out of it. We have the first winner, Dr. Suhasini Jain from Rukmani Birla Hospital, Jaipur. Rukmani Birla Hospital, Jaipur, Dr. Suhasini Jain. We have the next paper presentation winner, Mr. Rahul Anand from Government Kamaraj Hospital, Chidambaram. We have Rahul Anand from Government Hospital, Kamaraj Hospital, Chidambaram. Moving on to the next, Dr. Disha Bhatia from Akash Healthcare, Dwarka, New Delhi. May I call upon Dr. Patrick also to join Mr. Gaurav Loria to give away the gifts. Moving on to the next, it is that is Dr. Disha Bhatia. A big round of applause, please. Moving to the next, Miss Kanika Narang from Indraprastha Apollo Hospitals, Delhi. Miss Kanika Narang, Indraprastha Apollo Hospitals, Delhi.
May we request any other representative to come and collect the award, please?
And moving forward, we have Yamini Patel from Hira Nandini, a Fortis Network Hospital, Vashi, Navi Mumbai. Yamini Patel with a lot of applause from the top. Moving forward, we have Dr. Shweta Elizabeth George from SP Medifort. And we have Dr. Shweta Elizabeth George from SP Medifort. And we have last Radhika M from Apollo Main Hospitals. We have Radhika M from Apollo Main Hospitals. We are moving forward to the poster.
Thank you, Dr. Patrick. Now, may I invite Dr. Katsan to be here on the stage, please, with Mr. Gaurav Loria to give away the awards.
We are moving forward to the poster presentation winner. The first prize, one of the winner is Boba's Jaws from Apollo Hospital, Navi Mumbai for Handshake Stewardship. Poster presentation, we have 3 winners and one of them is Boba's Jaws from Apollo Hospital, Navi Mumbai. The next poster goes to Rahul Anand from the Government Kamaraj Hospital, Chidambaram for Connected Care. And Government Kamaraj Hospital, this is the 3rd prize they're winning in a row. A big round of applause for them. And one more winner from the poster presentation, we have Mr. Padma Kumar Subramaniam, Apollo Specialty Hospital, Madurai. We have Mr. Padma Kumar Subramaniam from Apollo Specialty Hospital, Madurai. We have our CEO, Mr. Nilkandan, receiving it for him. A big round of applause, please.
Now, ladies and gentlemen, it's time to announce our very, very important category of award, Safe-a-thon, the first time ever hosted activity in this particular conference, 12th IPSC. So we had total 15 participants from 15 different hospitals. Out of all those, we have selected 5 participants and they had to present it today to the jury about their presentation. They had to speak on a very important topic on effective communication and fall prevention. They had to give solutions on these 2 topics. So as per the presentation given by the members to our jury member, we have selected the 3 winners. The hospitals as the winners are to be declared here today. So starting with the second runner-up, may we invite, and I really want all the members available of this particular hospital to receive the award. Medanta Hospital, Gurugram, the second runner-up. May I please invite Dr. Sanjay Dalsania to join here with our esteemed dignitaries to give away the award. Medanta Hospitals, Gurugram, the second runner-up for Safe-a-thon activity, the first time ever hosted activity by Apollo Hospitals Group, ladies and gentlemen. And the launch was done in 12th IPSC, International Patient Safety Conference 2025. Medanta Hospitals, Gurugram, receiving the award. And Medanta Hospital receives a sum of rupees 20,000 as an award, or rather as a reward. Congratulations. Congratulations, Medanta Group. We request everybody to be careful while they are walking to the stage. With this, I announce the first runner-up for Safe-a-thon, Narayana Health, Bangalore. I request all the members who are available from Narayana Health to join here on the stage to receive the award. Narayana Health, Bangalore. And the team receives sum of 50,000 as a reward for winning the first runner-up category under Safe-a-thon. Congratulations, Narayana Health, Bangalore. They had given a solution for the topic which was allocated to them on effective communication and fall prevention. And they have been shortlisted in top 3. Congratulations, Narayana Health. Now, may I invite Ms. Rekha also to join our jury members to declare and give away the reward to the winner of Safe-a-thon. Ladies and gentlemen, any guesses? Who is the winner for Safe-a-thon? I can't hear you. Very correct. It's AIMS Delhi. May I please request people from AIMS Hospital to come and receive the award here on the stage from our esteemed dignitaries. And the winner receives 75,000 as a sum amount. AIMS Delhi. I would again want to inform everybody that out of 15 participants, 5 were shortlisted who presented today to our jury members. And out of all those 5, these are the top 3 winners for the category Safe-a-thon. The first time ever hosted activity by Apollo Group of Hospitals. And the launch was done in 12th IPSC 2025. Done, sir.
Thank you, everybody. Thank you, Dr. Carsten. Before we end the 12th edition of International Health Dialogue, I would really like to thank Apollo leadership, first of all, our chairman, Dr. Sangeeta Reddy, Dr. Preeta Reddy, Dr. Sunita Reddy, Dr. Anupam Sibbal, Dr. Madhu Shashidhar, Dr. Rohini, Dr. Usha Banerjee, for all their help and support. I would like to thank our sponsors and partners. Dozy, our title sponsor, Pfizer and Fujifilm, our platinum sponsors, 3M and BD, our gold sponsors, our silver partners, bronze partners, registration partners, delegate, exhibition, and all our other partners for all their help and support to make this event really successful. I would like to thank all our speakers, all our delegates. I would like to thank our pharmacy and procurement teams for all their support for sponsorships. Dr. Nandini and her complete team for all the help in all the collaterals, marketing, making sure that everything is up to the mark. Mr. Mayank for his support from HR perspective. I would like to definitely thank Shiv sir and Dr. Gaurav. I don't know if you are there, but without their support, this wouldn't have been possible, definitely and for sure. Would love and would definitely probably ask Satish and the complete quality team on the stage. They have tirelessly worked day and night to make this event happen. So Satish, I don't know, I can't see you where you are. Great. So Satish is on his phone as usual, but he and his team had really worked hard to make this a reality today, what we have done. The complete quality and ops teams, all the regional heads, Balaji, Dr. Sanjay, Rekha, Soma, Reshma. Okay. All the regional heads, I now lost the count of who all I announced because Satish disturbed me. But all the regional heads for all the efforts and your respective teams, the whole IPSC ambassadors, Mukram, Amrit, Vamshi, and everybody else, Bhumika, please come here. Uma Shankar, definitely not to be forgotten and missed because all that we have been very happily spending the money is all coming through Uma Shankar's efforts. So thank you, Uma Shankar, for doing that. Everybody else who have worked in the team, I really don't want to miss out anybody. So all our team, the team leads of all the teams that we have, can I please request all of you to come on the stage? And last but not the least, definitely, Yogmaya. She's like the pillar and binding everybody together. So thank you for everything that each one of you have done. Please come. I don't need to invite any one of you. Please come, everyone. The complete team that has worked towards it. Nishant, Akash, Bhaskar, Pradeep, Nirmal. Not to be forgotten, Shravan, Sagar, Narendra, Bharat. Please, everybody just come on the stage. Let's take a nice picture, like a picture that we take every year. But probably we should move these tables behind so that we can take a better picture. No, remove the tables probably.
3 cheers for the amazing team that brought this together for the 12th time. Hip hip!
Hooray!
Hip hip!
Hooray!
Hip hip!
Hooray! That's it. Thank you so much, all of you. Thank you so much. Let's take a picture.